morning, friends. Best of ASH, which has been going on from 24th of January. Today is the last day, that is day 7. This webinar is brought to you by Mumbai Hematology Group, managed by Mice Ideas. We have 4 lectures today. In the pre-lunch session, there is one lecture that is on lymphoma, best of ASH, by Dr. Ranjana Advani. She is Saul A. Rosenberg Professor of Lymphoma, Stanford Cancer Institute, Stanford, California. This is supported by Alkem. After lunch, we have 3 lectures. First is on AL amyloidosis by Dr. Ashutosh Wechalekar, who is from London, UK. This is supported by Zydus. The next lecture is on acute lymphoblastic leukemia in children and adolescents as well as young adults. That's by Dr. Ajay Vora from London, supported by Emcure. And the last lecture is on myeloma, especially Daratumumab-based therapies, which will be by Dr. María-Victoria Mateos from Spain. This is supported by Janssen. I thank Mr. Abhijit Nazare and his team from Alkem, Mr. Ashish Kumar and their team from Zydus, Mr. K.U. Soni, Dr. Arvind Vilas, and Manisha Sonavdekar and their team from Emcure, Mr. Hitesh Khandelwal and the team from Janssen, Rajesh Kalpesh and the team from Mice Ideas for managing this webinars, Executive Committee of Mumbai Hematology Group, our Chief Guest Professor Dr. Vijai Tilak from Varanasi, our guest speakers Dr. Ranjana Advani, Dr. Ashutosh Wechalekar, Dr. Ajay Vora, and Dr. María-Victoria. All our discussants were themselves eminent hematologists and hemato-oncologists, and you participants for sparing your Sunday. Our discussants today include very prominent personalities from India, with Dr. Revati Raj from Apollo Hospital, Chennai, Dr. Neeta Radhakrishnan from Postgraduate Institute of Child Health from Noida, Dr. Lalit Mohan Sharma from Mahatma Gandhi Medical College Hospital, Jaipur, Dr. Pankaj Malhotra from PGI, Chandigarh, Dr. Venkatraman Radhakrishnan from Cancer Institute, Chennai, Dr. Abhishek Kakru from Vedanta Institute, Ahmedabad, Dr. Prashant Ganesan from JIPMER, Puducherry, Lieutenant Colonel Dr. Uday Yanamandra from AFMC, Pune, Dr. Nirmala Roy Malik from Tata Memorial Hospital, Mumbai, Dr. Chetan Dhamane from Tata Memorial Hospital, Mumbai, Dr. Sunit Lokwani from Shelby Hospital, Jabalpur, Dr. Ruchira Misra from SRCC Hospital, Mumbai, Dr. Kunga from Vardhaman Medical College, Delhi, Dr. Darshana Rane from Nanavati Hospital, Mumbai, Dr. Rajani Priya Yedla from Mahatma Gandhi Cancer Hospital, Visakhapatnam. It's my pleasure to introduce the chief guest of the day, and I'm privileged to have the participation of Professor Vijai Tilak to inaugurate today's webinar. He's Head Department of Pathology, in charge Division of Hematology, in charge UGC Advanced Immunodiagnostic Training and Research Center, Institute of Medical Sciences, BHU, Varanasi. Thank you so much, and I request Professor Vijai Tilak to say a few words and inaugurate today's webinar.
A very good morning to all of you. It is a proud privilege and an honor to be the chief guest of today's webinar hosted by the Mumbai Hematology Group. And indeed, I'm honored to be invited by Professor B Agarwal sir to be the chief guest. And I'm also humbled to share the dais with the stalwarts in hematology. Today, I'm going to speak from my heart. And I like to interact first with B Agarwal sir. मैं सबसे पहले B Agarwal sir से रूबरू होना चाहूँगा. Sir, I have 2 philosophies that I've been practicing on a day-to-day basis. The first one is create like a god, command like a king, but work like a slave. And my second philosophy of life is when the vision is 1 year, cultivate flowers. When the vision is 10 years, cultivate trees. But when the vision is eternity, cultivate people, good people, committed people, trustworthy people, passionate people, people who work for a cause and not for applause, people who are willing to work not only from 9 to 5, but also from 5 to 9. And these are the people who now constitute the Varanasi Hematology Group. Now I turn my attention to my target audience, who are young budding hematologists and hematopathologists, who may not be that fortunate to be one of the institutes, to be working in one of the institutes of excellence in hematology in India. And if that is the case, my friendly advice to them would be that they should go to one of these institutions, work there for some time, even if it is unpaid, to hone their skills, talent, knowledge, since what you learn at the beginning of your career is much more important than what you learn, what you earn. Failure is part and parcel of life. Bill Gates has said that life is often unfair. Accept it. So how to deal with this failure, with this disappointment, with this unfairness? My advice to my friends would be, whenever you get a setback, do not sit back. Just step back to bounce back. I've been greatly inspired by the saying of Sir Martin Luther King, who said that I like to fly. But if I cannot fly, I like to run. If I cannot run, I like to walk. And even if I cannot walk, I like to crawl, but I'll keep moving forward. This is this policy, this philosophy that has paid me rich dividends in my life. Professor Mamin Chendi, who is a living legend in hematology in India, said that if you want to do something, you often cannot do it alone. You need a team effort. Same emotions have been reflected by Michael Jordan, who said that talent wins games, but teamwork wins championship. Friends, form a trustworthy, passionate, multidisciplinary team whose members have small egos but think big. Punctuality and discipline are vital traits for being successful. And if you want to learn punctuality, the best person in hematology to me is Professor B Agarwal, who starts all his academic sessions in time. It has been said that if you want to know the value of a second, ask a runner. If you want to know the value of a day, ask a prisoner. If you want to know the value of a month, ask a pregnant woman. And if you want to know the value of life, ask a dying person. So friends, that is the value of time and life. Respect time. And if you want to learn self-discipline, I think the best person is Professor Tathagat Chatterjee, sir, who is senior to me, and still he's so fit, healthy, and looks so young. I finally will like to conclude by saying, सोच को बदलो, सितारे बदल जाएंगे. नजर को बदलो, नजारे बदल जाएंगे. कश्तियां बदलने की जरूरत नहीं है. दिशाओं को बदलो, किनारे बदल जाएंगे. Thank you very much, sir.
Thank you, Professor Vijai Tilak. Very well said. Thank you for sparing your valuable time, coming this morning, addressing our group, and giving such wonderful speech, and a very, very well-crafted speech with a lot of messages. Indeed grateful to you.
Thank you, sir.
We'll move on with the scientific session now, and I'll once again share my screen to introduce our first speaker. So, as I mentioned in the morning, the first lecture is on lymphoma, West of Ash. The speaker is well known to you. She has been our faculty by coming to India, as well as through webinars during last 2 years. I think a large amount of learning of lymphoma in this country by hematologist, medical oncologist, and hemato-oncologist is by listening to her and reading her work. She is the Saul Rosenberg Professor of Lymphoma. She serves as the physician leader of the Lymphoma Clinical Care Program. She specializes in research and treatment of Hodgkin, non-Hodgkin lymphomas. She has developed a broad collaborative investigative program encompassing clinical trials and translational correlates. She's the principal investigator of numerous clinical trials. She currently serves on the NCCN Non-Hodgkin Guideline Panel, Lymphoma Core Committee of the ECOG, and the NCI Lymphoma Steering Committee. This part of the webinar is supported by Alkem. I'll stop here and request Dr. Ranjana Advani to start her talk. Ma'am, there is no time limit for your talk. We have nothing else in the pre-lunch session. Your talk and the question answer session till you get that.
So thank you for your kind introduction. I will go ahead and share my screen. So I assume you can see my screen?
Yes.
Okay. So this is going to be a tour de force for what I thought was clinically relevant in lymphoma at the ASH meeting. And these meetings are always a lot of work to prepare for, but it serves you well in the long run because it forces you to read about 1,000 abstracts and then try to sort it out in your head. And if you sort it out in your head, then you can try to explain it a little better. So these are my disclosures. So I'm going to start out with diffuse large B-cell lymphoma. So, there have been lots and lots of attempts to improve of R-CHOP. It's been giving it more often, doing upfront transplant, giving maintenance Rituxan, adding new agents, and every trial so far has failed. Also trials based on interim PET, like the Memorial trial or one of the ECOG trials, where if patients had interim PET positive disease and they were changed to a salvage regimen like rice, even that there was no advantage. And there are some known factors which are associated with inferior outcomes, such as older age, over 70, of course, interim PET positive disease, high IPI, and then subsets within the cell of origin. And R-CHOP, because of that, has basically remained the standard of care for almost all patients with large cell lymphoma. So what are some of the reasons for these potentially equivalent outcomes? One is that the trials enrolled all comers. They were not stratified by germinal center, non-germinal center, and they inadvertently included double-hit lymphomas. And they were also not powered to detect differences based on these subgroups. You can also argue that the control arm did really well. And one of the reasons the control arms do very well in these trials is that the enrollment bias is that the sickest patients don't go on these trials because you need to treat them right away. You don't have time to wait 20 days to get the path centrally reviewed, or they want the pathology block to be sent so that molecular cell of origin can be determined. You just don't have that. So this was actually looked at, and it's quite well established that patients who have to be treated within a week, that means these are our sickest symptomatic patients, do much worse than patients who can wait for about a month to start treatment, who tend to be not as sick. And that's one of the reasons why all these trials have been negative. The other reason which we're learning is that, thinking of large cell lymphoma as germinal center, non-germinal center, based on the last WHO classification, was probably a little too naive, because we've learned now that within the germinal center subtypes, there are more clusters, and within the ABC subtype, there are different clusters, which also have different outcomes. So not all are good, and not all ABC are bad. And that's why you have differences between these trials too. The other, at ASH this year, there was a presentation which looked at the impact of trial eligibility criteria on outcomes. So this was an interesting paper which was presented. They looked at the remodel trial, the Goya trial, the Polarix, which I'll go into detail, and the HOVON trial. And in all these trials, the patients and they looked at the retrospective database, and they looked at all patients in the Nordic lymphoma database who would have been eligible to go on that trial based for the frontline therapy with R-CHOP. And they looked at the eligibility criteria for all these trials. And main reason for exclusion of trials were approximately about 20% of patients who got R-CHOP would not have been eligible for one of these trials, mainly because of bilirubin being elevated or a creatinine being abnormal or a performance status. And then if you look at those patients who were not eligible for clinical trials, they had an inferior outcome. Again, supporting that our sickest patients, or those who don't meet eligibility criteria, do poorly because what goes into clinical trials is the creme de la creme. And that's why it's been hard to show outcome differences with, almost 2 decades of trying to improve upon R-CHOP. So in conclusion of that presentation, there was that trial ineligible patients have worse survival, even when you adjust age and disease category. And the exclusion was mainly due to kidney and liver dysfunction. So about 20% would have been excluded. And again, the baseline performance status and platelet counts also had a big impact on the differences in overall survival. So that brings me to one of the late-breaking abstracts, which was presented, the POLARIX study, which looked at polatuzumab combined with R-CHP versus standard R-CHOP in patients with untreated large cell lymphoma. So polatuzumab is an antibody drug conjugate. It binds 79B, which is ubiquitously expressed on large cell lymphoma cells. And like brentuximab, it binds to CD79, it's internalized, and then you get microtubular disruption and MMAE is released and apoptosis. And polatuzumab and Rituxan has been studied. Polatuzumab has been studied in combination with R-CHOP or Gazyva CHP. You don't give vincristine when you give polatuzumab because it's a tubulin toxin. And it's been shown to demonstrate activity in first-line DLBCL. And you can see that at least in the preliminary experience in the phase 1 study, the progression-free survival was about 80%. So that was the premise for this phase 3 trial. So this included patients with large cell lymphoma with IPI of 2 to 5. They had to have a good performance status. And they were stratified by the IPI 2 versus 3 to 5, bulky disease, and based on which part of the world you were treated in. And it was standard R-CHOP versus Pola R-CHP and for 6 cycles. And another 2 doses of Rituxan were given in the end because some European centers do that anyway. And this was so that there was uniformity across the world. The arms were very well balanced for stage, age, bulk, IPI. The median age was 65. About 40% had double expressor phenotype, and they all 80% had a good performance status, and about half the patients had the GCB subtype. The therapy was well tolerated. You can look at the adverse events. One side is R-CHOP in blue and the polar R-CHP on the green. And you can see that the rates of neutropenia are pretty similar. The rates of peripheral neuropathy are pretty similar. There's really not much difference in the 2 arms, suggesting that this did not add more damage than just R-CHOP. There was slightly more febrile neutropenia, but that did not lead to more infections. So if you look now at the progression-free survival, you can see that the progression-free survival was in favor of the polar R-CHP by about 7%. And there was absolutely no difference in overall survival. And this is at approximately the median follow-up of about 18 months or so. If you look at the forest plot of who benefits from these therapies, you can see that while forest plots are not used to make treatment decisions, it gives us a hint as to what subtypes do better. And you can see that males tend to do better, people with a better performance status, people with the highest IPI, 3 to 5, who do not have bulky disease do better. And then you can see over here that patients who have the ABC, so the non-GCB subtypes do better compared to the GCB subtype. And the ones with double expression seem to do quite well. And we don't know much about the double hitters yet, but the numbers then become really small. So again, to summarize there, the PFS is seen particularly in the IPI 3 to 5, non-bulky disease, older male patients and the ABC subtype, and the toxicity is similar in both arms with no overall survival benefit. I don't know why my screen is frozen. I think I'm going to stop sharing and share again because it looks like it has frozen. Just give me a second. So the next paper I want to discuss is actually a randomized trial looking now specifically at double hit or double expressor lymphoma. So we know that these patients do pretty poorly with R-CHOP. And the choice of therapy in most centers has been dose-adjusted EPOCH. So this was an effort by the Alliance group to look at R-chemo or venetoclax R-chemo. And your chemo choice could have been R-CHOP or dose-adjusted EPOCH, but in most patients, dose-adjusted EPOCH was used if it was double hit. Venetoclax, why venetoclax? Because what is a double hit? So a double hit is you have MYC rearranged as well as BCL2 rearranged. And BCL2 is targeted by venetoclax. So it was a logical choice to choose that as a novel agent backbone to combine with our chemotherapy. And if you look at dose-adjusted EPOCH, which was the backbone used for double hit, adding venetoclax led to a lot of toxicity. So compared to regular dose-adjusted EPOCH, the dose-adjusted EPOCH R had much more toxicity, leading to a lot of treatment delays. And if you look at the progression-free survival and the overall survival, it was in favor of just regular dose-adjusted EPOCH. So the trial was actually closed early for the lack of, because it was too toxic. So while scientifically it made sense, I think at a practical level, the toxicity was too much. The same story with ibrutinib R-CHOP. So the Phoenix trial, if you recall, was a negative trial. But then they looked at subsets of younger patients who seemed to do better because in older patients, when they added ibrutinib to R-CHOP, those patients had a lot of toxicity and you couldn't get the R-CHOP in. So what Lou Stout and his group did then is look at the group, and that trial took only the ABC subtype. So in that, they looked at the genetic subtypes. I think right from the beginning, I showed you that not all ABC are bad, and there are some subsets within the ABC which are actually pretty good. So in that, they did these further subtypes, the MCD and the N1 type. And those are the mutations which actually promote chronic active BCR signaling. And if you gave ibrutinib R-CHOP to that group of patients within the non-GCB, that group had 100% survival. So that sort of rekindled the interest in continuing to try using a BTK inhibitor in our large cell lymphoma in frontline therapy. So this was a NCI trial looking at a window study where you use acalabrutinib, which is a new generation BTK inhibitor, prior to frontline therapy in untreated aggressive lymphoma. So this took untreated all comers. They gave a window of acalabrutinib alone for 2 weeks, and they actually looked at circulating tumor DNA, looked at imaging by CT scan. And if patients had, and they were stratified by whether they had a 25% reduction, less than that, or more than equal to that. And they were given, if they had less than a 25% reduction, they were just given the dose-adjusted EPOCH or R-CHOP, basically no exposure to further acalabrutinib. However, if they'd responded by more than 25% reduction, acalabrutinib was added to the dose-adjusted EPOCH. It's becoming a problem again. I'm so sorry. I have no idea what is happening here. We're going to try to do it without going to the full screen to see if this stops us from these interruptions. So you can look at the eligibility criteria. This took all molecular subtypes, and the endpoints were the overall response rate, event-free survival, and overall survival. And you can see that just in the acalabrutinib window, which is the 2 week, 2 weeks of acalabrutinib, and then you give them, do an imaging study, you already start seeing responses. And that correlated with the level of circulating tumor DNA as well, where in patients with more than 25% reduction on the CT scan, they also had it correlated with a log change in the circulating tumor DNA. And this translated to an excellent event-free survival and overall survival. So this is pretty early, but it sort of sets the opportunity of trying these novel agents in a much more molecularly targeted fashion in very specific subgroups, because maybe we were just giving it very broadly before. Now, moving on to CAR-T, there are 3 approved agents in the US for large cell lymphoma after 2 lines of therapy. And one is Axi-cel, Tiso-cel, and Liso-cel. And these are approved. So what we saw, there was a lot of activity on CAR-T at ASH this year. One, we heard the update of the ZUMA-12, which what it did was it took high-risk patients with large cell lymphoma, and high risk was defined as high-grade lymphoma with MYC and BCL2 rearrangement or a triple hit. And they had to have a large B-cell lymphoma with the IPI greater than 3. Those patients, if they met the criteria, got started with a Rituxan-containing regimen, R-CHOP or RDHAP, and they had dynamic assessment. That means they had a PET scan after 2 cycles. And if they had a Deauville score of 4 to 5 on interim PET, basically means refractory disease, and they had good performance status, they were enrolled onto this trial, and then they were given CAR-T therapy with Axi-cel, because that's a group which traditionally has not done well with salvage or transplant. And if you look at the updated results, they're really excellent. And in this high-risk group, which was positive after the first 2 cycles of our chemotherapy, the overall response rate is almost 90% with a 78% complete remission rate. And you can see at a median follow-up of almost now 15 months that the duration of response is about 16 months. The median event-free survival has not been reached. The median progression-free survival has not been reached. And the median overall survival has not been reached either. So this ZUMA-12 was the first study evaluating CAR-T cell as part of the first-line therapy in high-risk DLBCL, which was defined in a dynamic way. The rate of rapid and high durable responses, the median follow-up is about 16 months. There's no new safety signals, and higher frequency of the product actually suggests that there's more T-cell fitness if you give CAR-T earlier on. So not at the third relapse, but actually right in the beginning if patients are not doing very well with therapy. Now, how do patients do when they relapse with large cell lymphoma? So there was a presentation, a poster by the Vancouver group, which looked at progression-free survival in transplant-eligible patients according to the timing of relapse. So what we can see over here is that if you relapse within a year, or honestly, even within 2 years, the progression-free survival is pretty pathetic. It's like 25 or even 10% or so. However, if you relapse after 2 years, then the progression-free survival after transplant is 50%, which is not bad. So the really poorly acting group is this group over here, which relapses early within a year. So what we saw at ASH this year were 3 randomized trials looking at 3 CAR-T, ZUMA-7, which looked at Axi-cel, Belinda, which looked at Tiso-cel, and the Transform trial looking at Liso-cel, asking the question, at first salvage in large cell, will CAR-T replace auto transplant? So they took patients who were at high risk, who were refractory to first line, but they had to have relapsed within 1 year, because that's the group which does really poorly. And they were randomized to CAR-T or salvage. So I'll go into details of those, but there were a few differences in study design. So this was the ZUMA-7. So it was relapsed within 1 year. And over here, for bridging therapy, they were only allowed steroids. So no chemotherapy. They were randomized, and then they got, investigator-based platinum therapy. And they were assessed at the end of the cycle 2 or cycle 3. And if for Axi-cel, they went straight on to get the CAR-T arm, get CAR-T. If they were transplant, they were assessed. And if they had CR or PR, they went to transplant. If they didn't have a CR or PR, they were taken off study. And the formal assessment, which was the main endpoint, was event-free survival. It was done on day 100. Okay, and there was no protocol specified crossover allowed. In the Transform study, same study group, less than 1 year of relapse, but here bridging therapy was allowed. So you could give chemotherapy before the patients actually got, while waiting for the CAR product to be made, you could give them bridging therapy. And the other difference is that a crossover was allowed. So for patients who didn't respond to the standard of care by 9 weeks, you were allowed to cross over to the Liso-cel arm. So that's another difference. Again, PFS was the event-free survival was an endpoint, but that was assessed the first assessment was at 9 weeks. And the last trial, the Belinda trial, again, same eligibility criteria. Again, bridging therapy was allowed. And over here for the transplant arm, if they achieved CR or PR, they were taken to transplant. However, if they had stable disease or progressive disease, they were allowed to cross over, and that was also counted as an event. So there are some differences which are important to understand why the trial results were not all concordant. The one other thing is, if you look at the patient population, is very similar. Okay, the primary refractory was slightly less in Belinda, but about still pretty high. If you look at the percentage of patients who actually got CAR-T versus standard of care, across all three trials, over 90% actually went to CAR-T. But look at the numbers who got just standard of care, 36%, 47%, 33%. So there was a lot more progressive disease or failure to achieve a CR or a PR with a salvage therapy. So they didn't get to transplant. Also, the median time to infusion of the CAR-T. So in ZUMA-7 was about a month. It's not been reported for the lysocell. But in Belinda, in this trial, it was over a month, almost, it was like close to 8-7 weeks, so really long. Now, bridging therapy, 36% could get steroids. However, chemotherapy was allowed in the other two, and in the Transform trial, 63% got chemotherapy as bridging before they went to CAR-T. And over here in Belinda, 83% got bridging before they got CAR-T. So that means there was a lot of delay before they actually got the CAR-T product. And I think it's important to know that. The crossover, while this didn't allow it, the Axicell, which didn't allow it, half the patients did cross over. Similarly, on the others, it was allowed and about half crossed over. And as I showed you before, the event-free survival definition also varied between the three trials. The first one was blinded at day 150. The second one also included failure to achieve a CR or PR as an event, and that was at 9 to 12 weeks. And the third one was at 12 weeks. So within all those differences, the ZUMA-7 and the Transform trial were positive trials in favor of the CAR-T arm compared to the standard of care arm. The overall response rate was higher, the CR rate was higher, the median event-free survival was much higher, 8 months, 2 months, 10 months, 2.3 months. The median progression-free survival was higher, and the median overall survival has not been reached in the Axicell arm compared to the standard of care arm. In Belinda, which used Tisacell, that was a negative trial. There was no difference between the CAR-T or standard of care. And one of the reasons is that a lot more patients in Belinda got salvage chemotherapy before they got Tisacell because it took so long to get them the product, almost. And that's one of the reasons why we think that this trial did not do as well as the other two. This is what the results look like in Kaplan-Meier. You can see that the first two trials is a good, nice progression-free survival advantage, whereas in Belinda, there's not. The arms completely overlap, and the toxicity is very similar to what you expect, with Axicell having the most immune-related toxicity as well as cytokine release compared to the other two products. So primary refractory and early relapsing patients with aggressive B-cell lymphoma have poor outcomes with salvage and transplant. CAR-T in second line appears to improve the event-free survival with acceptable toxicity. It will likely become standard of care, but at present, I don't think we should extrapolate this beyond the study populations. So, someone's relapsed after 1 year, that's not this population. It's only for this highly selected group. And it may not be appropriate for all patients, particularly those with rapidly progressive disease, because those are the ones who don't do well even with CAR-T. And of course, we have to take into effect the cost effectiveness. So there were other presentations looking at predictors of response in CAR-T. So one was the cumulative illness rating score. So if you have, specifically if you have respiratory or hepatic insufficiency, with CAR-T, the outcomes are particularly poor. And the other thing is on PET parameters. So not just an SUV at baseline or an enteropet, but if you look at metabolic tumor volume at the time of relapse or just before CAR-T or tumor lymphoma glycolysis, if those are high, those are the patients who tend not to do well with CAR-T. So maybe with these very expensive but very effective therapies, we need to get smarter about how to choose which patient where it's going to be worth it. The next part of large cell lymphoma was talking about CNS prophylaxis. So we know that CNS relapse can occur in about 5% of the patients, and in really high risk subgroups defined as the CNS IPI, it's 10 to 30%. and the median time is about 6 to 8 months. And that's the rationale to have given prophylaxis, and most people try to do it early. And high-dose methotrexate is one of the most commonly used ones when you're using R-CHOP. And of course, there are various ways to do it. So some do it, early on, like with every cycle of R-CHOP. Some do it at the end, and one really doesn't know what the best way is. So this was a retrospective international study from 47 centers worldwide, and they looked at to see whether there was any difference in outcomes, whether you did it at intercalated, that means with every cycle of R-CHOP, or whether you did it at the end of therapy. Now, there are some differences between the two groups. I don't kind of want to belabor on those because those are not the point of this presentation. But I think you can see over here that whether you did it in between or you did it at the end, the percentage of patients who actually landed up with CNS relapse is no different. Even if patients had a CR, it was no different, and it did not make any difference in overall survival. In fact, by intercalating it, by trying to do it on day 10 or day 15, all that it did is actually lead to treatment delays in about 20% of the patients or so. And that led to inferior progression-free survival in those patients where it led to treatment delays of more than a week. So conclusion of that was that end of therapy high-dose methotrexate did not increase the risk of CNS relapse compared to early integration, and intercalated increased about 20% delay, increased the risk of R-CHOP delay, which then led to a poorer outcome. So if you're going to use high-dose methotrexate, I think you can defer as prophylaxis. Remember, this is not for patients who have involvement. This is prophylaxis for high-risk patients. You can defer it till you finish with your R-CHOP, and then you can give 4 doses every 2 weeks apart. And if you're doing it intercalated, then you have to be really careful, especially in older patients, because otherwise it's going to lead to delay. But I think the bigger question is, does it make a damn difference at all, whether you use high-dose methotrexate or you don't use it? So this was another study presented where they took patients with large cell lymphoma with a high CNS IPI, or they took the traditional high-risk patients who had either high-grade B-cell lymphoma with a double hit, or they had primary breast or testicular lymphoma. And they were given, our chemotherapy, which was with curative intent. And they excluded patients who had known CNS involvement by lymphoma, or they had transformed nodular LP or PTLD. And those patients, they had two groups. One, this was again a retrospective study, patients who were given the high-dose methotrexate and then no high-dose methotrexate. And they looked at the outcomes and even looked at the outcomes in patients who achieved a CR. And if you see over here, the cumulative incidence of CNS relapse for all patients was absolutely, there was no difference at all. It was 9.2 versus 8.1. So whether you did high-dose methotrexate or not, whether you achieved a CR or not, made no difference. So this, in this largest study to date, it really hasn't shown any difference. So honestly, I think it begs the question, why are we doing it? Unfortunately, there's no prospective trial which tells us definitively. So a lot of us do it out of habit. We have actually stopped doing this. We only do it for testicular, and we do it for the really, like, not the intermediate CNS IPI, but just like 5 and 6 for the really high IPI, because we don't know what difference it's going to make. And we really hope that, better methods of determining risk, which was actually presented last year at ASH, like at the circulating tumor DNA in the CSF, might be more predictive. So now another class of drugs is the bispecific antibodies, which are really emerging as a force by themselves. And there are 4 which are, none of these are approved, but there are 4 in clinical trials: mosunetuzumab, glofitamab, odronextamab, epcoritamab. And they all basically have CD20, which then also has CD3. So you sort of bind to the CD20 moiety as well as CD3 on T cell, and you bring it closer so you have better attack of the lymphoma cell. And there are some differences, and glofitamab can be given subcutaneously. Now, there's a lot of data with all these 3 compounds, and I'm just giving you examples of MOSI, Glofi, and epcoritamab. In the phase 1 data, they showed, these are just example waterfall plots showing that they can respond. You see responses in indolent as well as aggressive lymphoma after 3 prior lines of therapy. So really active drugs. So what we heard at ASH this year were results of glofitamab in combination with polatuzumab. So now polatuzumab has made it to the front line with the Polaric. So now they're looking at this. It's also approved in the relapse setting with bendamustine rituximab. So this is now looking at glofitamab with pola in relapsed large cell lymphoma. And the other trial looked at mosunetuzumab plus POLA. So both bispecific antibodies combined with a 79B antibody drug conjugate. And summarizing that data, you can see that some of them had about, in the MOSI trial, half of them had prior CAR-T. The overall response rate in GLOFI-POLA was 80% with 50% CR rate. The median PFS had not been reached, and there was very little cytokine release. So unlike CAR-T, there's really no neurological toxicity, and the incidence of cytokine release syndrome is also much less. Very similar results with mosunetuzumab and POLA, including in patients who failed CAR-T. So summarizing large cell lymphoma, just briefly, just to kind of put it all in perspective, was a lot of data. POLA-R-CHP improves the PFS in IPI 3 to 5, non-bulky, non-GCB patients. There's no overall survival advantage. And I think this may be appropriate in specific situations, like if you have an older male patient with a high IPI non-GCB, I think this is the 7% advantage may be worth it. High-risk non-Hodgkin's lymphoma, I think the quest for better therapies is ongoing. Adding venetoclax certainly was not a very good idea. And I think the results of ZUMA-12 with interim PET dynamic assessment are very provocative. And with longer follow-up, if that data holds up, it will change the standard of care. The role of CNS prophylaxis has been challenged. I think there's no difference between IV or IT. This I had shown you last year at ASH, and this year at ASH, I showed you there's no difference whether you give high-dose methotrexate or you don't give it, or when you give it. And for relapse or refractory disease, if you relapse within 1 year, I think the standard of care is likely going to change to CAR-T instead of standard salvage. However, if you relapse more than 1 year, I think standard salvage still has a role. And I think bispecific antibodies alone or in combination with polatuzumab are very encouraging. They're certainly going to give CAR-T the run for the money because they're much easier to use and they're off the shelf. But none of them are approved. More trials coming, so stay tuned. So moving on to peripheral T-cell lymphoma. So PTCL is a very heterogeneous disease. So 7% of all lymphomas, there are 19 entities, varied clinical presentations, median age of diagnosis is 65 years, and treatment strategies have largely been derived from large aggressive B-cell lymphoma. And for non-ALCL subtypes, the 5-year progression-free survival is about 20 to 40%, and 5-year overall survival 25 to 50. And with that, the advent of brentuximab and the Echelon-1 trial, Echelon-2, which looked at brentuximab in combination with a CHP, no vincristine, or CHP, it's the preferred regimen, certainly for ALCL, and it can be used for other lymphomas too, though 75% of the patients in the Echelon-2 had ALCL. So for that, it clearly is the preferred regimen, but I think the jury is out there for the other subtypes. So if you look at the 5-year update of the Echelon-2 trial, yes, the differences of progression-free survival hold for the BV chip arm, this is the forest plot, and you can see that the maximum impact is in the ALCL histology and not so much in the other histologies. And that actually was presented now in a different form where they looked at subset analysis at ASH this year, again confirming that the benefit is not there in the other subgroups. It's mainly in ALCL, where you see it across the IPI, and you see the progression-free survival and ALCL advantage as well, overall survival. So this shows you that the curves overlap for the other subtypes, PTCL, NOS, and AITL, for progression-free survival as well as overall survival. But where you see the differences are with ALCL. So there's a lot of room for improvement for PTCL because yes, well, we have a good therapy for ALCL. That's not the case for PTCL, NOS, or AITL or the other subtypes. So of course, we have other drugs which are approved for relapse refractory PTCL, such as pralatrexate, and then the HDAC inhibitors, romidepsin and belinostat. And there's been an attempt to use these other agents in combination with CHOP to see if you can improve the outcomes. So what was recently published was looking at romidepsin plus CHOP compared to CHOP. So romidepsin is an HDAC inhibitor, and that trial was completely negative, and this was recently published. So is that the end of the romidepsin story? Well, what about adding it to CHOEP? So, as a chemotherapy backbone, some retrospective data suggests that CHOEP is a little better than CHOP, especially if you have a younger patient. So the Italian group looked at adding romidepsin to CHOEP, and their aim was, can we show a 15% increase in the 18-month progression-free survival if you add romidepsin to CHOEP and then take patients to transplant. So 55% from previous trials to 70%. So with CHOEP and transplant, you can expect 55%. So the goal is if you add romidepsin to CHOEP plus transplant, can you go from 55 to 70? And the study failed to meet that endpoint. As you can see that at a median follow-up of 26 months, that it was only 59%. So it didn't hit that 70% goal, which they had hoped to. So enrollment was stopped. And there were deaths also because of it was more toxic. So you can't add romidepsin for sure. So what about adding brentuximab to CHOEP? So this is the CHOEP, but because it's brentuximab, you have to drop the vincristine. So it's CHEPBV. And this was presented by Alex Herrera from City of Hope. So this was a standard design where you get the CHEP CHEP doses were pretty standard. Etoposide was given for 3 days, as is usually the case, and you gave patients 6 cycles. If they achieved a CR/PR, you took them to transplant, and then there was consolidation with brentuximab. And these are the results in about 48 patients, and you can see that the subtypes were a variety of subtypes. Some of them, there was ALCL in it also. But if you looked at the CD30 expression, about 2/3 had greater than 10%, about a third of them had less than 10%. And remember, the less than 10% would not have been eligible for echelon 2 because that was only for patients with more than 10% expression. Most of them had advanced stage, had good performance status. And you can see that they were given standard of care. And you can look at the progression-free survival. At 18 months is 61% with an overall survival of 89%. And these are the common side effects during induction and then during the consolidation. So if you look at the PFS, if you look at the ALCL, it's not surprising ALCL does better than non-ALCL. And that is because ALCL universally expresses CD30. But if you look at the other subtypes, there's actually the T follicular helper seems to have done well with no difference with PTCL, NOS, or AITL. But if you look at the progression-free survival by CD30 expression, less than 10% or more than 10%, there's absolutely no. And if you look at the landmark analysis, the patients who actually got to transplant after getting the chemotherapy did much better than patients who did not get to transplant. So the conclusion was that CHEP-BV was very tolerable, led to a high CR rate. There was similar febrile neutropenia. 74% received BV consolidation, but most did not complete it because of neuropathy. And doing that approach and consolidation was effective. And in ALCL is better PFS than non-ALCL, but it's certainly a regimen which is some activity and merits further study. The other frontline abstract which was presented was looking at using the advantage of epigenetic modulation with oral acitidine. So oral acitidine is a drug which is an epigenetic modifier and inhibits DNA methyltransferase. So the hypothesis was, can we chemosensitize using the epigenetic priming with CC4486, which is oral acitidine in combination with CHOP, and can that lead to increased better outcomes? And the reason to do that is because we know that in AITL, especially the T follicular helper, there are a lot of epigenetic functions which are mutated because you get TET2, DNM3A, IDH2, and ROA mutations. So this was a study design. It was pretty straightforward. There were 21 patients treated, and you can see that the overall response rate was really high, 75%, and much higher in the T follicular helper subtype, which is particularly prone to epigenetic dysregulation, and a high CR rate of 88%. And if you look at the median follow-up of 21 months, the overall survival is 68% overall. But if you look at it in the T follicular helper subtype, it's 75%. So certainly very provocative. So then the study also looked at the mutations. So patients with TET2 mutations actually did very well. But if you have the DNMT3A mutations, you don't do so well. So this combination is now being tested in the US intergroup as a frontline arm in patients with untreated non-ALCL, CD30 negative PTCL, where they'll get this or they'll get duvelisib or CHOP and CHOA. So summarizing T-cell lymphoma, there's not a single paradigm. understanding the specific subtypes are going to lead into more individualized therapy. So I think, as you've seen, like for ALCL, combining CD30 is a slam dunk. It's not the case for the other subtypes. So we really have to treat subtypes by therapeutic vulnerabilities. And if to understand where standard treatments work and build upon them. So for example, for frontline, you have to build upon CHOP or BV-CHIP or CHOEP and transplant, because not one of these by itself is enough. I think all of these put together and add a novel agent, but choosing the right patient. And of course, we have to continue identifying new targets, but because none of these are perfect. And the term PTCL-NOS will continue to shrink as a clinically meaningful entity as we recognize more and more subtypes. So moving on to indolent lymphomas. In indolent lymphoma, a long time ago in ECOG, we did this trial where we took low tumor burden. So these are patients who you can normally do watch and wait, but they don't want to do watch and wait, and just gave Rituxan 4 doses. And then they were randomized to Rituxan maintenance or retreatment at progression. And at that point, the original conclusions were, well, yes, Rituxan retreatment was actually as effective as giving maintenance. And even though, yes, maintenance delayed the time to cytotoxic therapy, both strategies appear to delay time to chemotherapy. But you use 4 times more drug with the maintenance strategy. It increased the cost without any benefit of quality of life. And there was no impact on transformation. So it was recommended that if you're using Rituxan, just do 4 doses. There's no need for maintenance. So what was presented this year was the long-term 10-year follow-up. And at 10 years, the results pretty much are similar. It does delay onset to first cytotoxic therapy. The duration of response is slightly longer if you do Rituxan maintenance, but there is no overall survival advantage even at 10 years, 83%, 84%. There's no difference in the risk of transformation, and there's no risk of no increased change in second cancer. So, patients fear that if I don't treat it, I'll transform. That's not true. That's held on study after study. So their conclusions are the same. There's no overall survival benefit. So that the 4 times less drug was utilized. So a Rituxan retreatment strategy remains the recommendation. So the next abstract, which was updated, was from the Italian study, looking at the role of maintenance after R-bendamustine or R-CHOP. Now, after R-CHOP, based on the PRIMA trial, we know that if you give Rituxan maintenance, there at 10 years also there is a progression-free survival advantage, but there's no overall survival advantage even after R-CHOP. And we really haven't looked at that with R-bendamustine. The STILL trial looked at it, and again, it wasn't really designed that way, but they looked at 2 versus 4 years, and there was no difference. But this trial was a little different in that they used sort of a PET scan and they looked at MRD to determine whether patients should get maintenance or not. So in the standard arm, everybody got it. In the experimental arm, if they were in a complete metabolic response by PET after 6 cycles of R-CHOP or with bendamustine, MRD was done. If they were negative, they were observed. If they were positive, if they were negative and they were observed, and then if they were positive, they were given Rituxan maintenance. And this trial then focused on looking at the role of maintenance versus no maintenance. And you can look over here that we know about R-CHOP even based from the PRIMA trial, that the progression-free survival was in favor of R-CHOP. And now we have the same story with bendamustine as well, that you can give RB, and if you give Rituxan maintenance after bendamustine, the progression-free survival is better, but there is absolutely no difference in overall survival, and there is slightly higher rate of second malignancy after bendamustine. So this is not a good practice if you've used bendamustine to give any maintenance Rituxan. It's also very immunosuppressive, so especially we're not through the pandemic as yet, it's best not to give anybody any maintenance therapy, because you deplete the B cells completely and you don't mount a vaccine response. So people may even take a booster, but we've just published our paper this week, actually yesterday, where we looked at our Stanford data, and up to 2 years after you've had Rituxan, you can still fail to mount an immune response. So if you look at the relapsed refractory therapies which are available right now, you have the PI3 kinase inhibitors, and then you have the EZH2 inhibitor. All of them have a pretty low CR rate. I mean, they're all approved, but they have a very low CR rate, %. The overall response rate is about 50%. But the PFS is not bad, it's 10 to 11. And just earlier this year, Gilead discontinued idelalisib for follicular lymphoma. And in December, duvelisib was pulled off the market because, again, their confirmatory trials, they felt the landscape was too competitive. They weren't going to be able to do the confirmatory trial. So what we heard about at ASH this year was, again, the bispecific antibodies and CAR-T. So glofitamab, which as monotherapy or in combination with obinutuzumab, which is another anti-CD20 antibody, they looked at various dosing strategies. But if you look at this over here, the patients did pretty well. These are the side effects are mainly grade 1 and 2, whether you did glofit alone or you combined it with obinutuzumab. And the rates of cytokine release syndrome, they tried to do an extended dosing to see if they could cut it down. It really didn't make a difference. But there is no immune neurological effect. There was no febrile neutropenia. And if you look at the overall response rate and the complete metabolic rate, it's as monotherapy. Remember, I told you with the other agents approved, the CR rate is like 5–10%. Look over here, across the board, the CR rate is over 50 to 60%, which is very, very active. This is the waterfall plot, shows it's quite active. Similar story with, the conclusion is basically it works. Mosunetuzumab, another bispecific antibody, same story. Median of 3 prior lines of therapy. Some had had a prior transplant. They were refractory to the last therapy. And about half the patients had progressive disease at 24 months. And again, if you see, the waterfall plot shows it was very active and 60% CR rate, which is much higher than a 14% historical CR rate in this population with the other patients, with the other agents which are approved. And the response is comparable to the high-risk subgroups. That means those with POD24 as well. And you can see that the duration of response and the progression-free survival is all very encouraging. And again, a very manageable toxicity profile, very little CRS and almost no neurological toxicity. Again, concluding that it's very active. And if you just look at this table, just trying to sort of compare the antibodies in follicular lymphoma, very high overall response rate, very high CR rate, very encouraging median progression-free survival, and very well tolerated. So we also heard long-term of CART in relapsed follicular lymphoma. And remember, in the US, it is approved for third line or beyond. And this is now the ZUMA-5, which was looking at axi-cell. Again, very high overall response rate and complete remission rate in duration of response, time to next treatment. And you can see this graphically over here, especially in patients. This we looked at even marginal zone, but I'm just going to focus on the follicular lymphoma patients. And you can see that they really do well. This is the ELARA study, which used Tisacel. Again, same story, very high complete remission rate in patients who have failed 3 or prior lines of therapy. So the last part of the indolent lymphoma is looking at yet another PI3 kinase inhibitor, umbralisib, with a different anti-CD20 body, obinutuzumab, which is a glyco-engineered one, in marginal zone lymphoma. And this was the Unity trial. It was a phase 2. So they took just marginal zone lymphoma, and they gave the U² regimen and looked at the primary endpoints. So normally we treat marginal zone lymphoma like follicular lymphoma. So if you need treatment, you can use BR. If they fail, then the checkpoint, the BTK inhibitors are approved in the space, R² as activity. So this is now looking at U². And you can see over here that in the marginal zone lymphoma, that the overall response rate is in the 70% range, but the CR rate is quite low. So the overall response rate, 50–60%, but the CR rate is still pretty low. Nonetheless, the progression-free survival is, the median has not been reached, and the progression-free survival for patients who didn't, this was during the COVID pandemic. So there were some patients who died because of COVID. In the other group, it was 17 months. So summarizing indolent lymphoma, first-line low tumor burden, resort trial, no meaningful advantage of maintenance Rituxan. For frontline high tumor burden, again, maintenance Rituxan improves PFS after R-CHOP and BR, but no overall survival advantage and the risk of increased second cancers. And as I told you, the immune suppression. And for relapsed refractory disease, the CART and bispecifics are very active. There are toxicity differences, and there are encouraging results with umbralisumab. Moving on to Hodgkin lymphoma. For frontline therapy, ABVD has pretty much been the standard of care, and there are other regimens. There's escalated BRCOP in Europe, and of course BV-AVD, which is brentuximab AVD. And the dilemma of therapy has always been to use ABVD, which we all know how to do. There's a slightly lower cure rate, but is a lot better tolerated than escalated BRCOP, which may have a slightly higher cure rate. And then somewhere in between is brentuximab AVD, though the survival with all of these is very similar. So the checkpoint inhibitors are very active in Hodgkin's, and they are now being used in the frontline setting, and that's what we heard at ASH. One was an update of a single agent Pembro lead-in followed by AVD. So this was 30 patients. They got 3 doses of Pembro, and then they had a PET, and then if they were PET negative, they continued, which was defined as a correlate of 1 to 3. They got AVD, and then they had another PET. So this was 30 patients, and you can see about 60% had advanced stage disease, a third of the patients had bulky disease, and extranodal involvement was seen in half the patients. And if you see over here now at a median follow-up of about 2.5 years, the progression-free survival and the overall survival 100%. So it really did very, very well, this regimen. This is actually now being tested globally. There was no response between PD-L1 levels and the response. So unlike lung cancer, where you actually have a correlation between expression of PD-L1 and the response, that's not the case in Hodgkin's because it's universally expressed. Another way to do it is do it concurrently with AVD. So what my prior fellow, Ryan Lynch, who's now at the Hutch, did, he looked at Pembro AVD, where he also, you get with it on day 1 of every cycle, and then he sort of sandwiched it in between. But so the Pembro was given every 21 days and AVD was given every 14 days. And you can see that this was also 30 patients, very similar to the previous one. This did include some early stage patients, but if you look at very few patients had bulky disease, and most of the patients had a low IPS. So this was a little more favorable patient population than the previous study. Nonetheless, it was well tolerated, but you do get slightly more febrile neutropenia, but not any horrible immune-related adverse event. And the PET2 CR rate, again, by doing it concurrently, was 66%, at end of chemotherapy, 81%. And if you look at the progression-free survival at a median follow-up of about 16 months, it's short, but the 1-year PFS is 96% and the overall survival is 100%. Now in relapse disease, we have brentuximab and we have nivolumab pembrolizumab. But what happens once they fail all of that? So this was looking at ruxolitinib, which is a JAK2 inhibitor. So why look at the JAK2 inhibitor with Nivo? Well, chromosome 9q-p4, which is recurrent abnormality you see in classic Hodgkin lymphoma, that leads to increased expression of PD-L1, and JAK2 is amplified. So targeting, the JAK2 pathway in addition to the PD-L1 pathway makes sense biologically. And that's exactly what was tested in this phase 1 design. Looked at different doses of the ruxolitinib. There were just 19 patients. All of them had failed a prior checkpoint inhibitor. Some of them Pembro, some of them Nivo, and about 73% had actually progressed while they were on the checkpoint inhibitor. And if you look at the median number of cycles they got with this combination was 8. There was no dose-limiting toxicity. And there were the usual mild immune side effects, but nothing major. You look at the activity, there was an overall response rate of about 50% with 24% CR rate. So this is, remember, patients who've already failed a checkpoint inhibitor. And some of these responses, based on these arrows, you can see are durable. The progression-free survival at 46% and overall survival 87%. So I think these are pretty interesting data where in patients who fail checkpoint inhibitor, you can now add a ruxolitinib and try to sort of overcome that resistance. So in conclusion, for the Hodgkin's, the checkpoint inhibitors are very well tolerated as a lead-in or concurrently. And in US intergroup, there's a study ongoing with brentuximab AVD versus Nivo AVD. So let's see where this all eventually comes to play. Now moving on to mantle cell lymphoma. So in mantle cell lymphoma as frontline therapy, there are lots of options, but in general, if you have a younger patient who can tolerate aggressive therapy, the standard of care is a Ara-C-containing regimen based on the French data looking at RDHAP and then or alternating R-CHOP, RDHAP, taking them to transplant and then doing Rituxan maintenance. Okay. So this was the European Mantle Cell Network trial, which kind of looked at either giving this was a randomized trial, R-CHOP, or this alternating therapy, and then going to transplant. But this was an ancient trial. So at that time they were using TBI-based regimens for transplant, which is not used in this day and age. And that's one of the problems with this trial, but that's not the reason for presenting this. So when this was first looked at 6 years and published in 2016, the Ara-C containing regimen where you alternated R-CHOP with RDHAP improved the complete remission rate, the time to treatment failure, the PFS, MRD status, but there was no difference in overall survival. Now we have a much longer follow-up at about 50 months or so. And you can see that the time to next treatment is in favor of the RDHAP arm. The progression-free survival is in favor. And you look at overall survival for the whole group, there's no difference. But if you look at by MIPI, for the highest risk MIPI subgroup, there is a difference there in favor of the RDHAP arm in terms of progression-free, in terms of overall survival. And of course, because this was a TBI containing transplant, there is an increased risk of second malignancies in patients who go to transplant. So the conclusion of this was that high-dose Ara-C containing induction and auto transplant achieves a 60% survival at 10 years with acceptable toxicity. And you see this benefit of high-dose Ara-C in the high and low-risk patients. The overall survival also is improved in the high-risk MIPI. So of course, the open question is, how do you salvage if you had just used R-CHOP, though nobody uses R-CHOP these days. And of course, nobody uses TBI these days. So I think these data establish the comparator for chemo-free strategies, which are being looked at now in frontline. Now, when patients with mantle cell relapse, we give them a BTK inhibitor, like ibrutinib, or acalabrutinib, or zanubrutinib. Those are all covalent BTK inhibitors. And at this ASH, we heard about pirtobrutinib, which is a next generation non-covalent BTK inhibitor in patients who had previously been treated with a BTK inhibitor. So this drug, pirtobrutinib, is a highly potent and selective non-covalent BTK inhibitor. And you can see in 134 patients with mantle cell lymphoma, all of them had a prior BTK therapy. It's very active, no dose-limiting toxicity, and a median progression-free survival of about 18 months or so. So again, this is really very provocative data, and there's a phase 3 trial going on to look at this. The other agent which is available, it is approved in the US, is CAR-T, brexacaptogene. And again, CAR-T has its own set of toxicities. So I think if you have a patient who is not going to be able to tolerate BTK inhibitor, this certainly is an agent to look out for. Another drug which is coming into play is this anti-ROR1 antibody drug conjugate zilvomatab vedotin. So this ROR1 is an oncofetal protein, which is important for embryonic development, and is present on tumor cells and is amenable to targeting. So this zilovertamab is a antibody drug conjugate, and binding of this again leads to internalization, very much like brentuximab or polatuzumab. So in this phase 1 study, they took patients. It had all comers, but I'm just going to show you the mantle cell data. So in mantle cell, there were 17 patients, and you look at the the best overall response rate is about 50%. And patients, certainly seems to have some activity, failed prior BTK. And then the last thing we heard about is, again, the bispecific, the glofitamab, which also seems to be active in mantle cell lymphoma, and most of them, again, who had failed prior BTK therapy. So you can see in this characteristic of patients, all of them had failed most of them had failed prior BTK therapy, and you can see that the response rate is pretty high in the 90% range, with a CR rate of about 60 to 70%. Very encouraging tumor activity, and the expected side effects, but again, no neurological side effects, some cytokine release syndrome, but nothing horrible like you get with CAR-T. So summarizing mantle cell lymphoma, the long-term outcomes suggest that IRC regimens are quite useful pre-transplant. They're durable, and I think it improves the PFS in high-risk MIPI patients. The non-covalent BTK inhibitors are also very interesting. And the glofitamab, the bispecific antibodies, stay tuned. And the RO1-directed antibody drug conjugates also have a promising activity. So that is my last slide, and thank you for your attention. And I am very grateful for a lot of the investigators who actually shared the slides with me for my lecture. Happy to take questions.
Thank you, Dr. Advani, for that real update. We have Indian faculty here who would like to interact with you. Put the raise hand sign. Some questions have been put them in the chat box. One question is that in testicular lymphoma, intrathecal methotrexate versus systemic high-dose methotrexate, which is better for CNS prophylaxis?
So for testicular, if you look at the patterns of failure, they fail in the brain parenchyma. They don't fail in the leptomeninges. So doing intrathecal is useless. So if you have testicular lymphoma, you should do high-dose methotrexate. And that's what we do. And that's the subgroup we still do high-dose methotrexate, because you can see parenchymal brain involvement even later on, 5-6 years later on. So again, there's no randomized study in that subgroup saying not doing it is better. But if there's a subgroup, you would still continue doing it, is primary testicular lymphoma, and do high dose. Don't do intrathecal. They don't fail in the leptomeninges.
Another question is in T-cell lymphomas, if CD30 is expressed, should we use brentuximab upfront with all chemotherapies?
So, certainly for ALCL. Okay, ALCL universally expresses CD30, 100% of the cells do. I think it's debatable in the other histologies, as I showed you. Most of the effect isn't that, but based on the echelon 2 data, if you have more than 10% expression on the malignant cell of CD30, it's reasonable to do BV CHP if it's affordable, because it's very expensive. I don't think it's any better than CHOEP or doing CHOP and transplant in that subgroup of patients. I think that's the subgroup of patients which needs more study. But ALCL, definitely.
Thank you. The other question is, in elderly Hodgkin or patients with multiple comorbidities, can we give single agent immunotherapy?
So, for the interest of time, I didn't include that abstract. So yes, it has been looked at. We actually looked at it in combination with brentuximab. So we did a study with nivo brentuximab, and the response rate is pretty high, but they're not durable. So if you have somebody who just cannot take any chemotherapy, yes, you can do it. But the way I approach it is I give it to them initially to improve the performance status and get them to a point where they can actually tolerate some chemotherapy, because then the outcomes are better. But if the short answer is yes, you can give it.
Thank you. Okay, guys over here, you want to ask any questions? Okay, another question that has come up is there any specific subset of advanced Hodgkin lymphoma who will benefit from escalated BACOP upfront?
So I think the AHL trial is one of the best done trials, where you start out with escalated BACOP, and if they're PET negative after 2 cycles, you drop it down to ABVD. And actually these days you can drop the bleo if they're PET negative. So I think if you have a patient with really high risk disease, like an IPS of 4 to 7, very symptomatic, that is I actually like that approach. I start out with escalated BACOP and then I go down if they're interim PET negative. Remember, BV AVD on the echelon 1 was not a PET adapted strategy. They got 6 cycles. And if you look at the subset analysis, they did collect data on interim PET. The patients who got BV AVD who were interim PET positive, their PFS is only in the 50-60% range. Whereas if you start out with escalated BACOP, and if they are PET negative, you can drop down to ABVD or just give them 2 more cycles of escalated BACOP, which is a total of 4. And their PFS is in the 90% range.
Thank you. Another question is, After 2 cycles of R-CHOP in DLBCL, if there is a severe peripheral neuropathy due to vincristine, what will be your next approach?
Drop the vincristine. I mean, vincristine by itself is not the most active agent. So if you have severe peripheral neuropathy, giving more is not, it's going to make it worse. So at the first sign of neuropathy, if somebody starts complaining, I ask them every time, if there's any hint of interfering in fine motor function, buttoning the shirt, texting, typing, anything, I drop the vincristine dose by 50%, make it 1 milligram. Or if it's an older patient, 70, 75, or diabetes or something, start out with 1. But if they get significant neuropathy, despite that, just omit it. I don't think you could substitute with anything.
Dr. Abhishek, your question.
Ma'am, excellent talk. You basically covered everything. There's nothing more to ask, but I think just wanted to ask, is it time that we do away with GCB and ABC? Because last 6 months, what I've observed is even GCBs don't behave like GCBs. So is it time to go towards molecular, means just like solid tumors, go towards NGS, like in solid tumors, we do an NGS on day 1 and then try and look for targets and give treatments to the patient? Because a lot of GCBs are behaving as bad as ABCs.
So I think I showed you data that there are clusters which have been defined and the field is moving towards that. The thing is, it's not ready. There's no immunohistochemistry test to do it. You have to do, like you said, NGS or something. So they're not widely available. It's restricted to academic centers. And, as I showed you in the Phoenix trial, it was a negative trial. But when they looked at those molecular subsets within ABC, they found that the N1 and the MCD subtype had 100% survival. So yes, I think the field is moving to that direction, but it's not ready for prime time.
Thank you. Dr. Rajani, your question. Unmute yourself.
Thank you, Agarwal sir, for giving me this opportunity. Thank you, Ranjana ma'am. That was an excellent talk. You have very well answered our most debated question, the role of high-dose methotrexate as CNS prophylaxis. So my question is, what is your experience with CD20 negative DLBCL? How do these patients do? Do we need to add any other chemotherapy agents to CHOP, or do we need to intensify our chemotherapy upfront in these patients, ma'am?
So, so CD20 negative DLBCL is pretty rare. You see that in plasmablastic lymphomas where they can be CD20, those tend to be immunocompromised or HIV. So, I think you really need to make sure it's a B-cell lymphoma, though. Make sure the pathologist has done other B-cell markers, and often it's make sure that control is working also, because it's really pretty rare. And we've had this problem that it's come as negative and you rerun it with a different control and it's positive. And since, if it's truly cold negative, despite being careful, then adding Rituxan doesn't make, or any other CD20 antibody doesn't make sense. I don't think we have any alternative to say that a more intensive, even before R-CHOP became standard of care, there was a trial looking at CHOP versus ProMIS, Cytobam versus MBCOP, none of those were positive trials. So you're stuck with CHOP, and you just have to have a lower threshold to see if they are of following them pretty carefully, because if they don't go into a CR or they relapse, you might have to take them to auto transplant. You can also check for CD19 expression, because if they have CD19 expression, I think there are some subsets which might then benefit from the CART approach.
Okay.
Thank you. Abhishek?
Ma'am, I have this patient, she's a 50-year-old, and she has got an ileocecal huge mass where it's showing high-grade large cell lymphoma, CD20 positive, and the bone marrow is showing marginal zone lymphoma. There's disease only at 2 sites, no other nodes, no liver spleen involvement, and she did not respond to 6 cycles of R-CHOP. She has not responded to GDP. She has not responded to ICE, and we re-biopsied her twice. It again shows the same disease, large cell lymphoma, high grade, 80, 90% Ki67, and it's still there. It hasn't even progressed. It hasn't moved an inch. So what do we do with her?
It's localized disease.
Yeah, it's a localized disease. Only problem is we had a bone marrow showing marginal zone lymphoma.
So this is clearly, It's transformed, right? I mean, you can get an isolated site of transfer. The underlying marginal zone is there, but there's transformed. But if it's all localized, is it amenable to radiation at that site?
Yes, ma'am. Yes. It's in the ileocecal region. She might have some trouble.
But given the alternatives, they're refractory to every chemotherapy you've just mentioned.
Yes.
So other choices, polatuzumab, you could try polatuzumab. It's approved with BR, but what we do here is we just give it as give polatuzumab by itself. You could also otherwise consider just trying some oral lenalidomide and seeing whether that makes any difference, because
we tried that also, ma'am. It's not working.
Then I think you're stuck with to try radiation.
Is there a role for surgery in such a case, ma'am? It's removable.
Okay, the question is, how do you define yes, I would say yes, there is. In such a refractory case, there is. The question is, it's this disease at the microscopic level is probably there beyond what a clean margin will be, in the cancer world. So maybe have your surgeon do a wider margin, but yes, there will be a role for surgery in something like this.
Thank you, ma'am.
Thank you. One question from Dr. Shyam Rathi is, how do you compare efficacy of Ven plus Ibru with R-DAP in mantle cell lymphoma?
So venetoclax, ibrutinib versus R-DAP in the salvage setting. I mean, they're completely different approaches, right? I mean, or you mean upfront, because there are trials going on for both.
Upfront, probably.
Okay, so for upfront, the attempts to go to a chemotherapy-free approach are ongoing, looking at a BTK inhibitor along with a BCL, like a venetoclax-like drug. And they're very active, and we just don't have longer-term data to say that it can replace chemotherapy. So still the standard of care, if you have a younger patient, is to give an Ara-C-containing regimen, alternating R-CHOP with R-DAP and taking them to transplant, and then maintenance Rituxan. There are trials going on looking at the role of transplant. If you're MRD negative at the end of induction, it's being randomized to transplant versus Rituxan maintenance. Being randomized to transplant versus BTK maintenance. So I think the goal, people are challenging the role of transplant, challenging the role of chemotherapy, and challenging the role of, we know that if you have P53 mutated, transplant doesn't work. So in mantle cell, the whole field is moving towards, can BTK inhibitors with venetoclax replace the conventional chemotherapy approaches, be in frontline, be in salvage? But again, we're not there yet.
Thank you. Another question about Hodgkin lymphoma. As per Rathal, if PET is positive, you go for BACOP 14. But there is no difference between SB14 and escalated BACOP. Is this statement okay?
So they looked at they looked at it, and they found that standard BACOP, but you have to use more doses. You can't get away with just 4 doses of escalated BACOP. You have to go 6. It's given every standard BACOP every 14 days, so it's a little bit more intense. I think it again is a situation where if you're more comfortable using standard BACOP, you can certainly do it every 14 days. Because if you try to do it every 21 days, it doesn't work.
Thank you. Another question is there a separate protocol for T-cell rich B-cell lymphoma?
No, you treat it like large cell lymphoma.
CD5 positive DLBCL. Should we give R-CHOP or R-EPOC?
Okay, it's rare. It's there in about 5% of the cases. We still use R-CHOP because there's, the CLGB's trial randomized patients to R-CHOP versus dose-adjusted EPOC-R. There was no difference. So the only places where we use dose-adjusted EPOC-R as frontline therapy is primary mediastinal lymphoma, because you want to spare young, big mediastinal radiation. We use dose-adjusted EPOC-R if you have a double hit lymphoma as frontline therapy. But other than that, there's really there's nothing to say that R-CHOP. Now, of course, you have the Polarix data suggesting that the polatuzumab R-CHOP may be better than R-CHOP, again, in certain, non-bulky, non-GCB, high-risk IPI patients.
Thank you. ALK positive ALCL with contiguous CNS involvement line of treatment?
It's again pretty rare. Okay, very, very rare. So I'd really check the histology. But on the other hand, I assume if they have tried brentuximab. There is some data about it crossing the blood-brain barrier. I think you're forced to do a methotrexate-based regimen. Use a high-dose methotrexate-based regimen, something which crosses the blood-brain barrier.
Thank you. Is it possible to have c-MYC rearranged on fish when IHC was negative?
That's the more common scenario. So in fact, the IHC is not a surrogate for molecular studies and vice versa. Okay, so at our center, what we do is we look for MYC by fish on everybody. And if the MYC is positive, only then we do look for BCL2 and BCL6 rearrangement. But immunohistochemistry is done on everybody. Those don't necessarily correlate. In about 20–30%, there's an overlap, but that's not 100%. And double expressor is very different from a double hit.
Right. Isolated parenchymal CNS relapse of a double expressor DLBCL after 6 cycles of R-CHOP and salvage with high-dose methotrexate, high-dose ARA-C. Should we go for ASCT?
Yes.
Right. Is there a role of single-agent rituximab for low tumor burden, marginal zone lymphoma? And should we use it 4-weekly doses or 6-weekly doses?
So yes, I mean, it's like any other indolent lymphoma. If you need treatment, and remember, low tumor burden, you don't have to treat. But if you want to treat and have to treat for some reason, you just use weekly ×4. There's no data. I just showed you the long-term results of the RESORT trial. Retreatment is just as good as maintenance. So just 4 doses is what you need.
16-year-old classical Hodgkin lymphoma progressed after ABVD, got complete remission with high-dose therapy, early second relapse, financial constraint. What should be the next line of therapy before doing allotransplant?
I mean, you said financial constraints, so I think that will dictate what you can do. But I mean, brentuximab or the checkpoint inhibitors are all there. And if you have to compare the two, the Keynote 204 study showed that Pembro is better than brentuximab in the randomized setting. So if I have to use one drug, I'd probably pick pembrolizumab, and you can give it every 6 weeks. That the increased dosing and try to get some time then. I think it's certainly a lot better tolerated. But if you just cannot even afford that, then the very limited options. We've used single agent Velban. Before all these drugs were available, we used to use single agent Velban, and you could buy time for many, many years with that.
Refractory ALK positive large B-cell lymphoma after failure of 3 lines. Any further options?
And you can try the ALK inhibitors like crizotinib, or one of the other lung cancer drugs which are used, which are approved. They have a fair amount of activity too.
Okay, Dr. Rajani, you raised hand. You have a question?
Yes, sir. Ma'am, in advanced Hodgkin lymphoma, if the interim PET is suggestive of a DUALI score of 3, can we safely go with the de-escalating strategy as we do for the DUALI score of 1 and 2? If it's an end of therapy PET DUALI score of 3, okay, we are sure that it's a CMR. But for interim PET, can we go about with the de-escalation for DUALI score of 3 is my question, ma'am.
But this is only for stage 3 or 4 disease. We're talking only of stage 3 or 4.
Yes, ma'am. Advanced stage. Yes, ma'am.
Yes, so advanced stage, that was the RATHL trial. A Dobel score of 1, 2, and 3 was considered negative, and glioma.
Yes, ma'am, that was taken as negative. But in our real world scenario, DUALI score of 3 patients, I'm not sure whether we can go with it omitting of.
The randomized trial of over 1,000 patients said you could.
Okay, so we can go. Okay.
RATHL trial, a negative scan was defined as a Dobel score of 1, 2, or 3. Now, in early stage disease, where you are only giving, 4 cycles or 3 or 4 cycles of ABVD, there a 3 is not okay. there it has 1 or 2 and you never drop the bleo. But in advanced Hodgkin's, if you have an interim PET with a score of 1, 2, or 3, assuming your nuclear medicine is accurate in what they're calling a Deauville score, yes, you can drop the bleomycin.
Okay. Okay.
Thank you.
Ma'am, I have another question for you. For transplant ineligible relapsed refractory DLBCL patients of ABC type, so what is your experience using ibrutinib alone or in combination with rituximab, ma'am?
So, you know, the ibrutinib does have some activity, but this is transplant eligible or ineligible?
Ineligible, ma'am.
Yeah.
Ineligible.
So, you know, it's one of the options, but it's not that it's any better than R square or it's, you know, lenalidomide also has activity in ABCs. Yes. So I don't think ibrutinib is particularly better than that. There's been no randomized trial. It certainly is a class of drugs which the BTK inhibitors are a drug which have more activity in non-GCB subtypes. So if you can't take somebody to transplant, it's worth trying.
Thank you. Case of DLBCL received 3 cycles of R-CHOP, then developed COVID pneumonia. After this, and patient had a solitary bone 1AE stage disease. What will be the further treatment?
Radiate.
Beg your pardon?
Radiate the bone lesion.
Radiate the bone. So no further rituximab, no further treatment.
Because, you know, you've had 3 cycles of R-CHOP. I assume the patient is in a CR by now, because a stage 1 disease, usually after 3 to 4 cycles, they're in CR. And I would, especially with extranodal disease and bone, there's a lot of data supporting the role of radiation.
Isolated parenchymal CNS relapse of Burkitt's lymphoma, which was upfront treated with R-GMOL, salvaged with high-dose methotrexate HiDAC. Would you do an autologous transplant?
You know, this is, again, a very rare scenario. It's not the most common scenario. And, you know, anyone, it's if the patient, an auto transplant, you have to think it's only useful if you have chemosensitive disease. Because if you don't have chemosensitive disease or if you have rapid relapse, then an auto is not going to work. So in this situation, I mean, really, this is somebody who has been salvaged, and if the patient is in complete remission and has responded, then yes, an auto makes sense.
Thank you. Do you know a transformed follicular lymphoma? Would you recommend ASCT in CR1?
No, not as the data doesn't. There are lots and lots of treatment options. So we used to do that, you know, 20 years ago. But now with the increased armamentarium of drugs available, I don't think anyone does auto transplant in CR1.
Any comments on duration of vinblastine for a relapsed ALCL responding to vinblastine 6 monthly with weekly single agent?
So, you know, it's based on count tolerance. And again, we've used it. I've used it in patients before brentuximab was available. That's what we used to do. And we could do it for anywhere from about 6 to 10 months, and then counts become difficult and you can't do it weekly. You'll end up doing it every 2 weeks. It's based on what the patient can tolerate. I don't think there's a hard and fast rule on this.
Abhishek?
Another rare one, primary progressive PMBCL. So this guy responded to R-the-IPOCH. The mass was about 10 centimeter, came down to 4. And after 6, it went to 9. We rebiopsied it. It was again PMBCL, CD30 positive. It's a huge mass. Should I radiate it immediately or give a couple of cycles of maybe a second line agent or a pembrolizumab with brentuximab? It's CD30 positive because it's a 10 centimeter mass.
I would radiate it because radiation will act quickly, and you can then you can do it concurrently with pembrolizumab as well. Okay, so the trial of brentuximab and PMBCL was stopped early because of lack of efficacy. They all express CD30, mostly. So you cannot do brentuximab, but pembro is quite useful. And there's a publication of looking at pembro along with brentuximab in that, which also looks good. So you can do, and those agents you can combine with radiotherapy. So to have somebody who has such primary refractory disease after dose-adjusted EPOC is also pretty rare. 90% of them do really well. That if you really need to control, it's still localized, you can still radiate and control them, give them pembrolizumab and then take them to auto transplant. Because giving them a checkpoint inhibitor sensitizes them to chemotherapy again also. So that's why auto.
Thank you, ma'am.
If you can't give radiotherapy now, you can give pembro or give BV Nivo or BV pembro, bring the mass down, take to auto transplant, and then radiate. I mean, this patient is going to need radiation one way or the other.
Thank you, ma'am.
Hodgkin lymphoma, post auto transplant for a relapsed case who has received Nivo BV salvage and now has undergone allo transplant. Should we maintain with BV?
I don't think has undergone allo transplant after BV Nivo.
Auto transplant, it failed, and then
BV Nivo. Okay, I don't think there's any data.
Right. For primary CNS lymphoma, what is your preference for consolidation? Low dose whole brain RT or high dose chemo plus transplant?
So depending on the age of the patient, if it's younger patients, we go for transplant. If it's a slightly older one who's not going to be able to get to transplant, we do the low dose radiotherapy.
Is there any role of intrathecal rituximab as CNS prophylaxis?
No. It's been tried. It works when you have active disease. Even intraocular rituximab has been given for eye involvement. But for prophylaxis, I'm not aware of any data.
Is there increased incidence of engraftment syndrome when you do ASCT after prior checkpoint inhibitors?
Yes, there is emerging data. So, we ran the BV Nivo trial for first salvage in Hodgkin's. And when we took those patients to transplant, there is a slightly higher incidence of engraftment syndrome. I mean, it's not horrible, but we see it much more than what we used to see after, say, ICE or, GND or something. So there is a little bit more, and you just have to be aware of it. But most patients get through it.
56-year-old follicular lymphoma, DR, R-CHOP, R-square, and then LEN maintenance for a year. Now gets isolated right thyroid relapse. Should we do surgical excision or radiate or something else?
I assume and I hope that this patient has needed all these treatments, just chasing a relapse at all these times, because, if your patients if they have low tumor burden, you really don't need to treat them. So this one nodule which is there, if it's asymptomatic, thyroid functions are okay, and it's not a compressive mass, you can leave it alone. But if it is, and you need to treat it, local radiation this is recurrent follicular lymphoma. So 2 gray times 2, just very low dose radiation with 4 gray is very good at controlling local disease. You have a 75% response rate in such scenarios. So we never use a higher dose, just 2 gray times 2, only if you need it.
Right. Any minimum gap you recommend between checkpoint inhibitors and allo transplant?
A minimum of 6 weeks.
That's the last question here. Any question from the faculty? Okay, so that's it, Dr. Ranjana. Thank you so much for sparing us such a valuable time. Late night.
Sure. My pleasure.
Thank you so much.
Thank you.
For all the Indian colleagues, we're going to meet again at 2 o'clock. Thank you. afternoon, friends. So we are back to the post-lunch session. Morning we had lymphoma by Dr. Ranjana Advani, and this afternoon we have 3 lectures. The first of this is on AL amyloidosis, and as you know, the speaker is Dr. Ashutosh Wechalekar. He's Professor of Medicine and Hematology, Director, Jack O'Neill Amyloidosis Lab, National Amyloidosis Center, UCL, Royal Free Campus, Department of Hematology, University College London Hospitals, Department of Hematology, Royal Free Hospital, London. He had his initial medical training at Medical College, Nagpur, India. Subsequently, he received hematology training in UK. He did clinical research fellowship in myeloma and related disorders at Princess Margaret Hospital, Toronto. 2004, he joined the UK National Amyloidosis Center as a senior research fellow, funded by a grant from Leukemia Research Fund. His scientific interests are focused on characterization and treatment of systemic AL amyloidosis, myeloma, Waldenstrom, with a focus on the biology of plasma cells and to study new and novel agents in these disorders. He has formed a UK Amyloidosis Network and is a member of the European Amyloidosis Consortium. He is a board member of UK Myeloma Forum and of British Society of Hematologists Committee for Standardization in Hematology for developing guidelines for treatment of myeloma and amyloidosis. He has published extensively in these areas. He is a member of the International Consensus Panel for Nomenclature and Diagnosis of Amyloidosis. He has set up a website, which is a continuously updated free web resource detailing all known mutations in hereditary amyloidosis and their clinical phenotype. This part of our webinar is supported by Zydus. Well, thanks, and I request Dr. Ashutosh to take over.
Thank you, Dr. Agarwal, for this very kind introduction. I hope you can see my slides.
Yes.
And it's always a great pleasure to join this meeting. As we were just talking before this introduction, it's have not been able to see this meeting in person for a couple of years, but it's a delight to be here virtually and look forward to this session. So I'll be talking today about AL amyloidosis, focusing on what was presented at ASH 2021, but also taking liberty to talk a little bit about other bits that we have published in amyloidosis, which will influence how you diagnose these patients, how you assess these patients, and how you treat these patients. So this is an interesting slide, and it is becoming very popular. These are the number of peer-reviewed publications in amyloidosis since 1973 onwards. As you can see, there were hardly any publications of amyloidosis in the last, in sort of the 80s and the 90s. And now we are getting about 500 publications with amyloidosis. If you add transthyretin amyloidosis to this, then the number of publications in the last 4 years shoots up to over 4,000 to 5,000 a year. So it's definitely becoming very popular. It's being increasingly recognized and diagnosed more often. This is particularly true for ATTR amyloidosis. And this is a paper we published now a couple of years ago, which looked at the prevalence of different kinds of amyloidosis based on the patients who were referred to our center. The number of referrals and the number of cases have been going up. AL amyloidosis cases have gone up over the last 10 years, but now we think they are sort of reasonably steady. But this little gray bar here, which is ATTR amyloidosis, the numbers have really gone up exponentially. And we are now seeing between 400 to 500 patients with ATTR amyloidosis every year. And we definitely feel that we only see a small proportion of all patients who are diagnosed. And that's very important for us from a hematology perspective, because a lot of patients with ATTR amyloidosis, they fall in their 70s and their 80s. When we looked at our patient cohort, 23% of these patients had an underlying gammopathy. And that brings up an important question of differential diagnosis. Cardiac amyloidosis, particularly isolated cardiac amyloidosis in an older adult, can be ATTR or AL, and typing therefore becomes very crucial. One important means of differentiating AL and ATTR amyloidosis has been DPD or PYP scintigraphy. This has been widely adopted. I'm not sure how widely this is used in India, but any bone scan tracer will essentially do the same thing as DPD or PYP does. We looked at DPD in AL amyloidosis, and as you can see, majority of the patients with AL, 40% had uptake, 60% had no uptake. But a small number of AL patients continue to have low-grade uptake, and a quarter of AL patients continue to have a lot of uptake in their heart on DPD scintigraphy. So DPD scintigraphy is useful in differentiating AL and ATTR, but in a negative way. If a patient with cardiac amyloidosis has no uptake or low-grade uptake, then AL amyloidosis becomes a strong possibility. But on the other hand, if a patient with cardiac amyloidosis has significant cardiac uptake, then a positive DPD scan does not mean ATTR amyloid. It could be AL as well. And in this case, a biopsy becomes absolutely crucial to confirm the diagnosis of amyloidosis. We have presented this before. The survival for patients with AL amyloidosis continues to improve. And the median survival has improved from about 1.5 years to nearly 5.5 to 6 years. We continue to see early mortality, and we'll talk about that in a moment. But what is quite important is that none of these graphs, even though the survival is improved, are plateauing. And we are seeing ongoing deaths in patients, particularly even after many years of diagnosis. And this is quite challenging. Some of the patients will die at relapse, but other patients will die of other causes. Vaishali Sancharwala and colleagues from the Boston University Medical Center Amyloidosis Group presented this very nice series at ASH this year, where they looked at causes of death in a 40-year natural history study of light chain amyloidosis. What they were able to show that over the 40 years, there was a reduction in the mortality from 23% in their patients diagnosed in the 80s to 30% in their patients diagnosed from 2010 to 2019. This is the overall mortality, all patients taken together. Now, it's important to remember that Boston is a referral center, and a lot of patients are referred to Boston for transplantation. Their mortality figures are very encouraging. We don't see anywhere near this. We find that this is more close to 25 or 30%. And I'll show you some slides about that. But in the cause of death, about a quarter of the patients had sudden unexpected death. This is probably sudden cardiac amyloidosis. And a number of patients, nearly 50%, went on to get progressive organ failure, cardiac or renal being the two most common ones, which was the cause of death. And a small number of patients died of treatment-related events. This is quite important because we don't know if amyloid patients die of amyloidosis, particularly years after diagnosis. And this slide certainly seems to suggest that patients continue to die of amyloid-related organ problems or sudden death due to cardiac amyloidosis. We stratify patients of amyloidosis based on the Mayo staging, which uses NT-proBNP and troponin T. Now, this has been done for a long time, since 2004 when it was first described, and then modified by our group and the European colleagues. And we can see that this stratifies patients into no cardiac involvement, mild, moderate, and very severe cardiac involvement, with high mortality in those with severe cardiac involvement. But can we do better than this? And we've been trying for many years to improve this. Shahaji Kumar from the Mayo Clinic published a modification of this using free light chains, which is used more in the US, not so much in Europe. We have tried to add a few other things. 6-minute walking distance is a very, very simple test that can be done in any clinic with no equipment whatsoever, apart from something to measure the distance and a timer. And what we can show is that as the cardiac involvement gets worse, patient's 6-minute walk distance decreases. But more importantly, depending on how much a patient can walk, more than 300 meters, less than 300 meters, or they were unable to attempt a walk test, we can significantly stratify these patients into 3 big groups. And we think this will be an important tool to allow us to globally judge how unwell a patient is. We certainly use this when we look at patients who are going for stem cell transplantation, and we would only choose patients who are able to do a walk test of over 300 meters to proceed with transplants. We do echocardiograms in all our patients with amyloidosis, and one of the things we see in these patients is that their cardiac function isn't so good because of heart involvement. The typical affection in amyloidosis is that the radial function, which is your ejection fraction, remains normal. But the longitudinal function, which is the vertical contraction of the heart, the so-called longitudinal strain, is impaired. Amyloid deposition starts in the base of the heart and then gradually progresses towards the apex. So this part of the heart stops moving first, then this, and then this. So when we look at the strain, you can see the movement of each part of the heart. And in amyloidosis, you can find that the apex continues to move normally, but the base starts to become quite flat. And this gives us what's called as a global longitudinal strain as a percentage movement from baseline. Normal is about -20 to 25. In amyloidosis, we find that there is a significant reduction of strain. Patients whose strain is greater than -9, so the heart isn't moving very much, have very poor outcomes compared to patients whose strain is better. And we have now proposed a new staging system for cardiac amyloid patients where we can incorporate both the cardiac biomarkers and the global longitudinal strain. Together, we can have a functional marker and a biomarker. And this is particularly useful in patients where biomarkers become unreliable, such as those with significant hypoalbuminemia, fluid retention, renal failure. And strain is a useful marker to track improvement. Patients whose strain improves by 2 have significantly better outcomes compared to patients whose strain doesn't improve. The other important thing about imaging amyloidosis patients is that assessing the entire body's load of amyloid deposits is very difficult by all of these techniques. Each one is assessing either the heart or the kidneys or whatever. And having a global imaging method, we use something called a serum amyloid P scintigraphy in London. We've been doing that for now 30 odd years, but it is not widely applicable. And this was a study presented by Jonathan Wall and colleagues, where they've got a molecule called AT01, which is a small peptide which binds to amyloid deposits. And this is a patient with AL amyloidosis showing extensive uptake in the liver, spleen, as well as kidneys. This is another patient with before and after treatment, where you can see that the amyloid has significantly regressed after treatment. They were able to show that the cardiac uptake is seen in a very high proportion of patients, as well as liver and spleen, and they think the sensitivity and specificity for this tracer is very high. This is a PET scan tracer. It will be something that is being studied in phase 2 clinical trials, and we do hope that this tracer gets commercialized to allow wider imaging of amyloidosis in many centers. When patients with AL amyloidosis are treated, we have to assess how they're doing with treatment. For a long time, we have been using the standard myeloma-related markers such as paraprotein and light chains, particularly serum-free light chains, for defining complete response, very good partial response, and so on and so forth. But other response categories are also equally important in the diagnosis of amyloidosis. We were able to define now a few years ago that patients who achieve very low levels of light chains, the difference between the involved and the uninvolved light chain of less than 10, had very good outcomes. They did not require treatment at a median follow-up of nearly 4.5 years. Patients who had a DFLC of less than 10, nearly 80% of these patients hadn't gone on to get their second-line treatment, and their survival was very good. Ray Comenzo and colleagues from Boston also reported something very similar. If the involved light chain had dropped below 10, these patients had very good outcomes compared to patients whose light chains were higher. So we do believe that deep light chain response should be an additional category of response assessment in amyloidosis. And we have gone on to do a couple of other studies. Minimal residual disease in myeloma is now a hot topic. And we looked at MRD in patients with AL amyloidosis. A number of studies have been done over the years looking at MRD assessment in AL amyloidosis. This was a Euroflow study done jointly with colleagues from Pavia and Spain, where we were able to show that cardiac responses in patients who were MRD negative were significantly better, and the survival was very good. This is a study from the Boston amyloidosis group, where they were able to show that patients who were MRD positive had worse outcomes compared to patients who were MRD negative. They also tracked patients' MRD status over time, and 84% of patients continued to have sustained MRD negativity, and only a very small number of patients converted to MRD positivity. And therefore, we do believe that minimal residual disease assessment in amyloidosis has a role, but as the field continues to evolve, we need to assess how we actually use this and how we modify our treatment based on this. One of the big developments in paraproteinemias is the change in how we assess and measure monoclonal proteins. You're all familiar with these techniques. Paper electrophoresis, went on to gel electrophoresis, went on to capillary zone electrophoresis, which is now widely used in a lot of laboratories for assessment of M bands. But more lately, we have got mass spectrometry, where we can assess the mass to weight ratio of different monoclonal proteins, and we can get a nice spike detecting monoclonal protein activity. The sensitivity of these techniques is very, very high, and we can detect an M band down to as low as 10 milligrams per liter, and serum-free light chains down to as low as 0.1 to 0.2 milligrams per liter. We went on to look at this in patients with AL amyloidosis. These are one of our patients at baseline at follow-up. Using mass spectrometry, you can see the polyclonal normal, which is the dotted line. And you can see a nice little peak of total lambda. And then using the free light beads, we were able to measure the free lambda. And you can see a very nice free light chain peak in patient before treatment. The lambda light chain in this patient was not very high, it was only 39 milligrams per liter. Patient was treated, went on to get what we thought was a true complete response. Patient, in fact, felt a bit better, but the proteinuria didn't really resolve, and he continued to have about 5 grams of proteinuria. This was his total light chain measurement. It is very much tracking the polyclonal bands as we see. There is a bit of immunosuppression, so therefore the polyclonal kappa is lower. But when we look at the free light chain assessment, you can still see that there is a trace of a lambda band over here, which is being hidden in the total lambda, suggesting that the patient is not in a true CR. We went on to do a bone marrow for MRD assessment in this patient, and were able to document the presence of MRD. The patient went on to have a transplant and is now doing very well. The key in patients with amyloidosis is to assess their end organ response. Is the heart getting better? Are the kidneys getting better? And for a long time, we have had a yes-no response category. NT-proBNP drops by more than 350 and 30%, patient has a cardiac response. Proteinuria drops by more than 50%, patient has a renal response. But then the NT-proBNP might drop by 95% in one patient and only 45% in another patient, and they are very, very different. And this is the paper which we have done jointly with colleagues at the Mayo Clinic, where we have gone on to look at graded cardiac response based on the depth reduction in NT-proBNP. So the NT-proBNP essentially normalizes. We've called it as a cardiac complete response, and a very good partial response, and a partial response, and so on and so forth. Patients who get a cardiac complete response have very good long-term outcomes compared to patients who do not have a cardiac response, so have much worse outcomes, and the intermediate groups thereafter. But what was also striking in this paper was that the same group of patients, the number of cardiac responses deepens over time. We only have 10% of patients who have a cardiac complete response or very good partial response at 6 months, which goes on to nearly 30% at 12 months, which goes on to nearly 50% at 24 months. So it's important to remember that even after the patient has completed treatment, the responses will carry on deepening if the patients remain in a deep and a sustained complete response. Similarly, we looked at renal responses based on the decrement in proteinuria. If patients' proteinuria decreased to less than 200 milligrams per 24 hours, essentially disappearing, a renal complete response, and so on and so forth. The time for the percentage of patients who progress on to dialysis is very different. Patients who get a complete response, very few patients go to dialysis, compared to patients who don't get a renal response. Nearly a quarter of the patients are on dialysis by 4 years. But what's important to remember is that even the renal partial responders will go on to dialysis, and therefore trying to get a complete response still becomes very important. Moving on to treatment and assessment of patients during treatment, what are we looking at? One of the things we've been able to show recently is that patients' response assessed as early as 1 month can predict for long-term outcomes. We believe this is crucially important because these patients will continue to progress as long as the light chains remain high. We were able to show that patients who have a CR or VGPR at 1 month have significantly better outcomes than less degree of response. This is true at all disease stages. I just have an illustrative graph here for patients with Mayo stage 3 disease. You can see that patients who have a VGPR or better at 1 month, the median survival is over 5 years compared to a median of just over 2 years for who don't get this depth of response. And therefore, regimens which give you early responses become very important in treatment. We have certainly got a new algorithm for treating our patients. We believe that patients who don't get at least a partial response at 1 month who have high presenting light chains need to switch therapy as early as 4 weeks from starting the first-line treatment. This is absolutely critical because very few of these patients will increase their depth of response enough to stop amyloid progression. On the other hand, patients who get a partial response at 1 month, 50% reduction, maybe it's not time to abandon the regimen. Have a look at the trajectory of the response. If these patients are continuing to respond, you can carry on. But if you feel that the response is very slow or slowing down, then add something else or consider switching. The goal of response, we think, is a CR or achieving light chains of less than 10 or involve light chains of less than 20. If patients don't reach this goal, then we need to closely monitor the organ function to decide if further therapy is required. The other study which was presented at ASH was the EMN23 study, where we looked at nearly 4,500 patients with AL amyloidosis from most European amyloidosis centers, looking at their profiles over the years and also their treatment outcomes. About 40% of patients had received a bortezomib-based regimen, but what we can see that in this very large group of patients, the depth of complete response with bortezomib-based regimens is still not that good, about 15%, and an overall response rate of about 35%. The overall survival was stratified based on when the patients were diagnosed, pre-2010, post-2010, very similar survivals in patients with early Mayo stage patients, but slightly worse survival in other patients. We looked at survival in this by overall responses, and we are seeing something very similar to what you have seen many times before. Complete responders do well, partial responders don't do so well, but that's quite interesting to see that we can see this even in patients with advanced stage cardiac disease, the 3As and the 3Bs. And therefore, it's really important that in the patients with 3B disease, we strive to achieve rapid complete responses. Putting this data and our data together, getting a CR or a VGPR at 1 month in these patients now becomes very crucial and important. What about stem cell transplantation? We looked at this in our series of patients and published this last year, matched VCD to ASCT, and we were unable to show any significant survival benefit of transplantation in AL amyloidosis. Even in the deeper responses, transplanted patients and patients treated with VCD appear to do very, very well. We do believe that there is a role for transplants, but we believe this may be based on the patient's bone marrow risk factors, such as presence of a T1114 or significant plasma cell infiltration, rather than all comers across the group as we were doing before. We presented this data from one of our trials, which is the TRALA study. This is a study of patients with AL amyloidosis who had a radiation-based conditioning for transplantation. So rather than using standard melphalan, which causes significant toxicity, mucositis, and even morbidity, mortality in these patients, one could use a targeted approach just to kill the plasma cells. This is an antibody, which is an antibody to CD66, which is a myeloid targeting antigen. We labeled it with yttrium. Being myeloid targeting, it targets the bone marrow, doesn't target any of the other organs. Patients get radiation infused 14 days prior to the transplant. Patients start becoming cytopenic by day 7 as the radiation ablates the marrow, and then patients are transplanted at day 0. From day -14 to day 0, patients are outpatients, even though they are starting to get cytopenic. There were no mucositis and very few systemic side effects. And we did 3 different dose levels with the goal to achieve 45 mBq per kilogram. There were no infusional reactions. There was no mucositis. There were no fevers. CRP remained low. Patients were eating and drinking all the way through the transplant. And surprisingly, a lot of patients commented that this was probably the best tolerated treatment they've had. We had, even in this sort of dose escalating study, we got 3 complete responses, which are now sustained, 3 very good partial responses, and 2 partial responses. We do believe that this is a novel approach to transplanting patients with amyloidosis, and we're hoping to move on to a phase 2 study, so this could be adopted widely, and maybe patients who are not candidates for transplantation by melphalan may be candidates with this. One of the questions which gets asked is there a role for transplanting patients who don't respond to frontline treatment, the so-called refractory patients? And this was a nice study presented by Nelson and colleagues at ASH in a poster form, where they looked at the response to autologous transplant in just around 100 patients based on their sensitivity to induction or refractoriness to induction therapy. So when patients were sensitive to induction, patients deepened their response. The green bar is the CR rate, which was about 10% here, went up to 40% in patients who were sensitive to induction therapy, with an overall response rate nearly reaching 90%. They had a group of patients who were refractory to induction therapy, no response to induction, and these patients went on to get transplantation. And even within this group, we are seeing some improvement in response. 20% of patients are getting a CR, and another 10% of patients getting a VGPR. So whilst there is a role for transplantation in refractory patients, it is very important to see that the depth of CR and VGPR achieved is actually not great. And therefore, one may choose to consider novel agent-based induction to achieve a deeper response before these patients go to transplantation. I believe this data is going to be more and more important to us, particularly as we start using Daratumumab in frontline treatment, such as Dara-Cybo-D. And if patients don't respond well to Dara-Cybo-D, there may be a big role for transplant to consolidate responses in these patient groups. Of course, that brings me on to Daratumumab in amyloid. You've probably heard and read a lot about this, so I'm not going to go into great details. Licensed as the first treatment for AL last year, based on the data from the Andromeda study of Dara VCD versus VCD. And an updated analysis was presented by Ray Comenzo at ASH at the median follow-up of 25 months. 60% of patients in this study had achieved a CR in the Dara VCD group compared to just about 20% in the VCD group. And there were no new safety signals on the long-term follow-up. The patients' number of deaths were slightly higher in the bortezomib arm than the Daratumumab arm. When we look at organ responses, again, nearly 50% of patients in the VCD arm with Daratumumab had achieved responses compared to just a quarter of the patients in the Velcade arm. So this long-term follow-up of this study confirms that Dara VCD not only gives deep responses, but gets translated into a significant number of cardiac and renal responses on longer-term follow-up. This was another study presented by Statis Kastridis and colleagues from Greece, conducted by the EMN group, looking at single-agent Daratumumab in patients with a very advanced Mayo Stage 3B cardiac AL amyloidosis. This group of patients has pretty much been excluded from every prospective study done so far, and the mortality remains between 50 and 60% at 3 to 4 months from diagnosis. So this is a really important data set. And what they have been able to show was that even within this data set, they are getting CRs and VGPRs, and their overall survival at 6 months is 63% with a 12-month survival of 50%, which is pretty remarkable when the median survival in most series, including the one from our center, is about 4 months. So single-agent Daratumumab, no chemotherapy, I think would be an important regimen for patients with very advanced cardiac amyloidosis. What about patients with relapsed disease? We presented this paper recently where we looked at responses to relapse. You probably heard in myeloma, and we think about this in every other malignancy, that the percentage of patients who get deep responses after second line, third line, fourth line treatment keeps on dropping in every further line. Patients with AL, we have to remember, don't have myeloma. They have an NGUS or at best smoldering myeloma. And what we saw to our surprise was that within our series of patients, the responses to second line and third line, particularly combined CR-VGPR rates, were reasonably and broadly similar without a significant drop-off. And what was striking and also slightly saddening was that the overall survival from the start of each line of treatment was fairly similar. So patients continue to die at relapse, but it isn't that the survival curves are worse after relapse. They're very similar to how we see it at diagnosis. And we can take away a positive message that patients with relapse therapy do well. And we can also take away a cautionary note. We still see cardiac deaths at relapse, and therefore we must treat these patients early. Of course, Daratumumab is an important agent in relapse amyloidosis. I don't need to tell you this. This data has been presented many, many times in different meetings. But in relapsed AL, single-agent Daratumumab or combined with bortezomib, we're seeing response rates of 70 to 80%, and certainly has an important role in patients who have not been treated with frontline Daratumumab. I've presented this slide before. Venetoclax is a targeted therapy for amyloidosis. In 2020, we published this paper looking at 43 patients with venetoclax, single agent or with bortezomib, showing responses of 78% CR or VGPR and 41% CRs in patients treated with single agent venetoclax or with venetoclax bortezomib. Very similar data also reported from the Mayo Clinic group. It's a really well-tolerated agent in amyloidosis. As yet, we don't have any prospective studies, which is a bit sad, but we hope we'll have some prospective trials. But we do believe that this has an important role in patients with AL with T1114 translocation, either alone with dexamethasone or with bortezomib and dexamethasone. This is a new agent for myeloma treatment that you've probably heard of in the previous sessions, belantamab, anti-BCMA conjugated with a toxin. And this has been looked at in AL amyloidosis. This was one of our first patients treated with belantamab, previously treated with multiple lines of treatment, including isatuximab Pomdex as 4th line, belantamab single agent as 5th line, and patient achieved a rapid and deep complete response within 3 doses of belantamab and remains in a sustained CR over the last year. We've got a phase 2 EMN study that is ongoing, and data was presented on 6 patients from an American group looking at belantamab with median 6 prior lines of treatment. Majority of these patients had multiple myeloma. They were able to see responses in 5 out of 6 patients, with 3 out of those 6 patients achieving a complete response. Certainly in our hands, this agent is being very well tolerated in amyloid patients, but corneal toxicity still remains a very significant issue, and we need to learn how to use this agent properly if we are to use it for amyloid patients. The real key in amyloidosis is to improve organ responses. CAEL-101 is one of such antibodies which was recently published in Blood. It's an antibody targeting amyloid fibrils, developed initially against kappa light chain fibrils, but then realized it also targets kappa and lambda light chains. In this paper that they presented at Blood, this was the data from the phase 1 study, showing that patients given single dose of this antibody had good cardiac responses, and a significant number had marked improvement in proteinuria, showing 67% cardiac responses, and a third of the evaluable patients had renal responses. And a small further study was presented by Jason Valent. These were about 10 patients who had been treated on a phase 2 trial. Induction therapy was with either VCD or Dara-VCD, and he reported renal and cardiac responses in these patients. And within the best renal response, you can see that at least half the patients show reduction or significant reduction of proteinuria. From cardiac perspective, a number of patients show modest changes in the NT-proBNP, but it's still quite early in this study to know what this drug is doing, and we await further assessment of this agent in the phase 2 study. 2 phase 3 trials are ongoing with this drug, one looking at CAEL-101 and placebo in patients with the very advanced cardiac patients, the so-called Mayo stage 3B patients, and another in the stage 3A patients. These studies are open across multiple centers globally. And if this antibody does show its promise, as we've seen in the phase 1 trials, then certainly for the first time, we may have something which helps us to clear the amyloid fibrils earlier. So to conclude, the interest in AL amyloidosis has increased. Certainly, we are seeing more research articles in AL, but diagnosis is no easier. Differentiating between AL and wild-type ATTR is becoming an increasingly frequent problem. It's important to get this correct. We have now even got a small number of patients where we have got both types of amyloid in the same patient, and therefore typing is going to become more and more important as we start diagnosing greater numbers of patients with wild-type ATTR. We've got new staging criteria and response criteria, both for baseline assessment and stratification, as well as figuring out which patients have achieved a response and then how to characterize and track these responses, both from a hematologic response perspective, as well as an organ response perspective that will allow for better patient selection and better treatment selection. There is no doubt that Dara-CyBO-D has shown deep responses in newly diagnosed AL, translating to organ responses. Single-agent Daratumumab appears to have activity in patients with advanced stage AL amyloidosis and appears to be tolerated enough. We await the final results from this study. Venetoclax remains an attractive agent, and we hope we'll be able to study this prospectively. Belantamab may have role in patients with relapsed disease. We are seeing new imaging techniques which will allow us to both see how much amyloid is there in the patient, but also track what's happening to those amyloid deposits in a different way. Antifibril antibodies, we have been around for a long time. I presented lots of different studies. We've had some negative studies, and further studies are ongoing. We have to wait for the phase 3 studies, given that we have previous negative studies. Main thing, early diagnosis, still very, very important. Patients present with advanced disease, still remains problematic as ever. And do think of amyloidosis in patients with MGUS or patients with unexplained multi-system disease with a monofocal gammopathy. Think amyloid is my last 2 words. Thank you all very much for listening.
Thank you, Professor Ashutosh, for that lovely update on amyloidosis. We have the Indian colleagues here who will be likely to ask you questions. I can start the same by asking you first question. So will you feel that DARA-based treatment is probably the best upfront treatment for a newly diagnosed AL amyloidosis?
I think we are now getting to the point where I would agree that Daratumumab-based treatment should be considered as frontline treatment for patients with AL amyloidosis. I think the data from DARA-VCD, certainly in patients from stage 1 to stage 3A, is very, very clear. The stage 3B patients were not included in the study, in the Andromeda study, and bortezomib can be quite challenging to use in the 3B patients. So if you have a 3B patient, then single agent daratumumab may be the way to start, with adding bortezomib a month or 2 down the line when the patient's a little bit more stable. But yeah, I do agree that DARA would be considered as frontline treatment where accessible.
Right. The second question I have is there a place for maintenance DARA?
That's the one that we don't know the answer to. So the study did go on to give maintenance DARA for 2 years in patients, and responses deepened in about 8 to 10% of patients who receive maintenance DARA. The 2 issues with maintenance DARA are that there is clearly a risk of ongoing infections because of persistent immunosuppression with maintenance DARA. And then we are really not sure if we need it, because when we looked at our data with VCD, patients who got a CR or a very, very, very good partial response with low light chains, even just 6 cycles of VCD, patients didn't relapse for 4 or 5 years. So clearly, just 6 cycles of VCD in these patients was good enough. Now, if you get a CR or a deep CR with DARA VCD, are we going to delay the relapse by how long with maintenance DARA for 2 years? There is a significant expense to this therapy, and there is a risk of complications. So I think for patients who have less than 10% plasma cells, who achieve very deep light chain responses, the role for maintenance DARA is not proven beyond doubt. But then patients who have more than 10% plasma cells, we know that these patients relapse early, and we've got a separate paper which we'll hopefully see very soon, that patients who relapse within 2 years have much worse outcomes, and majority of these patients have high light chains at presentation. And I do think that maintenance DARA will have a role in patients with high light chains or higher plasma cell burden. The patients are edging more into the myeloma range rather than just the pure MGUS range.
Thank you. I don't see any raised hand sign as yet. I'll take question from the audience. Is there a role of renal transplant in AL amyloidosis if they don't show renal recovery after the medical treatment?
Yes, there is definitely a role for renal transplant in patients with AL amyloidosis. We have recently compiled a global series of just about 280 patients who have had renal transplants across all the amyloid centers. The renal graft survival is excellent, and very, very few patients have lost the graft because of recurrent amyloid. The biggest challenge is cardiac involvement and autonomic neuropathy. And patients who have a complete response before renal transplant seem to have the best outcome after renal transplant. So we certainly within our center have got a very clear policy that patients who go in for renal transplantation should have achieved a CR or a near CR before transplant. They should not have significant autonomic dysfunction, and we will do a series of cardiac tests to ensure their cardiac fitness for transplantation.
Thank you. Pankaj, your question.
Thank you, Dr. Ashutosh, for the lovely lecture. So my question actually is regarding the duration of therapy. Let's say the light chains, they do not normalize, but they are on a decreasing trend. So would you continue VCD or DARA VCD regimen, and how long would you like to continue? And many times, what the problem which we face is the organ response kind of is not there. Proteinuria, if it is persisting 11 grams, 8 grams, So, it's sometimes very difficult to convince the patient that, the organ response may take a little bit more time, but your light chains have normalized. So we want to stop the medicine. So one is the duration of therapy, how long to give if the patient is responding. And the second, role of maintenance therapy if we are not giving DARA, let's say VCD regimen, especially in those patients who still have organ dysfunction which is going on.
Thank you, Pankaj. Good to see you again. I think you've asked some very, very important questions there. So I think if the patient is responding, what do you do with treatment in an ongoing basis? What I tend to do is look at the trajectory of the light chains. If the light chains are dropping every month, then it's worthwhile carrying on the treatment because you know that the patient will reach a complete response. If the light chains are reaching a plateau, then there is probably no great advantage in continuing treatment for too long, because all that happens is you will simply accumulate side effects from the treatment. Now, in patients with persistent organ dysfunction, renal or cardiac, I think it's becoming increasingly clear that you need a true light chain CR. So the light chains, they involve light chains within the normal range or less than 20, or a DFLC of less than 10. I think pick any of the criteria you like. It doesn't really matter. They all seem to do exactly the same. And if you're not reaching that, if, for example, the light chains are 40, I would actually change therapies or add something to achieve the patient or get the patient to a CR rather than persisting with the same treatment. And the question of organ dysfunction is extremely difficult because from a patient perspective, it is incredibly frustrating that they have undergone 6 months of chemotherapy or 8 months of chemotherapy, and they're actually feeling rough and they're feeling worse than when they started. And there isn't an easy answer till we get antiviral antibodies. And one thing we do with all our patients is we kind of emphasize this to them at every single time we see them, that the heme response and organ response are two completely different things. And our therapy is not directed by your organ response. It is directed by the blood response, and it's tempered by the organ response. So if you see worsening organ function, we might add therapy or change therapy. But if we don't see organ function, but we see a really good response, we are not going to persist with treatment because they all end up with side effects after a while. And it's often very difficult to reassure the patient that, after stopping treatment, you're not going to relapse within a month and everything is going to get worse. But I think that is really a challenge. And we start by telling patients that, you're going to start off on treatment, you're going to feel a lot worse than what you feel now for the next few months, but then you'll start to feel better as we kind of withdraw treatment. And that at least prepares them that, they're not going to start feeling better within 2 months of starting therapy.
And do you, feel that any role of maintenance therapy? So
with VCD, we don't do maintenance because I just think the patients get really bad side effects. I mean, you can in an occasional patient, but for vast majority, I just stop. And certainly in the UK, a median number of cycles of VCD is about 5. With Daratumumab, I think we just had the discussion with Professor Agarwal about the pros and cons of maintenance. And lenalidomide, we don't tend to use an amyloid because the kidneys often get worse with len. So it's quite a challenge to use len as maintenance. So at the moment, I think there is a debatable role of maintenance in amyloid. The main question for me is that patients, if they get better, there will be a role for a transplant. And that sort of ends the treatment. So you give them VCD, their kidneys get better, you transplant them 6 to 8 months later, and then you can leave them off therapy. And that's certainly a way of treating these patients, and probably in this era of sort of a very, very expensive treatments, then that becomes quite cost effective.
Thanks. The other related question is, let's say the patient is on DARA VCT, achieves a good complete response, and the patient is receiving DARA maintenance. Do you still think a role of auto transplant in these patients?
That is one thing for which we've got no data whatsoever. What we have certainly done here in our UK patient cohort is patients who have presented with more than 20% plasma cells at diagnosis, we have gone on to transplant them as we would transplant the myeloma patients. Patients who presented with less than 10% plasma cells, we have elected that, we would harvest your stem cells but not transplant you in a CR because there is a risk of mortality. And then for patients between 10 and 20% plasma cells, I'm not entirely sure what one does. And we've gone on a case-by-case basis. So patients who had a really rapid response, who went into a CR within 1 month, we have kind of taken the view that you've got very sensitive clone. We may not need to transplant you, but patients who have taken 5 or 6 months to get to a CR, we would suspect that there is a degree of resistance to the clone, and we've gone on to transplant them. And I think MRD may have a big role to play here. So if you could document that the patients were MRD negative, there's probably no advantage of transplanting an MRD negative patient. But if the patient was MRD positive, then there may be a role for transplanting an MRD positive patient. And I think that is the bit which needs to be explored in further sort of retrospective and prospective studies.
Right. Thank you so much. Thank you.
Dr. Ashutosh, this MRD is the flow to look at the clonal plasma cells?
That is correct. Okay. So either flow or next generation's NGS, depending on what's accessible.
Okay. What is the place of venetoclax upfront? If you documented 11-14, which is there in half the patients, I suppose.
What is the place of venetoclax upfront? No studies to guide this. But I think if you've got access to it, it's a really well-tolerated drug and the responses are very rapid. And I certainly would, you'll have to counsel the patient that there's no data for this, but in a data-free zone, I would love to use it. I can't use it in the UK because I've got no funding for it. But there certainly would be a potential for upfront venetoclax in the very advanced patients because we see responses literally within a week or 2 weeks for the 11-14 patients, even just venetoclax with low-dose steroids. And the combination, which is very attractive, is Dara-venetoclax, which is a very low toxicity combination.
There's a question that patients who cannot tolerate Velcade, what's the best alternative? Can we use carfilzomib?
You can use carfilzomib. We published a paper a couple of years ago on carfilzomib in neuropathic patients, and we'll just publish our prospective phase 1 study of carfilzomib thalidomide dex. We would be wary of using carfilzomib in patients with ejection fraction of less than 40% or patients with a GFR of less than 30 because we do see renal toxicity with it. We tend to use carfilzomib once weekly for amyloid patients when we use it. We never use it twice weekly, and then we go very, very slow with dose escalation. So we'd start at 20 milligrams per meter squared and then go to 27 milligram per meter squared. And then if they're tolerating it, go up to 36 milligram per meter squared and assess the response in the background. We also find quite interestingly that it's really well tolerated by the neuropathic patients because of the lack of peripheral neuropathy, but also because of its significant side effect of hypertension. Patients with autonomic neuropathy, their blood pressure really improves quite remarkably when they start carfilzomib, which is quite interesting.
Right. Another question is there a role of bortezomib maintenance?
So we don't think there is a role for bortezomib maintenance in AL because of the ongoing and cumulative side effects of bortezomib. There may be an occasional patient where you think this is refractory disease or they are aging into the myeloma range where you might use it, but in general, the answer is no. I would give a fixed number of cycles of bortezomib.
Are there patients of AL amyloidosis who do not have alterations in the free light chain and where plasma cells clonal cannot be documented in the marrow?
So this is becoming an increasingly rare occurrence nowadays. And we think that in the past, when we were seeing these patients, we were misdiagnosing them. So if you have a patient where you cannot document plasma cells and you've got nothing in the serum, I would definitely make sure that the amyloid is typed by mass spectrometry before you call it as AL. The only time we see this is patients who have got amyloidosis related to Waldenstrom's or a marginal zone lymphoma, which might not be in the bone marrow, but might be in the lymph nodes or the spleen. And these are patients where the light chains are very minimally abnormal. So the kappa might be like, 18, 19, 20 in these patients. And you may find it very difficult to document a bone marrow clone. So if you have a amyloid to be of AL type by mass spectrometry and you cannot find anything in the blood, then one possibility is to try and get mass spectrometry done on the serum for light chains. The Mayo Clinic does offer this as a commercial service, both for M-band and light chains, and you may be able to detect a peak there. And we have certainly treated this patient on the assumption that they may have a WM-like clone in the lymph nodes and with a rituximab-based regimen.
Right. One question is macroglossia still seen in AL amyloidosis or it's a late finding?
It's absolutely seen in amyloidosis. It's seen in about 15 to 20% of patients. It is a late finding, but some patients will present with that as their first symptom. But yes, it's late finding because these patients' diagnosis is missed.
AL amyloidosis with a plasma cell clone of MGUS or smoldering myeloma, does it make a difference in the outcome?
It does. Patients who present with an MGUS clone, so bone marrow plasma cells of less than 10%, have much better outcomes than those with 10 to 20%, than those with plasma cells of more than 20%. There are 2 or 3 very nice papers on this from the Mayo Clinic group who have looked just at the plasma cell percentage and outcomes. And I think one of the things which I'm trying to emphasize is that we are always focused on amyloid on how badly the organs are damaged. But we also need to take into consideration what their percentage clone was at baseline and modulate our treatment based on the clone. As we discussed with Pankaj a little bit earlier, if they have more than 20% plasma cells, you may be more inclined to transplant these patients after induction therapy than patients who have less than 10% plasma cells, for example.
What is the prognosis of patients having GI amyloidosis?
That's a very difficult question to answer because there are 2 different ways of answering this question. Now, GI amyloidosis can occur as a part of systemic amyloidosis with multi-organ involvement, and these patients often have lots of autonomic neuropathy, cardiac and renal disease. They do very badly. Or GI amyloidosis can occur just as isolated gut amyloid with no amyloid anywhere else. So this is localized GI amyloid. And these patients actually do extremely well. A lot of these patients may not require treatment. The amyloid deposit may be in a single site. Or if they require treatment, they still do really well. They never get cardiac or renal disease apart from a very small number of patients. So GI as a part of systemic disease, not very good. GI as localized amyloid, generally very good.
And the localized amyloid is treated in the same way as AL amyloid?
So localized amyloid is treated very differently to AL. So if the localized amyloid is not causing symptoms, we wouldn't treat it at all. Now, if it's a single deposit, then you may even ask your surgical colleagues to try and remove it. Or if it's say tracheobronchial, you can get a bronchoscopy and laser that deposit away. But if it is at a site which is amenable to radiation, then radiotherapy is probably a best treatment. Only if the patient is not suitable for surgical resection or radiotherapy, then I would consider the patient for systemic chemotherapy.
Dr. Khungal, your question.
Yes. Excellent lecture, sir. I just want to ask, what is the cause of primary amyloidosis? Have we some genetic alteration?
You have come to the crux of the matter immediately. A question that I really cannot answer because it's basically unstable light chains, and what we don't really know is what makes those light chains very unstable. What is the predisposing genetic alteration which causes the instability of light chains as compared to a myeloma or an MGUS patient? We've done a lot of studies. We did a big study looking at genomics in about 1,500 amyloid patients, looking at next generation sequencing with whole genome SNP assays, and we were unable to find any associations. We have also done NGS whole genome sequencing, and all that happens is that the plasma cells segregate with MGUS and nothing else crops up. So either it's just a random event, or it is something that we are looking in the wrong place. But the answer is no one knows.
Another question, sir. In your experience, have you reached the cure with high dose chemotherapy and stem cell transplantation? Have you reached the cure in some patient?
So probably not is the answer, to be honest. I mean, the Boston group has the best experience in long-term outcomes, and they were able to look at what happened to their patients who had remained in a CR, complete response, for more than 10 years. And even within that cohort, a quarter of the patients relapsed after 10 years. So we are seeing very, very deep, very, very long responses, but whether I would use the word cure or not, I think I would still hesitate. Because we are seeing 10-year plus relapses in some of the patients after stem cell transplantation.
But secondary amyloidosis, if we treat the cause, then this will definitely help.
So in secondary amyloidosis, AYA amyloidosis is very different because if you control the underlying cause, then of course the amyloid deposits will not come back. But that's a very different condition to AL amyloidosis in terms of what happens. But also in secondary amyloidosis, even if say the amyloid was secondary to rheumatoid arthritis, any inflammation will cause worsening. So we've had patients with rheumatoid who have actually done extremely well. The amyloid's gone away, rheumatoid's kind of gone into remission. they get a bad pneumonia and amyloid comes back within days. So, it's important that even in secondary amyloid, it never really goes away.
Thank you.
Thank you. One question has come up is there any place left for oral melphalan-based therapy in place of cyclophosphamide?
So I think simple melphalan dexamethasone probably has a very limited role. We only use it in, say, the very frail patients who got bad neuropathy, who we think are not candidates for bortezomib because we can't access things like daratumumab frontline. We use melphalan. But I think as it is melphalan dex or melphalan pred, probably very limited role because the deep responses are very small. The phase 3 study of melphalan dex bortezomib certainly was very promising. And whether there's a role for DARA, melphalan, bortezomib dex, remains to be answered. But I think DARA VCD seems to be very well tolerated. So certainly that's our favorite.
Any data on bendamustine?
Bendamustine is very useful in IgM amyloidosis, Waldenstrom's related amyloidosis is certainly the first-line treatment of choice, rituximab bendamustine. In patients with plasma cell related AL amyloidosis, I think a very small role for bendamustine because it's, we often use it as third, fourth, fifth line and the responses are very, very poor.
Do you still use doxycycline?
Do I still use doxycycline? We still use doxycycline. There was a phase 3 study which came from a Chinese group which showed that there was no benefit of doxycycline compared to placebo. So I think the role of doxycycline is now a lot more questionable. We still think there may be a role of it, particularly as it will prevent infections. And it still remains in a gray zone, but I would certainly have a very low threshold for stopping if the patient doesn't tolerate it, now that we've had a negative phase 3 study.
The question is about the diagnosis of localized amyloidosis. It is by the usual amyloid documentation or there is a plasma cell infiltration there?
No, it's almost always by documenting the amyloid deposits. You can see infiltration with plasma cells often in the deposits themselves, but it's very hard to prove that because the numbers are very small.
Do you reduce melphalan dose to 140 if there is GI tract involvement, even if creatinine clearance is normal?
We have pretty much stopped doing MEL 140 transplants for amyloid patients now because we think that the deep responses and certainly the data from both the Mayo and the Boston group suggest that the outcomes are much inferior with melphalan 140. Now, if patient has got GI involvement, we tend to keep their platelets high. So during transplantation, we'll aim to keep their platelets above 30. We'll normally do stool local blood for 3 times before we take the patient for transplant, just to make sure that they are not bleeding actively, and they'll get intravenous high dose PPI during the transplant, but we don't cut the melphalan dose.
Paraproteinemic neuropathy, how do you approach and what is the long-term treatment?
So paraproteinemic neuropathy is quite difficult. So we've got different groups. You've got IgM-related neuropathy, which is quite separate, which is very straightforward. So you can have an anti-MAG neuropathy, or you can have direct IgM-related toxicity or cryoglobulinemia-related neuropathy. And then you've got paraprotein IgG, IgA-related neuropathy, where if you've just got a low-level paraprotein and neuropathy isolated, then often the relationship is much more tenuous. The neuropathy may not be directly due to the paraprotein. If it's amyloid neuropathy, then you'll almost always have something else going on in that patient. So these patients will have GI, autonomic, renal, cardiac, or something else. And if we are really struggling, we often have to undertake a nerve biopsy to prove that the neuropathy is due to amyloid deposits. And that we will undertake that if the neuropathy is significantly progressive. And then the last neuropathy, which is important in this setting, is POEM syndrome, where you've got lots of other changes. So I think paraprotein neuropathy is a very complex question, but if you've got an MGUS, so a very low-level IgG kappa paraprotein, and a neuropathy which is not progressive, a bit of tingling numbness in the feet, I would be very circumspect in attributing the neuropathy to amyloidosis, especially if the patient has underlying diabetes or spinal canal stenosis. Often the neuropathy is because of something else.
The IgM related will be treated by rituximab?
So IgM-related neuropathy will be treated by rituximab, or even we tend to treat it with rituximab bendamustine because I think getting a complete response is actually really important. And therefore, the data with single-agent rituximab are slightly mixed because these patients only get a modest response with single-agent rituximab.
What is the management and treatment of amyloid arthropathy?
So amyloid arthropathy is very uncommon in AL. So pure amyloid arthropathy. We often get amyloid arthropathy in patients with dialysis-related amyloid, which is beta-2 microglobulin amyloid. That's the commonest cause of dialysis-related amyloid arthropathy. And there is no good treatment. I mean, it's incredibly steroid responsive. So a 5 milligram or 7 milligram prednisolone dose will often get rid of the symptoms. And miraculously, it disappears after renal transplantation. So it's clearly something to do with the way dialysis clears beta-2 microglobulin. So there isn't a good treatment for amyloid arthropathy, but steroids do help in symptom control. And you have to question the type of amyloid when you get amyloid arthropathy.
In patients who cannot tolerate bortezomib, can we use reduced dose bortezomib?
Yes, absolutely. So we would consider starting it at 0.7 milligrams and then gently escalating it. And we often start small and build up rather than start high and build down. Because if they get severe side effects, you end up in interrupting therapy. So if you're not sure that the patient will tolerate, please start at a small dose and then gently escalate it.
So those are the questions in the question box. Anyone here wants to ask anything more?
Yes.
Yes, go ahead.
So I just want to ask, is there some coagulation abnormality which we can see in amyloidosis, some specific coagulation abnormalities for amyloidosis?
We do indeed. So the specific one is factor 10 deficiency. That's an acquired factor 10 deficiency is very classic for AL amyloidosis. The factor 10 adheres to the amyloid fibrils and therefore disappears from the serum. And these patients tend to have a lot of amyloid, particularly in their liver and spleen. They tend to bleed. So for me, factor 10 deficiency causing amyloid is a characteristic coagulation abnormality. And the other end of the spectrum, patients who are very severely nephrotic become very prone to thrombosis because they lose antithrombin 3 in the urine. So there is a high thrombotic risk in patients with severe nephrotic proteinuria. And the biggest challenge is if you have a nephrotic patient with factor 10 deficiency, you're having both the procoagulant, anticoagulant effect at the same time, and you have to figure out which one is causing the patient's more problem. Particularly when you're using an IMiD-based therapy, question often arises, what do you do with this patient? Do you anticoagulate the patient? Or do you give a procoagulant to the patient because the patient is bleeding, and it's very case-by-case basis. So amyloid patients can range from prothrombotic to a bleeding tendency. And the bleeding tendency can be because of factor 10 deficiency, but also because of, say, physical amyloid deposits in the gut, which may make the patient bleed.
Thank you.
Except doing bone marrow for MRD detection, during the follow-up of a patient of amyloidosis, do you ever do any organ biopsies?
No, because they are only useful for documenting amyloid. And the only other time we do an organ biopsy is if we think there's a secondary, particularly patients with renal amyloid, we often occasionally find a secondary renal cause, which is causing proteinuria. So a patient with renal amyloid, normal light chain, suddenly develops new proteinuria, where there isn't evidence of relapse in the serum, we may consider a second renal biopsy because occasionally these patients can get unrelated glomerulonephritis. But if they're relapsing, then we wouldn't biopsy them again.
For the nerve biopsy to document the connection, it's always a sural nerve biopsy, or you go with the nerve conduction studies?
So we start off with nerve conduction studies, and we'll do all the other things, including, say, lip biopsy, abdominal fat aspirate, to see if we can bone marrow, to see if we can document amyloid in any of these other biopsies. And only if everything else is negative, then we would consider a sural nerve biopsy, because the patients are, of course, left with a numb foot after the sural nerve biopsy. So it's really important that you choose the correct patients for a nerve biopsy.
Right. Any other question? Okay, so in that case, Dr. Ashutosh, thank you very much for being with us. Very, very important lecture and very, very interactive question answer discussion. Very, very helpful to everybody. Large number of students, postgraduates, trainees have attended this lecture from, as I mentioned to you, from almost 15 countries. And I'm sure the care of amyloidosis will be much superior from tomorrow. Thank you so much.
Thank you for the kind invitation. It's a pleasure to be there.
I look forward to see you in Mumbai.
Thank you.
Thank you.
So friends, we have a little gap. The next session will start at 3:25. So we have a break of 20 minutes. 3:25 we log in for acute lymphoblastic leukemia by Dr. Ajay Vora. 3:25. Bye-bye.
Good afternoon, colleagues. I'm Dr. Arvind. On behalf of organizing team, I would like to welcome each one of you for today's session on the occasion of Best of American Society of Hematology meeting, which is organized under the guidance of Professor B Agarwal, sir. He doesn't need any introduction. He's the president of Mumbai Hematology Group. He has been the professor and head of department at Bombay Hospital and consultant Leelavati Hospital and Bridge Candy Hospital. He's a gem of a person, and we are really grateful for his guidance to put together such an academic program, which I'm sure will benefit to the medical fraternity in India as well as in abroad. And today we are touching upon a very interesting topic of childhood and adolescent associated ALL. So with this and without a further ado, now I invite Dr. Professor B Agarwal, sir, to take us through the meeting proceeding. Over to you, sir, and thank you so much for your guidance.
Thank you, Dr. So this is the third lecture of the day, second in the post-lunch session. It's on childhood and AYA Acute Lymphoblastic Leukemia. The speaker is none other than Professor Dr. Ajay Vora. He has been our speaker in the webinars in last 1.5 years. He was also our faculty in Mumbai at a couple of occasions, and of course to the pediatric hematology oncology group in India. He has been a friend, colleague, philosopher, advisor for last 25-30 years. And he has been with this group all the time. His formal introduction: he is a consultant pediatric hematologist at Great Ormond Street Hospital, London. His daily practice involves the care of children with a variety of malignant and non-malignant hematological disorders. He has a very special interest in childhood leukemia and cord blood transplants. He is chair of the UK NCRI Childhood Leukemia Subgroup and IBFM ALL Committee. He is chief investigator of the current and previous frontline childhood and infantile ALL clinical trials and is involved with several research projects in these areas. He was program director of the Trent Regional Pediatric Hematopoietic Stem Cell Transplant Services. He has taken a lead role in the clinical trials in childhood ALL and hematopoietic stem cell transplantation nationally and internationally. He is chief investigator of several national and international phase 3 clinical trials and principal investigator of over 20 trials. He has 150 peer-reviewed publications and is editor of a book on childhood ALL brought out by Springer. He received GG2 Award for Innovation. This award recognizes exceptional contributions by British Asians to the arts and sciences. He also received Anthony Nolan Supports Award in recognition of services to bone marrow transplantation. I'll stop with this and request Dr. Ajay Vora to take over.
Thank you, Dr. Agarwal, and for that kind introduction, as well as for inviting me to give a talk at this prestigious and very popular seminar. So, can you see my slides?
Yes.
Let me go to start. Okay, can you see the full view now?
Yes.
Yeah. Okay, so thank you for submitting your questions in advance, because I was conscious of the fact that you've had a talk by David Tichy just last weekend on a similar topic, and I didn't want to duplicate what he may have told you, especially since he probably gave you information on some of the latest results on the topic that were presented at the American Society of Hematology meeting in December. So I have grouped the questions you submitted into these 8 or 9 themes, and I hope that the slides I've put together will give some answers to your questions. There are some questions to which I think you the audience and the faculty will know the answers better than I do, because they're very, very India-specific questions. But I hope that the information I provide might give you some guidance on the matter, rather than necessarily answer the specific question. So the first theme was the application of diagnostics and MRD for stratification. We have known since childhood ALL was found to be a curable disease that some children do better than others. Girls still do a bit better than boys. The prognosis is inversely related to the white cell count, and B lineage still do better than T lineage. We know that infants continue to have a very poor prognosis. Those between 1 and 10 years of age have a better prognosis than older children and young adults, although the association between age and prognosis, as is the association between white count and prognosis, is linear. We use categoricals such as white count of 50 and age more or less than 10 for our stratification purposes, but ideally we should use these two variables as linear variables, and we have developed a formula recently in the UK where every unit increase in age or white cell count factors into a specific stratification for that particular child based on those two variables. We also know that cytogenetics influences outcome, with those who have good risk cytogenetics, primarily V6-ROX1 and high hyperdiploidy, having a better prognosis than those who have one of these abnormalities, who have a, what for AML would consider good prognosis, whereas for ALL is considered a poor risk group. We also know that MRD at particularly too early time points in treatment is associated with outcome, and is probably the best discriminant of outcome. With those who achieve MRD low risk status, and there are various definitions for this, either negative or very low MRD at the end of induction, have a near 95% event-free survival with less than 5% relapse risk, whereas those who have persistent MRD at greater than 0.01% or higher, which particularly does not clear with consolidation therapies, have a worse prognosis. What we have also recognized recently is, and this was data that was published from a UK trial, UCAT 2003, by my genetics colleague Anthony Morman in JCO, that MRD is, the kinetics of MRD is different according to different cytogenetic risk groups, with those who have good risk cytogenetics having more rapid clearance of MRD. And the lighter the color of this, the lower the relapse rate. Whereas those with intermediate or high risk or TLL have a slower kinetics of MRD response. But more importantly, at a given MRD level, say 0.01%, and this is at the end of induction, those with good risk cytogenetics have a lower relapse risk than those with intermediate or particularly poor risk cytogenetics in TLL. One important information about TLL MRD kinetics and responses, that for TLL, your high risk subgroups are better defined by MRD at the end of consolidation than end of induction. Although you can pick a lower risk group on the basis of either negative MRD status or low MRD at the end of induction. Because TLL seems to have a slower kinetics, but at a given MRD level, at a given time point, they have a better outcome than P-lineage ALL. We've also recognized in the last decade or so that the low resolution techniques we were using, G-banding and even FISH, did not reveal the full biological heterogeneity of ALL. And there are more and more abnormalities recognized using higher resolution techniques such as SNP arrays, whole genome sequencing, and RNA sequencing. And if you use SNP arrays to identify copy number alterations, then you can refine the risk stratification based on G-banding or FISH cytogenetics into further subgroups based on the copy number abnormality profile, which have a good intermediate and poor risk outcome. And we tested this on an old trial, ALL97, and validated it on a more recent trial, UCAT 2003. And this is particularly the case in patients who don't have standard cytogenetic abnormalities, so who don't have ETV6 RUNX1 or high hyperdiploidy, or some of the poor risk abnormalities that I described before, what are called B other ALLs. And this poor risk combination of abnormalities that we have identified overlaps significantly with a set of abnormalities that have been defined by the German Italian group, IOPFM, which they call Icarus Plus. And this group is similar to what you would recognize as Icarus Plus from the IOPFM literature. So in our current trial, which is a consortium of now 10 countries, because Spain is about to join us, as is possibly Cyprus. And we are going to recruit patients up to age 45, although in the UK it will be up to age 25. Nearly 1,400, and once Spain joins, 2,000 patients a year. And there are various questions in the trial, which are randomized, in which we'll test de-escalation of chemotherapy for low-risk groups and use of targeted agents immunotherapy in the higher risk group. But an important component is the refinement of risk stratification based on the information I've just given you, such that we'll integrate MRD, routine standard cytogenetics, G-banding and FISH, as well as copy number abnormalities identified by SNP array. Although in the next couple of years, that will be replaced by the same identified by whole genome and RNA sequencing, because that provides much higher resolution than SNP array. And using this integrated stratification, we identify 4 risk groups. Very low risk are patients effectively with good risk or intermediate risk cytogenetics who are true MRD negative, so no MRD signal, preferably using an IGT-CR PCR or using very sensitive flow cytometric method, who have a relapse risk of less than 5%. Intermediate risk group, which is the bulk of the patients, nearly 70%, who can be further subclassified into intermediate risk low or high based on a combination of their copy number abnormality status and MRD at not only end of induction, but also end of consolidation, with the intermediate risk low risk group, roughly 35% of all patients, who have as good an outcome as the very low risk patients, and an intermediate risk high group, who also constitute about 35-40% patients who have an intermediate outcome with a relatively high relapse rate. And then about 5% of patients who also have a high relapse rate, but with much more toxic treatment, including stem cell transplant. And the most important purpose of this stratification is to try and capture as many of the potential relapse cases into this group in whom we're going to test a novel agent, inotuzumab. So these are the randomizations, de-escalation for the low-risk groups, inotuzumab for the intermediate risk high, addition of a TKI for ADO class, and we'll come back to that. And then trying to replace stem cell transplant with CAR T for the very high-risk group to avoid the acute and late toxicity. And there have been several questions about indications for transplant. Again, this is what is relevant in the context of this Altogether trial and the UK. But you can see it's a very small subgroup of patients who will be tested for transplant who have high-level MRD or very poor risk genetics. This TCF3, HLF, D1719 have a very poor prognosis with current treatment. And regardless of their MRD status, they would have an indication for transplant or CAR T. And then MRD greater than 0.05% at the end of consolidation in patients who are NCI standard risk, because for NCI high-risk patients with age greater than 10, Wechalekar more than 50, who are MRD greater than 0.01% at the end of consolidation, we have a trial called Cassiopeia in the international trial testing the Novartis Kymriah product to see if their outcome can be improved or is similar to that with transplant, but avoiding transplant in the 40 to 50% of patients where CAR T provides definitive treatment. The MRD thresholds are slightly different for T cell compared with B cell, and most of the older patients, and this is relevant for the audience who treat AYA, where the young adults who are induction failures would have a transplant, whether it's B or T cell, regardless of subsequent response, whereas the under 16s, even if they have induction failure, would only have a transplant if the end of consolidation MRD is greater than 4.05%. There have been lots of questions about management of TLL and lymphoblastic lymphoma. And this is from a review that one of my trainees published with David Tichy, where they compared the treatment approaches in North America versus UK. And the main difference is that whereas in the US, based on the results of a legacy trial 0434, they now give the larabine in consolidation, then subsequently delayed intensification and maintenance, total of 6 cycles, to all patients with TLL and TLBL. In the UK, the larabine is only used for patients who are induction failures or have persistent MRD mid or end of consolidation, which will be the case for the Altogether protocol. We have always used complete C-methotrexate, and we'll come back to that when we're talking about CSF-directed treatment. Whereas in the US, they did a trial comparing high-dose methotrexate to Kapitsi and found, paradoxically, that Kapitsi was better. So they now had gone back to using Kapitsi methotrexate. And finally, although their standard induction steroid is dexamethasone now, in the 0434 trial, they did a randomization of prednisolone with dexamethasone and found dexamethasone to be more effective. Whereas in the UK, we used dexamethasone as our standard induction steroid for the last 20 years. Now, this was the results of a successor to the 0434 trial that were presented at ASH, and David Teachy might have referred to them, looking at the benefit of bortezomib given in consolidation in combination with chemotherapy, in induction in combination with chemotherapy. And there was no benefit in the overall trial population, but there appears to be a statistically significant benefit for patients with TLBL. So in answer to some of the questions about how to manage LBL and how do you manage particularly patients who are refractory at the end of induction, and remember the definition of refractory LBL, particularly on the basis of assessment of the solid tumor element, usually a mediastinal mass, is that they have to have less than 35% reduction in the size of the mass. So it's fairly high bar, and very few patients in our previous trial, less than 1% of patients are refractory on the basis of that definition. Finally, on the topic of T, there were questions about early T precursor ALL, which was originally identified on the basis of gene expression signature, but has a particular phenotype of being CD5 weak, having aberrant expression of CD13 and 33, 34 positive. And it has an overlap in its genetics with T myeloid mixed phenotype leukemia. So it's important to try and distinguish between the two. The most important means of distinguishing is that the myeloid aberrant expression should not include myeloperoxidase. If it does, then it's T myeloid. If it does not, or doesn't have any monocytic specific expression, then it's ETP. And we were the first to publish that ETP has a higher rate of induction failure compared with non-ETP, but those who achieve remission have the same event-free survival and relapse rate as non-ETP. Yeah, that was so. You would only treat those who have induction failure with further intensified chemotherapy, as you would non-ETP. So in that sense, your treatment of ETP is no different from that of MRD and remission stratified TLL overall. And whatever your indication for transplant, even the ETP ALLs tend to have a relatively good prognosis if you can get them into an MRD negative remission and may not need transplant. Okay, there were lots of questions around CNS directed treatment. This is the current UK practice. We give intrathecal methotrexate as our standard backbone. And at present, boys get more doses than girls. The reason being that the boys at present are getting an additional year of maintenance. They get 3 years instead of 2 years. But as of the start of recruitment altogether, we are going to give 2 years of maintenance chemotherapy to both boys and girls. And this will apply as much to patients who are treated outside the trial as to trial patients. We restrict the use of cranial radiotherapy to those with CNS3 who have not responded to the intrathecals in induction, but we've had no patients in our most recent closed trial, UCAL 2011, who fulfilled that definition. High-dose methotrexate is not part of our backbone. We did a randomization, the results of which are blinded. And at present, in altogether, we will be incorporating high-dose methotrexate. But if the results of UCAL 2011 demonstrate that standard entry maintenance or capivasertib is as good as high-dose methotrexate, then altogether backbone will be changed so that we'll stop using high-dose methotrexate. Now, the reason that most groups have stopped giving cranial radiotherapy, even to younger adults, is a high rate of CNS tumors, even with using 12 gray, and this is the ALBFM90 results, and the long-term effects on neurocognition as described by several studies, including this one from the St. Jude's Lifetime Cohort Study. And we did a randomization back in the early 90s comparing for a group who have a higher risk of CNS relapse cranial radiotherapy to IT methotrexate, and in a low risk group, IT methotrexate to high-dose methotrexate. And cranial radiotherapy appeared to have a benefit in the prevention of CNS relapse, which was offset by a slight excess of non-CNS relapses, such that the event-free survival of patients who had received cranial radiotherapy or not was similar. And therefore, we had, from that point on, stopped using cranial radiotherapy. And this is being confirmed in large meta-analysis, this one done on trials up to the early 90s, this one done on trials up to the noughties, where you can see that after the 90s, more and more trials limited the use of cranial radiotherapy to patients with CNS3 status only. And even then, if at all, patients who had had alternative CNS-directed treatment had a better outcome than those who had cranial radiotherapy. And we confirmed that in a PDL analysis that are led of more recent trials, where the only subgroup that may benefit from cranial radiotherapy was CNS3, but even they had a very poor overall survival. And therefore, cranial radiotherapy does not appear to be the answer, even in that subgroup, and we need better strategies. Now, intrathecal therapy, regardless of whether you give high-dose methotrexate or cranial radiotherapy, still remains part of all treatment backbones. And the question is, does triple intrathecal give you better outcomes than single intrathecal methotrexate? And this was addressed in an old CCG trial, 1922, which did, again, much like the cranial radiotherapy versus alternative treatment randomizations, have a better relapse outcome for triple compared with single IT, but an excess of non-CNS relapses such that the event-free survival of the two subgroups was the same, and the overall survival was statistically significantly better for patients who'd had single IT methotrexate rather than triple. And there's a lot of speculation around why that might be the case, but one answer might be that, in fact, what you're doing with triples is you're deferring what is eventually going to turn out to be a marrow relapse by suppressing it in the CNS. And therefore, because marrow relapses, especially combined with CNS, have a worse outcome after relapse than isolated CNS relapse, picking up the CNS relapse early before the marrow relapse occurs might obtain a better salvage. Then there are questions about high-dose methotrexate. As I said, we did a randomization of high-dose versus intrathecal methotrexate, and again, similar theme, slightly better CNS outcomes for high-dose methotrexate, lower relapse risk, which was statistically significant, but an excess of non-CNS relapses such that the event-free survival of high-dose methotrexate is the same. We've asked the same question again in our recently closed trial, UCAL 2011, but that result remains blinded, and we should get an answer by this autumn. And we're hoping to present those results at ASH this year. Now, the COG asked the same question separately for B lineage in this trial 0232 for NCI high-risk patients. So remember, this is for patients who are aged more than 10 or have a white cell greater than 50. And they did find a benefit of high-dose methotrexate compared with capivasertib methotrexate, which was statistically significant. However, as I mentioned before, these patients received prednisolone induction, and because most of the benefit appeared to be in the reduction of CNS relapses, whether dexamethasone can do the same, and that question will be answered by the results of UCAL 2011, because as you can see in the trial we did back in the early 2000s, 97, 99, that dexamethasone is highly effective. It halves the rate of CNS relapses, more so than its effect on non-CNS relapses. Now, in TLL, they did a similar trial, 4434, which I referred to before, where high-dose methotrexate appeared to have a better outcome than capivasertib methotrexate, which was statistically significant. But this was a highly complex trial where they tested dex versus spread in induction, capivasertib versus high-dose methotrexate, melarabine or not, as I described previously, as well as giving cranial radiotherapy to nearly 50% of patients. So there are so many confounders in this trial that it's hard to extrapolate the results of this trial to other treatment backbones, including that of the melarabine randomization, which is why the UK and the rest of Europe still limits the use of melarabine to patients with induction failure. There were lots of other questions about high-dose methotrexate. We don't test for MTHFR status because we had done a small study which did not find it to influence heterozygous or homozygous status, the efficacy or toxicity of high-dose methotrexate. I know there are one or two, one Japanese study and one other, which seem to suggest that certainly homozygotes might have excess leukocytis, but we've not found that, so we don't test for that. There were questions around how much intrathecal to give in maintenance. So if you follow the BFM approach, if you give in high-dose methotrexate, the precursor don't need any further intrathecals in maintenance. But if you've not given high-dose methotrexate, it's 3 monthly. For T-cell and white count greater than 100, even if you've given high-dose methotrexate, the BFM would give 3 monthly for the first year. But if you've not given high-dose methotrexate, much like the precursor, you give it 3 monthly throughout maintenance. And then there was a question about how much triple IT to give for CNS relapse. We would give weekly with reinduction systemic chemotherapy until you've got a clear CSF and a further 2, but a minimum of 5 in induction. And then how much more you give will depend on whether you continue with chemotherapy or going to transplant. If you're going to transplant, you give fortnightly as a bridge to transplant. But if you're continuing with chemotherapy, then you'd give fortnightly during the intensification period and then 3 monthly in maintenance. Okay, so the Americans like to call it AYA. Here we call it TYA, teenage and young adults, but it's the same group, 16 to 25-year-olds. And if you look at historically the results of adult protocols, and this is UK data, versus pediatric protocols in that age group, then pediatrics protocols obtain better event-free survival, lower relapse rate. And this has been replicated by the Americans and several European groups. And it's now standard practice to use either recruit the young adults, 16 to 25-year-olds, to pediatric trials, as we're doing in Altogether, or use what's called pediatric inspired protocols, but it means much the same thing. Now, young adults do have a worse outcome, and that's primarily because they have a lower incidence of the 2 large good risk cytogenetic groups, so, and an increasing incidence of some of the higher risk cytogenetics, particularly MLL and Philadelphia, and an increase in incidence of T versus B. T is less than 10% in the under 10s, and between 10 and 15, it's about 12%, and then by the time you get up to 16 to 25, it's 20%. So it's a biological difference that makes young adult treatment more challenging and obtains worse outcomes relative to the younger children. But those outcomes have improved, as is the case for UCAL 2003, where we had 70% event-free survival, which has since been demonstrated by many other groups. And the main difference, and this is the difference in relapse rate with the 1625 having a higher relapse rate of 20%. The main difference here is that these relapses are almost invariably unsalvageable, whereas the relapses in younger patients have a good salvage, especially with the use of new agents such as targeted therapy, immune therapy, CAR-T, etc. The 16 to 25s have a less than 20% salvage after relapsing. So my young adult treating colleagues are very much focused on the outcome you get with your first-line treatment and optimizing that such that you prevent relapses. And that is why a higher proportion of patients go to transplant in that group. The kinetics of MRD response is slower in the over 16s, where nearly 50% have persistent MRD at the end of induction, and a lower proportion than the under 16s are MRD low risk. But if they obtain, so the 30-odd% of TYA patients who obtain a good MRD response at the end of induction have an excellent event survival, which is comparable to that of younger patients, whereas the patients who are MRD positive at the end of induction have a relatively worse outcome. That for the under 16s, which isn't shown here, would be approaching 80%, whereas the young adults is closer to 60%. Toxicity is also a bit higher in the older patients, but there the age threshold seems to be over 10, although paradoxically in our current, recent closed trial, UCAL 2011, the TYAs have had a very low induction TRM of less than 1%, and that is comparable to the under 10s. And the same for remission deaths, although in UCAL 2003, the over 16s had a higher TRM in remission. In UCAL 2011, that is not the case. So there has been a learning curve which has improved the management of toxicity such that it has had less impact on TRM. They do get more serious adverse events, but these are limited to thrombosis and infections. Infections, behavior and thrombosis, and avascular necrosis, which seems to be a problem primarily of the 10 to 20-year-olds, and therefore a problem of the growing skeleton. Okay, next topic is Philadelphia positive BCR-ABL or PH-like ABL class. So the context of current and future treatment is that pediatric trials of Philadelphia positive ALL have demonstrated that adding a TKI to chemotherapy improves event-free survival, but most importantly, it allows for majority of patients to be treated without a stem cell transplant. And at least although they were not randomized studies, these successive studies that have been done using imatinib or dasatinib have shown no clear benefit for dasatinib. And finally, that with the addition of TKI, there is the scope not only to limit transplantation to a small minority, but also to de-escalate the chemotherapy treatment backbone, which on the basis of MRD can be stratified just as to more or less intensive treatment or transplant, just as we do for non-PH ALL. And this is on the basis of this small study that was done on the previous SFAL COG trial reported by Gianni Cazzaniga and Hematology. And the main message here is that time point 2 MRD at a level of greater than 5 times 10 to the minus 4, so 0.05%, seems to identify a group of patients who have a poor event-free survival. And this time point is the end of consolidation. And so the current SFAL trial stratifies patients to having a transplant or not based on this MRD threshold at the end of consolidation time point. And as the trial has gone on, the a priori expectation that there will be about 15%, 15% of patients who will be stratified to transplant hasn't turned out to be the case, because with the addition of TKI early in induction at day 15, you're seeing much faster kinetics of MRD response, such that less than 5% of patients now have that level of MRD at the end of consolidation and are stratified to transplant. So the earlier you add imatinib, the better. The problem is that when you add a TKI to a very intensive chemotherapy backbone, then you have excess treatment-related mortality of up to 15% in the previous SFAL trial. And this is primarily with the so-called HR blocks, which are very intensive and even in non-pH positive ALL have a TRM of nearly 10%. So the aim of this trial is to de-escalate that treatment backbone by getting rid of the HR blocks. It is going to finish recruitment in 2024, and we won't get the results for a couple of years after that. But I'll indicate what we're going to do in the next trial, which is that we're going to treat patients with pH-like ALL who have able class fusions, which constitute about the same percentage of patients as pH positive ALL in the pediatric group. The incidence is a bit higher in the TYA patients, close to 5%, who are phenocopies, these patients with able class, in terms of their phenotypic features, their response, and outcomes without TKIs. And there have been recent small retrospective cohort studies published, including from our group, which have shown that additional imatinib improves at least the induction failure rate and the 2-year event-free survival approaching 70 to 80%, similar to that obtained by adding imatinib to chemotherapy for pH positive ALL. So the next trial will treat both these groups of patients the same. There was a question about imatinib versus dasatinib. I've already mentioned that the trials that have been done in Europe and America have shown no clear benefit of dasatinib with imatinib. But this Chinese randomized trial comparing a lower dose of imatinib, and this is important to remember, than that which is used in European and American studies, with a higher dose of dasatinib than was used in the historical American study, which was 60 milligram per meter square. Here they used 80, and consequently, possibly of this lower imatinib dose, a much worse event-free survival for the imatinib arm, and a event-free survival for the dasatinib arm, which is similar to that which we obtained with imatinib in the European, the ESHVAL and COG studies. So the jury remains out as to whether dasatinib is better. The adults would use dasatinib, and because it's no worse, and you have that as a low-cost alternative, which we don't in the UK and large parts of Europe, but if you do have it as a low-cost alternative, there's no reason why you can't use dasatinib, but if you are using it, then you should use it at this dose rather than the lower dose. The most exciting paper in Philadelphia positive, and this probably applies to pH-like ALL with able class fusion, was the study published in New England Journal by the Italian group, where they, in the elderly, they used a chemo-free backbone of short course of steroid, followed by single agent dasatinib, followed by 4 to 6 cycles of Daratumumab, and obtained 80% 2-year event-free survival. And this was confirmed in a smaller study using ponatinib with Daratumumab by the MD Anderson. And in the next trial, we're planning to test the combination of Daratumumab with a TKI, starting at day 15 of induction, and using a much less intensive induction schedule. And there have been some questions around, if you're adding TKI, what induction you should give. I would recommend that you start the imatinib as soon as you've got the result, be that at day 8 or 15. And that from that point onwards, just give your TKI with vincristine and prednisolone even, not even dexamethasone, no more asparaginase, no more anthracycline. And if you have access to blinatumomab, then we've got preliminary data in 8 to 10 patients we've treated with this strategy of TKI added at an early induction time point, de-escalation of induction backbone, followed by a couple of cycles of blinatumomab, high-dose methotrexate, DI, and then maintenance with TKI given throughout for 2 years. And so far, we've not seen any relapses. And this trial, which will start in 2024, will test that question against the standard treatment intensity backbone. There was one question about infant ALL. This is the Interfan 99 trial, in which patients were randomized to AML consolidation instead of standard ALL consolidation. There was no overall benefit for AML, except possibly in a post-hoc analysis in small subgroup patients for those who were MRD greater than 0.05% at the end of induction. Many of them had expression of myeloid markers at diagnosis on immunophenotyping, and thus providing some biological basis for why they may respond better to AML blocks given in consolidation. But the overall outcome remains poor. And so the new strategy that we are piloting in the UK is, again, with blinatumomab, 2 cycles, replacing the intensive chemotherapy. And then for patients who obtain a good MRD response, continue with chemotherapy, whereas those who don't would go on to transplant, including those with a high risk of relapse as defined in the Interfan 99 trial, which is patients who are less than 6 months of age with MLL rearrangement, with a white count greater than 300, or with prednisolone poor response. And they, regardless of their MRD response, would go on to transplant. And we're also going to test the use of allogeneic CAR-T in blinatumomab failures as a bridge transplant. There was one question about relapse, and the main message I have about relapse treatment, based on this COG study that was presented at ASH and is now in print in JCO, and also a European study which asks a similar question of replacing intensification chemotherapy with blinatumomab, which showed that blina obtained much better event-free survival, lower relapse rate in either patients who were high risk and destined for transplant, or even standard risk patients. And that's the COG study that has just been presented at ASH, which showed a benefit over standard chemotherapy, even in standard risk relapses who continued with chemotherapy. So the UK strategy is this: blina given to the very high-risk patients or high-risk patients, whether by transplant or CAR-T increasingly, and the standard risk patients just get blina and chemotherapy. There were several questions on what to do in regard to off-treatment follow-up. And there are a couple of recent studies that are validating something that I have introduced into my practice nearly 20 years ago. One is, do you need to do blood counts on a regular basis after the end of treatment? And this study, which is published in the British Journal of Hematology, I would recommend reading it, but its conclusion basically is that it's not helpful in that you rarely pick up a relapse at a scheduled visit, whether it be monthly or 3 monthly, and a blood count in the absence of symptoms. And that even that odd relapse that you pick up has no better an outcome, having been picked up at an asymptomatic stage than when they develop symptoms. And so there's no need to do blood counts of treatment. The second is this question that because we don't have a test which we can say, even with sensitive MGS MRD, that's it, there's no disease left, your child is cured. We have to rely on time from diagnosis of end of treatment. And the standard practice has been to say 5 years from end of treatment or 5 years from diagnosis. And this has been validated by us, which shows that regardless of age or MRD status, by the time you get to 4 to 5 years from end of treatment, then your relapse rate is less than 1%. And that effectively can be your definition of cure. So again, validation of what something we've always been doing, but it's useful to have that. And then similar study done by the US long-term follow-up study, which has been looking at the outcomes of patients treated in various eras over the last 40 years. And what they have found, confirming what we did, is that 5 years, the excess death rate from ALL is less than 1%, and therefore you can call it a cure at that point. The second question is, how long do you continue to follow up patients? Are you following them up primarily to be able to diagnose a relapse and start treatment at an early point? And if so, how long do you do that for? And the answer to that is possibly 3 years from end of treatment, 5 years from diagnosis, if you're going only 2 years of maintenance. And the second is, beyond that point, do you need to continue following up for late effects? And this St. Jude's Lifetime Cohort study gives you a sort of answer. If you've not given radiotherapy, and this is the one in green line, then your risk of late side effects is a lot less. And the impact on, say, pubertal development, growth, neurocognition, lifetime chances of employment, etc., all of which they looked at, muscle strength, being able to do sports, etc., seems to be approaching that of their peers. So it does raise a question mark. What kind of follow-up and for how long should you do? So this is my current practice, which is that we still do review them either at a local hospital or at GOSH for 3 years with appropriate safety netting. And that's the most important thing, is that if the child has symptoms, they can get direct access to a specialist team who can at that point do bloods, but no routine bloods, immunizations at 6 months. And then we do transfer them to our late effect service. We have the luxury of having a separate late effects follow-up service, but they are increasingly relying on just annual postcards or telephone video consultations in the absence of clinical concern rather than actually seeing them regularly. Okay, I think this is my last slide. So there were other questions around use of rituximab, for which there is no evidence of benefit in children or AYA. There was an adult study reported by the French group which appeared to show benefit in particularly CD20 positive ALL, but that has not been replicated in a study done in the UK. But on the back of the French study, it has received a license, it has received approval by our reimbursement body NICE, and so the adults are using it. So if you wanted to use it for AYA, then I don't think there's any contraindication to doing so. Only thing I would ask you to be mindful of, particularly if you're using it in young children, which I would recommend against, is that you do get prolonged B-cell aplasia and hypogammaglobulinemia, which in the younger children may be associated with an increased risk of viral infections. GCSF we don't use at all, other than the occasional patient who has particularly, say, a pelvic abscess or prolonged neutropenia with typhlitis. And even there, we're increasingly using granulocyte transfusions rather than GCSF. Asparaginase TDM is a whole topic in itself for a talk, but we're currently doing it as a research question in the Altogether study where we're measuring asparaginase levels, not asparagine depletion, pre-dose, and then adjusting the subsequent asparaginase exposure according to either silent inactivation, which is defined as having less than 100 units per mil at 1 week, and absence of asparaginase at 2 weeks after a previous dose, in which case the patient is switched to Erwinaze, or obviously if there's a clinical reaction, and particularly because if you're using the IV route rather than the subcutter intramuscular route, then you get infusion reactions which can be difficult to distinguish from the neutralizing reactions. Their TDM is particularly helpful because it's an infusion reaction will give you an optimal asparaginase level at those 2 time points, whereas in the neutralizing reaction you won't. There is an ongoing debate. What if you have serious toxicity in induction due to asparaginase, say a thrombosis, or even a neutralizing reaction? Do you really need to continue with asparaginase post-intensification? My personal view, based on limited UK data, is that you don't and you should not. But my European and US colleagues who are much more wedded to asparaginase would disagree. So I think in the Indian setting, personally, given the cost and the the drug acquisition cost, as well as the associated cost of managing toxicity, I would probably, even if there was some benefit of post-remission asparaginase, it's likely to be marginal, and therefore it's not worth incurring that cost. And I would not give it. And the same for a patient who has severe induction toxicity and therefore has missed a lot of treatment during induction. The important thing is, despite that, and this is often the case, the patients who get, especially after infection, very sick, obtain a really good MRD response at the end of induction, even though you may have had to curtail or reduce the intensity of the induction, because that infection or gut toxicity is often associated with cytokine release syndrome, similar to that which you get after Lymphoma or CAR-T, and that can obtain a good response. And we are now, as standard practice, giving Lymphoma to those patients as a bridge to sometimes not even DI, because they've had such serious toxicity during induction that we just go on to maintenance. And we have, again, got 50-odd patients nationally treated this way, and we are seeing no early relapses in that group. But if you don't have access to Lymphoma, it just depends on how severe the toxicity is. But I personally would probably just give maintenance until they recovered from toxicity, and then DI and maintenance again, and hope and pray for the best. And as promised, that was my last slide. I'll stop there. And I hope I have addressed everyone's questions, but if we have time, I'm willing to take more questions now.
Thank you so much, Dr. Ajay Vora. Yes, all those who are here, please use the raise hand sign. Go ahead. 2 questions lying in the question box. One is, how do you treat 31-year-old CML with upfront ALL blast crisis?
Ooh, so the standard practice would be to give ALL induction with TKI. So you treat it like a Philadelphia positive ALL. And again, at that age, the standard practice would be to go on to transplant once you've obtained an optimal remission. But I'm sure you, Dr. Agarwal, will have more experience of treating that age group than I do.
Same thing what you mentioned, except that if somebody can afford, then we use ponatinib, that's all.
Yeah.
The other question is role of allogenic hematopoietic stem cell transplant in pediatric and adult Ph positive BLL.
Right.
Yeah.
I think I addressed it in the current SVAL study we have, that small subgroup with MR was still MRD positive at the end of consolidation. That's less than 5% of patients.
Dr. Revati, your question.
I just want to start by saying I could listen to him all day. It was so exhaustive and so amazing. I think you took us through the journey of what we've learned over so many decades. So thank you very much.
Thank you.
Given the cost difference and how much we need to admit patients for Blina versus inotuzumab, and the availability also in India for inotuzumab, what would you recommend if you had to make a choice between these two?
So there is this misconception that inotuzumab is immune therapy and equivalent, therefore, to blinatumomab or CAR-T. Inotuzumab is not immune therapy. It's targeted chemotherapy. And the means of targeting is using an antibody. That's why it's kind of misconceived as immune therapy. And so it has all the toxicity of chemotherapy, and in addition, liver toxicity, which admittedly seems to be a problem if you use it too close to a transplant and the VOD comes after the transplant. But where we have used it, which is in blinatumomab failures, we do get excellent responses. There's no doubt about it. So the problem, though, is the toxicity, in which we have seen this mucositis and prolonged neutropenias associated with infections, some non-VOD liver toxicity. But it's all manageable. The most important concern I have is that both the adult data as well as the preliminary pediatric experiences, that it does not seem to have any efficacy benefit. And this is the difference it's important to emphasize is activity is different from efficacy. Activity is the response. Efficacy is, does it improve your chances of cure? Does it improve your AFS and relapse rate? And all the indication, both in the adult setting as well as in pediatrics, is that it does not seem to improve your event-free survival or relapse rate. Whether you give it as part of a chemotherapy backbone, which there are much fewer trials because most of the trials have been using it as a bridge to transplant. But certainly, bridge to transplant, it does not seem to have improved outcomes to the extent that NICE has not approved it for reimbursement.
Okay, Dr. Neeta.
Thank you, Dr. Ajay, for taking us through those topics, especially question by question. So I had 3 doubts. One is in adolescent population, when we treat with PEG asparaginase, you mentioned higher thrombosis rates. Do you also observe higher rates of hypoalbuminemia? Like when you follow these children, when you compare it with younger children, we see a lot more albumin coming in the range of 3 to 3.5. As long as there is no infection, it's fine. But once they get into a sepsis episode, this albumin can be tricky. So do you observe that albumin?
Absolutely. And it's a surrogate for the efficacy of PEG asparaginase compared to native. Yes. So all the excess toxicity you get with PEG asparaginase compared with native asparaginase related to the fact that it is more effective. Okay. Now, there are two problems related to the low albumin. One is in itself, it will cause a bit of edema, some patients even ascites, because especially if you're giving it in combination with dexamethasone, you get two additional problems. One is hepatic steatosis, which can contribute to fluid retention. And the second is that albumin is a carrier for dexamethasone in the circulation. If you have a low albumin, then you have more free dexamethasone in your circulation. And then you get more dexamethasone toxicity, both acute on behavior, weight gain, etc., but also in the younger adults, a higher risk of avascular necrosis if you've given dexamethasone with pegylated asparaginase. So it's a really difficult and tricky thing. Those are the two most effective combinations, but we have no way of mitigating the toxicity that's associated with that combination at the moment, which is why I said for Philadelphia positive ALL, where you have got a TKI which has been shown in several studies to improve your kinetics for MRE response, that once you add the TKI, and the earlier the better in induction, then de-escalate your induction treatment backbone. Just give Winckenpred with it. And majority of patients will still get a relatively good MRE response.
Yes. So that was my second question also. So you meant continuous TKI is kind of the most important, one of the most successful factors. So in your practice, how continuous are you able to give TKI? As in, what do you aim at?
So we continue, it's not dose dependent. So regardless of counts, we continue the TKI. We would only stop it in the case of serious infection or serious gut toxicity. And TKI added early in induction to a 4-drug backbone will cause a higher gut toxicity. You will get more mucositis, stiflitis, etc., which is why all the more important, de-escalate your treatment backbone and definitely not give anthracycline, but I wouldn't even give an asparaginase.
Okay, thank you. And regarding GCSF, do you avoid it because of the second malignancy issues or for pulmonary toxicity?
It doesn't work.
Okay.
There are lots of studies which have shown that it may, in the ML, there's some evidence it may reduce the number of febrile neutropenias, but that doesn't translate into improved infection-related mortality or long-term outcomes. And in ALL, there are no studies that have shown benefit.
Okay. Thank you.
Thank you. One question from the audience. Dr. Roshni wants to know if there is hepatic dysfunction during induction. How do you handle it?
Don't do LFTs unless the child looks green. They will all have abnormal liver enzymes. They will all have slightly raised bilirubin because of the hepatic steatosis. And we would not alter their treatment unless the bilirubin was over 50, was conjugated rather than unconjugated, and where there were other signs of synthetic liver failure, such as abnormal fibrinogen, etc. But again, be mindful of the fact that asparaginase will affect the fibrinogen.
Thank you. Dr. Ruchira Mishra, your question.
Good afternoon, sir. I just have a question. With the availability of blinatumomab for relapsed ALL now, do we think that we're going to do away with ALL-R3 or the BFM-RES protocols and move straight to blinatumomab, or do you still want to give them first and then try the blina?
So we have already, for the past 3 years, stopped using R3. We replaced it with blinatumomab. As I showed you briefly, in the standard risk relapse as a bridge to kind of DI and maintenance, and in the high risk relapses as a bridge to transplant. And I have to say the Real group is going to do something very similar in the next trial.
Thank you.
Thank you. Dr. Radhika wants to know, 13-year-old B-cell ALL, hypodiploidy on UK ALL 2003 protocol, achieves MRD negativity, and now is on entering the maintenance. Will you do transplant in first year?
No, it's a simple answer, and I showed you why. So the two things to say about hypodiploidy is the definition. Remember, low hypodiploidy is higher risk, and low hypodiploidy is defined as 31 to 49 chromosomes. In those patients, you should exclude a TP53 mutation because 50% of low hypodiploid patients have Lymphoma, germline TP53 mutation. So that's the first thing you must do. And those patients, if they obtain a good MRD response, as has your patient, then there have been two large intergroup studies, COG and the PDL group, which have shown they have a 70 to 80% event-free survival with chemotherapy. And in fact, the MRD positives who have a 50% event-free survival don't benefit from transplant. So there's no evidence that transplant is required for those who have a good MRD response or effective in those who have a poor MRD response. And therefore, we need other treatments. And I think your blinatumomab for the MRD positives might be a game changer. And we, again, used it in a few patients, or CAR-T. But transplant, either not required or not effective.
Thank you. Dr. Radhika has one more question. 16-year-old pH positive ALL, BCR-ABL becoming positive during maintenance. Will you change the TKI?
Right, so this is a complex question. So there is growing evidence that biologically there is a subgroup of patients who have Philadelphia positive ALL, but in whom you get a much better, deeper response if you measure it by flow cytometry or IgTCR than you do with BCR-ABL. The BCR-ABL is discordant to the IgTCR MRD. And often by 1 or 2 logs, significantly. And these patients, when you look at their underlying biology, may have a CML-like Philadelphia positive ALL. And it's a question that we are hoping to answer in the next trial, which is that do you treat them like CML, continue with the TKI forever and a day, or can you just stop it and see whether they relapse? And we've seen both. We've seen some patients where the BCR-ABL has stayed positive after stopping the TKI maintenance chemotherapy and haven't relapsed. And we've had some patients where the BCR-ABL is rising and have eventually relapsed over a period, sometimes of 1 or 2 years. So what I would recommend is not transplant, stop the maintenance and TKI as planned at 2 years, and then just monitor peripheral blood BCR-ABL level as you would do in CML, but only intervene if that level is rising, ignore low levels.
Thank you. Dr. Priti, your question.
So thank you for the excellent talk.
You got muted.
As a follow-up of Dr. Revti's question, what I understood from your reply is that inotuzumab is not very effective and does not help much. Is that true?
So there is a group of patients where we are using inotuzumab. One is patients who have failed to respond to the inotuzumab prior to transplant. We do use it as a bridge to transplant. You just avoid giving it too close to the transplant. So avoid giving it within 6 weeks of starting your conditioning to reduce the risk of EOD. And then we are using as a bridge to CAR T. So once you've collected your cells and you've got rapidly progressive disease, you want to bring under control, we would give only 1 or 2 doses as a bridge to CAR T.
Right.
Because you're not aiming for MRD negative status. So we are using it. And as I mentioned, in the Altogether study, we are going to test it in a randomized way against the first cycle of maintenance chemotherapy. And we'll measure the toxicity and efficacy of that. But you will have seen at ASH, there was a poster from the COG group where they're asking the same question of inotuzumab, but given as consolidation. So compared with consolidation chemotherapy, and they are already in the safety phase, first 50 patients see an excess toxicity and some deaths.
Right. Okay. Thank you, sir.
Couple of questions that you have answered is, when will you use rituximab? You have answered that. Will you give 2 cycles of inotuzumab consolidation to all CD22 positive ALLs? I think you almost answered that. So we'll go to next questions. Pediatric B-ALL with TP53 positivity, role of allotransplant.
So when you say TP53, do you mean somatic or germline? If you mean germline, definitely no transplant, you'll kill the patient because they get excess toxicity. And as I said, for such patients, we would just give blinatumomab and then not even DI, just maintenance. And we've treated 2 or 3 patients that way, and so far they haven't relapsed. But if you mean somatic but no germline, TP53 in pediatric ALL at least does not appear to confirm a poor prognosis. So we would ignore that and just go by MRD response.
Chetan, your question.
Yeah, great as usual, Dr. Ajay Vora. I had one question, and that is just a follow-up question on Neeta's question. And this is regarding your experience with ALLs who have a stormy induction. So according to your experience, because they have the cytokine release syndrome, they tend to do better. So the first part of the question is that if they are on a TKI, did I get you right?
If they want, sorry?
If they are pH positive and they are on a TKI, you would rather drop the anthracycline or the aspergillus?
So that I would do as standard practice. So once you got the Philadelphia result, and nowadays you get it by day 8, right? So you jump in with your TKI, whichever one is your flavor of the month, and you de-escalate the induction backbone, stop the anthracycline, stop the aspergillus, switch the dex to pred. Just give Vinc and pred for the next 3 weeks. Yeah, regardless of whether there's been induction toxicity. But it's more difficult in the non-pH setting to de-escalate your induction because you've got nothing else to replace your induction backbone chemo with. So obviously you're going to try your best to deliver optimal chemotherapy. But if a child falls apart with either severe typhlitis or infection ending up on ICU, then you have no choice but to just temporize and wait and see. Measure your MRD response, and you will find yourself surprised. These patients obtain good MRD responses, even with just a week or 2 of Vinc and pred. And if that is the case, then Don't worry about the fact that he's not had optimal induction. He or she has had good MRD response. Just continue treating on the basis of that MRD.
Okay, great. So in your experience, you said you have used Lymphoma, and these patients need not have any transplant because they are MRD negative, irrespective of the high risk or anything.
Correct. Okay. Yeah, you ignore the genetics, except TCF3HLF. 1719, your rare patient that you're going to see one in your whole life. That patient you treat, because we've got nothing else with transplant at the moment, but they don't seem to benefit from transplant either. So we're going to test CAR-T, and we're testing various iterations, bispecific, trispecific, allo. So we're going to try all that and see if we can improve their outcome. But at the moment, unfortunately, it's an incurable condition. But all other high-risk cytogenetics, you go by MRD response.
MRD response. Okay, great. Thanks.
Allied question from Dr. Amit Khurana. In which case of BALL, who is MRD negative post-induction, MRD negative post-consolidation, will you still go for stem cell transplant?
None.
Right. Dr. Abhishek Kakru, your question.
Yeah. Questions. I have a couple of patients, as you just said, they are behaving like CML. There's no disease ALL anywhere in the body, but they had a. I was following them up with a PCR, and now imatinib, and they have been on imatinib since last 3-4 years. So, is there any data to change the TKI now, or I just forget the report?
Well, it depends on what's happening to the BCR-ABL level. If it's at really low levels and it's not rising, I would even venture
it's continuously rising. It's continuously rising every 3 months.
Right. Well, then at some point you're going to have to treat it as a relapse.
Okay.
And that would involve giving more chemotherapy, a different TKI as a bridge to transplant. And we have issued some new consensus guideline on what should be a new MRD-based definition of remission and relapse. And the simple message there is you define remission as less than 1% rather than the traditional 5% based on MRD. And what time point you have that is trial specific. You can have that after HR blocks, after DI, whenever. But your definition will be less than 1%. And therefore, by extrapolation, your relapse would be greater than 1%. So don't treat a patient as relapse unless they've exceeded that 1% threshold.
Thank you.
One question from Dr. Ruchira. CD19 negative relapse. What treatment will you offer?
We're seeing the CD19 negative relapses either in patients who've been exposed to CD19 directed treatment, blinatumomab or CAR-T, and more often after CAR-T than after blinatumomab, or as part of a lineage switch. So these are patients who've got mixed phenotype leukemia, who presented with a single lineage, and then within usually 6 months of diagnosis, they present with a lineage switch, which is not just CD19 negative, but AML, or often monoblastic. And it's more patients with KMT2 MLL rearrangements and those with Philadelphia who have these lineage switches, but we have seen that in other patients as well. And so if that is the case, then you have to treat with AML, but be mindful of the fact that they have a very poor prognosis. You can't cure them.
Thank you. We have exhausted our time, but Revati, quick question.
Just wanted to ask him to, finish the session by saying what he thinks is the place of vincristine and pred pulses during maintenance in this day and age.
Sorry, yes, that's one thing that I dodged the bullet, I thought. But so the reason I didn't answer that question is that it depends what your backbone is. If your backbone is BFM, don't use it, because BFM don't use it. If the backbone is Anglo-Saxon, then we're still using it. But we've asked the question in UCAL 2011. I'm hoping to have the answer next year. So ask me the question again next year.
Thank you. Thank you, Dr. Vora, for being with us, answering the questions, putting in a hard work to prepare your presentation based on the queries. It was wonderful.
I just want to ask one more question.
Kungar, you email it to him. Okay. Bye-bye. Thank you, sir. Bye.
Thank you. Bye.
So we'll move on with our next speaker, and I'll just utilize my screen to introduce her. Our last lecture of the day is Daratumumab-based treatment of myeloma. So we have a speaker, Dr. María-Victoria Mateos. She has been with us in past in Mumbai. She has also given webinars to us during this pandemic. All of you know her very well. She's a huge name in the field of myeloma. Just to complete the formality of introducing her, she's MD, PhD. She's consultant physician in the Hematology department, associate professor of medicine at the University of Salamanca, Spain. She's the director of the myeloma program and coordinates clinical trial unit in Salamanca's University Hospital Hematology department. She also serves as coordinator of Spanish myeloma group with direct involvement in the design and development of clinical trials. She coordinated many clinical trials in elderly and smoldering myeloma that have profoundly influenced current options for treating these patient population. She's a member of IMWG, IMS, EHA, EHA, and ASH. She's published over 250 papers in peer-reviewed international journals, some of which have become key references in the myeloma field. Her articles have received 29,000 plus citations, 19,000 plus since 2015, the H index of 79 and 60 since 2015. She's associate editor of myeloma in Annals of Hematology since 2011 and has acted as a reviewer for the top journals such as NEJM, Lancet, and Lancet Oncology. Among her invited presentations, she has contributed to the educational session of EHA from 2012 till date and ASH 2013 till date and ASCO 2015 till date. She has served on the EHA's Scientific Program Committee and Advisory Board since 2013 till date and on the ASH Scientific Committee on Plasma Cell Diseases from 2015 till date. She is a counselor on the EHA board from 2015 for a 4-year mandate, member of the steering committee for the Society of Hematological Oncology, member of the IMS board, and member of the European School of Hematology Scientific Committee. This part of our webinar is supported by Janssen. I'll stop here and request her to give her lecture.
Okay, hello to everyone. And first of all, thank you very much, Professor Agarwal, for the invitation, as well as for the kind introduction. So I can imagine you can see here my presentation. Let me check if I can.
We can see it.
Okay, but I am going to try to put it on presentation mode. Oh, no. Just one moment. Oh, I am going to share off screen and I am going to do again.
Sure.
Now. Well, thank you very much for the kind invitation. And it's actually a pleasure for me to be with you once more again. And the topic is Daratumumab-based treatment for patients with multiple myeloma. And first, you can see here my conflict of interest. And in the next slide, just from the historical point of view, maybe all of you know well how important was the development of monoclonal antibodies in general, and indeed the process to produce monoclonal antibodies resulted in a Nobel Prize in 1984 for George Kohler and Cesar Milstein. You know that in 1997, rituximab was the first monoclonal antibody so far approved for the treatment of patients with cancer. And if we focus on daratumumab, maybe you know that it has been the first monoclonal antibody approved for the treatment of patients with multiple myeloma as single agent, because it's true that ilotuzumab was also approved, but in combination with lenalidomide and dexamethasone, because ilotuzumab doesn't work as single agent. And the rationale for introducing daratumumab as a monoclonal antibody in the treatment of patients with multiple myeloma is derived from the great excitement it was in order to try to find a monoclonal antibody for patients with multiple myeloma. And you can see here the surface of the myeloma cells with many different targets, and different monoclonal antibodies were developed in order to have a monoclonal antibody for the management of patients with multiple myeloma. And this is an old slide, but just to put in context how monoclonal antibodies targeting CD40, CD74, IL-6, and so on as single agent in multiple myeloma resulted basically in no efficacy. And the exception was those monoclonal antibodies targeting CD38. And you know that the first one was daratumumab, and now it is possible to have other different monoclonal antibodies targeting also CD38. Why anti-CD38 monoclonal antibodies were effective as single agent in patients with multiple myeloma, and specifically daratumumab? Maybe because of its mechanism of action. As I previously told you, daratumumab targets CD38 expressed on the surface of the plasma cells, and this is going to result in a direct anti-tumor activity because the complement cascade is going to be activated, as well as the antibody-dependent cell cytotoxicity, the antibody-dependent cell phagocytosis, as well as a direct apoptosis throughout cross-linking activity. Concerning the phagocytosis, let me share with you one of our first patients treated in Salamanca many years ago with the daratumumab single agent. It was required to do a bone marrow biopsy at the beginning of the cycle 3. And this is what we've seen at the microscope, a large cell with a lot of small cells within this. This was a large macrophage, and all cells engulfed by the macrophage were plasma cells. We had the opportunity to demonstrate this by immunohistochemistry, showing this phagocytosis in a myeloma patient treated with the daratumumab single agent. But together with this direct anti-tumor activity, you know that the CD38 is not restricted only to the plasma cells. There are many other cells that can express CD38, and this is the case for the Tregs, the Bregs, as well as the myeloid-derived suppressor cells in the bone marrow. This means that when we treat our patients with daratumumab, we are going to induce a depletion of all these immunosuppressive cells expressing CD38. At the end of the day, what we are going to have is an increase in the CD8 positive, CD4 positive cytotoxic cells, and definitely this effect is going to result into an immunomodulatory activity, contributing to destroy myeloma cells, but at the same time, this immunomodulatory activity is going to be responsible of the deepening of the responses as well as the durability of the response. And maybe this double mechanism of action is the responsible of the great efficacy we've seen with the daratumumab in multiple myeloma. What was the rationale for the introduction of daratumumab in the management of relapsed and refractory myeloma patients? First, because we realized that when our myeloma patients had been already treated and even refractory to proteasome inhibitors and immunomodulatory drugs, and not only bortezomib and lenalidomide, but also carfilzomib and pomalidomide, the outcome for this patient was really very poor, and the median overall survival was not superior to 8 or 9 months. This was the rationale for the evaluation of Daratumumab in this population. And there were a couple of clinical trials in which Dara monotherapy in patients treated with proteasome inhibitors and IMiD, and majority of the patients double refractory to both PIs and IMiDs showed how the overall response rate was 30%. The median durability of the response was of approximately 9 months, and it's true that overall the median progression-free survival was 4 months. But if we focus on those patients who responded, the median progression-free survival was of approximately 15 months, and the great benefit was observed in overall survival. Remember that the median overall survival expected for this population was around 8-9 months, and that a single agent resulted in a median overall survival of 20 months. And also, it's important to see how this benefit in overall survival was not only driven by the responders, and in this case, the median overall survival had not been reached yet, but also from those patients in which the disease was just stabilized, because in these patients, the overall survival was of approximately 1.5 years, indicating that the treatment with the Daratumumab single agent allowed to rescue these patients with other different schemes, basically based on immunomodulatory drugs, and at the end of the day, the benefit in overall survival was evident. In terms of safety profile, just with these studies in which, as I previously told you, Daratumumab was used as a single agent in heavily pretreated myeloma patients, Daratumumab was quite well tolerated. And from the hematological and non-hematological point of view, the most relevant adverse events were anemia, neutropenia, and thrombocytopenia. And these adverse events basically occurred in non-responders patients. Safety profile was manageable, and also these studies put in context how the infusion-related reactions were going to occur with the Daratumumab in the IV formulation in approximately 50% of the patients, but also it's important to note how the majority of these reactions focused during the first infusion, and majority of them were grade 1 and 2, and also manageable, and patients were able to continue on therapy. These were the first clinical studies supporting the role of Daratumumab single agent in relapsed and refractory myeloma patients already exposed to PI and IMiD, and majority of the patients double refractory. Definitely with this activity, with this monoclonal antibody as single agent, resulted into a big clinical development plan in order to utilize Daratumumab in combination and in earlier lines of therapy. And in order to support the combinations, there were some preclinical studies. And here you can see how myeloma cells from patients refractory to lenalidomide and bortezomib responded from the lysis of myeloma cells point of view to Dara single agent. But when Dara was combined with either lenalidomide or bortezomib, you can see here how there was a synergistic effect with immunomodulatory drugs and additive effect with the proteasome inhibitors. And this synergistic effect is maybe derived from the activation of the immune cells contributing to the efficacy so far reported with the Daratumumab single agent. And the rationale for these combinations was also observed in samples from myeloma patients, in which you can see here when Daratumumab was combined with bortezomib, lenalidomide, and dexamethasone, there was a synergistic effect, and more myeloma cells were eliminated. And the same was done when Daratumumab was combined with bortezomib, melphalan, and prednisone. And definitely these preclinical studies were important in order to move forward with other combinations. One of the most relevant ones was the combination of Daratumumab with lenalidomide and dexamethasone in the phase 3 clinical study POLLUX trial, conducted in relapsed and refractory myeloma patients after at least one prior line of therapy. The median number of prior lines of therapy was just 1. And basically here you can see the update of the POLUS study published in 2020, and with a very long median follow-up, you can see here how the median progression-free survival for DARAL index in the intent to treat patient population was 44.5 months, maybe the longest median PFS we've seen in a phase 3 clinical study with relapsed and non-refractory myeloma population. And if we focus on the efficacy in those patients after just 1 prior line of therapy, the median progression-free survival was 53.3 months. To look at how the hazard ratio was 0.4, and in the control arm, Lendex was comparable to the efficacy that had been previously reported in phase 3 clinical studies, with a median progression-free survival of approximately 18 months. This superiority was maintained across the different subgroup of patients, but what about patients previously exposed to lenalidomide, sensitive to lenalidomide, non-refractory to lenalidomide? The efficacy is sustained, and the median progression-free survival was of approximately 40 months. And for patients refractory to proteasome inhibitors, DARAL index worked as well, and the median progression-free survival was around 3 years. In terms of response rate as well as complete response rate, from my point of view, this was the first time we see complete response rate of almost 60% in the relapsed and non-refractory setting. And this allowed to investigate on the minimal residual disease to figure out how approximately 1 out of 3 patients treated with the DARAL index achieved MRD negative, and most importantly, some patients were able to maintain the MRD as negative over time. And you know maybe how important is right now this endpoint, and this is going to help us to identify patients with myeloma with an excellent outcome. And indeed, in the right-hand side of the slide, you can see how minimal residual disease negative is an important prognostic marker predicting, in this case, progression-free survival. Time to subsequent therapy as well as a progression-free survival too were significantly prolonged for DARAL index, and we need longer follow-up in order to see the benefit in overall survival that we will see for sure, but because of the great efficacy, because of the plenty of possibilities of rescue therapies for these patients, we don't have any data yet in terms of overall survival. Safety profile has been acceptable, and we are going to see across the different studies that when we add Daratumumab to either IMiDs or proteasome inhibitors, or even proteasome inhibitors and IMiD, the incidence of hematological toxicity, and especially neutropenia, is going to increase, especially neutropenia grade 3 and 4, as you can see here in this slide. And from the non-hematological point of view, upper respiratory tract infections as well as pneumonia are the most frequent adverse events. We can see a bit increased when we add the monoclonal antibody anti-CD38. But it's true that these infections events are usually well managed with antibiotics, and in all clinical studies, when we see what is the incidence of discontinuation because of treatment emergent adverse events, is usually comparable in both arms, as you can see here in the POLUS, and again, this is going to be reproduced across the different trials. With this data, you can imagine that the DARAL index resulted in a standard of care for the management of relapsed and refractory myeloma patients after at least 1 prior line of therapy. This combination is basically based on the treatment of patients exposed to PI as part of the first line of therapy, and definitely the patients can be LEN exposed, but definitely they have to be LEN sensitive, and this would not be a combination for patient refractory to lenalidomide. The second important phase 3 clinical study based on Daratumumab, but not focus on IMiD-based combinations, is Daratumumab in combination with bortezomib and dexamethasone. And it was evaluated in the CASTOR study. also a phase 3 clinical study in a similar population, but with a different design because VD 8 cycles was compared with the Dara VD 8 cycles followed by Daratumumab single agent as maintenance therapy until progressive disease. The population was quite comparable, although it's true that the median number of prior lines of therapy in this case was 2 instead of 1 as it occurred in the Pollux study. And you can see here how approximately 60–70% of the patients had been previously exposed to proteasome inhibitor and MID, and approximately 1/3 of the patients were refractory to immunomodulatory drugs. The addition of Daratumumab to bortezomib and dexamethasone significantly increased the progression-free survival, and overall the median PFS was 17 months, and this median PFS was of approximately 27 months when we focus on patients treated with this combination just after 1 prior line of therapy. This benefit is also observed from high efficacy in terms of overall response rate, 85%, 30% of complete response rate, and 15% of the patients with MRD negative. And in patients after just 1 prior line of therapy, this efficacy was even more evident with a 92% of overall response rate, 43% of complete response rate, and 21% of minimal residual disease negativity rate. This is an update of the Castor study just to figure out how if your patients were previously treated with bortezomib and the patient was sensitive to bortezomib, it is possible to utilize Dara VD at the moment of first relapse, and the efficacy is going to be sustained with a median PFS of 20 months. If the patients were previously treated with lenalidomide, it is possible to rescue with Dara VD, and the efficacy is going to be 21 months, but the main problem is for the refractory population to lenalidomide, because in this situation, you can see how the median progression-free survival is a bit shorter from my point of view, and you can see here how it is only 8 months. From the MRD negativity point of view, I previously told you how approximately 12% of the patients achieved in the intent to treat patient population MRD negative, and it continues being a good surrogate marker for progression-free survival. Also, a clear benefit in terms of progression-free survival too, as well as time to next therapy. And we are going to see very soon how the Castor study resulted also into a significant benefit in overall survival, and this data will be presented in the upcoming congresses. From the safety point of view, nothing different to what I previously told you, with just one difference. The incidence of neutropenia in this case is not much more higher, because you know that we are combining here Daratumumab with a proteasome inhibitor instead of an immunomodulatory drug, and we have to focus on a slightly higher incidence of grade 3/4 thrombocytopenia. Dara VD is another standard of care we can utilize in relapsed and non-refractory myeloma patients after at least 1 prior line of therapy, as I previously told you, and it is possible to utilize in patients previously exposed to both proteasome inhibitors as well as lenalidomide, and maybe we have to take care about the population refractory to lenalidomide, and we will have the opportunity to see during my presentation novel combinations more effective for the population refractory to lenalidomide. Just some additional concepts about these 2 combinations from the clinical practice point of view. Indolent versus aggressive relapses. These 2 combinations worked very well in indolent diseases, but also in aggressive relapses. This is the Pollux study in patients who relapsed more than 1 year after the last line of therapy. And you can see how these are the good population, and the efficacy is quite benefit is quite evident. But what happens with the patients who early relapsed? Those patients who relapsed within the first year after the last line of therapy. You can see here how the control arm, Lendex, resulted in a median PFS of only 10 months. Remember that the median PFS in the intent to treat patient population was 17 months, indicating that this is a challenging population. When we add Daratumumab, you can see how we are going to add a significant benefit with a hazard ratio of 0.38. And these data are going to be updated right now, and we will have more information about the efficacy of these combinations in early relapses. The same effect is observed for Dara-VD. The benefit may be a bit less evident, but again, look how in early relapses, bortezomib and dexamethasone alone resulted in 5 months of median PFS, and we are going to duplicate it when we add the monoclonal antibody Daratumumab. What about the age? I previously alluded to the good safety profile we've seen across the different studies for Daratumumab, and this is something very relevant for the elderly population. This is a sub-analysis conducted in both Pollux and Castor study, and you can see how the progression-free survival is sustained for patients between 65 and 75 or even older than 75 years. And this is because of the good tolerability, allow the patients to be on treatment because they basically don't have to discontinue because of side effects, and this result in a similar efficacy so far reported in the intent to treat patient population. I've been just showed how the most efficacy of this combination is going to be obtained in patients after just one prior line of therapy. From the cytogenetic point of view, and this is going to be something applicable to all DARA studies, I would say that DARA improves, but not overcome the poor prognosis of the presence of high-risk cytogenetic abnormalities. This is the Pollux study and the outcomes observed according to the cytogenetic information. From the response point of view, high-risk patients responded very well in a similar way than standard risk patients, but when we evaluate progression-free survival, you can see how when we compare DARA Lendex high risk, Lendex high risk, there is a great benefit. But when we compare DARA Lendex standard risk and DARA high risk, DARA Lendex high risk, we can see how DARA is able to improve, but not completely overcome. And the same effect is observed for the Castor study. What about comorbidities? As I previously told you, safety profile is quite good. The only limitation maybe would be patients with severe COPD or severe asthma. And in this case, we have maybe to avoid the use of monoclonal antibodies anti-CD38 because of the potential infusion-related reactions. But my recommendation would be, in case of doubts, do pulmonary test, and DARA would be not indicated if the forced expiratory volume in the first second will be lower than 50%. You know that it is possible to complement with the use of Montelukast, and I will show some slides at the end of my presentation about the sub-Q formulation for Daratumumab, and we know how the incidence of infusion-related reactions is going to be significantly lower. Dara-VD and Dara Lendex were allocated basically to relapse and non-refractory after at least one prior line of therapy. But you know how the treatment for patients with multiple myeloma is rapidly evolving, and how definitely proteasome inhibitors and IMiD, and especially lenalidomide, moved to the first line of therapy. This resulted in the use of continuous therapy with lenalidomide in the transplant-eligible population, as well as in the transplant-ineligible population. And this puts in context that the majority of our patients at the moment of the relapse are going to be refractory to lenalidomide. This means that there is not any space for the use of Daratumumab in combination with lenalidomide and dexamethasone. And concerning Dara-VD, I showed you how in the len refractory population, the median PFS was only 7.8 months. This opened the door to novel combinations based on Daratumumab in order to overcome the len refractoriness. And this is the rationale for KD plus Daratumumab evaluated in the Candor study. a phase 3 clinical study in which the control arm is now carfilzomib and dexamethasone, and the experimental arm carfilzomib, dexamethasone, and daratumumab. The primary endpoint was progression-free survival, but here you can see how in terms of response rate, there is a significant benefit with overall response rate of 84.3%. Approximately 1/3 of the patients achieved complete response, and at 1 year, 12.5% of the patients achieved minimal residual disease negative. And in addition, this minimal residual disease level was definitely deepened for KD Dara versus KD alone. And you can see here in all patients in complete response, there are patients with MRD negative at sensitivity level 10 to the -5 and even 10 to the -6. And this population basically doesn't exist in the control arm. But the primary endpoint was progression-free survival, and the addition of daratumumab to the second generation proteasome inhibitor carfilzomib resulted into a significant benefit with a median progression-free survival of 28.6 months. This efficacy is important, but from my point of view, it's more relevant to see how this effect and this benefit was maintained in the population refractory to lenalidomide, that it is basically the population we see more and more every day in front of us. And this benefit in the population refractory to lenalidomide was observed in those patients after just 1 prior line of therapy, 2 or more prior lines of therapy. This puts in context basically how KD daratumumab is basically replacing the conventional bortezomib dexamethasone plus daratumumab. Benefit also in terms of time to next therapy and progression-free survival too. And maybe we will see also a benefit in overall survival. With no more toxicity, we have to take care with carfilzomib, but it seems that the addition of daratumumab resulted into a cardioprotective effect because the incidence of cardiac events were lower in KD daratumumab versus KD alone, and again, only a slightly higher incidence of thrombocytopenia, as well as some upper respiratory tract infections. And together with the KD daratumumab, it would be possible to utilize Pomdex plus daratumumab. And this has been evaluated in the Apollo study, another phase 3 clinical study. Numerically, we can see here how Dara PD resulted in a median PFS longer than PD, 12.4 versus 6.9 months. And from the numerical point of view, this combination seems to be less effective than Dara KD. But we have to consider that in this study, majority of the patients had been treated with 2 prior lines of therapy. This means that maybe when we utilize Dara-Pomdex as part of the first relapse, the efficacy will be great. And an important consideration presented at ASH 2021 is how the efficacy of Dara-PD was maintained in patients receiving lenalidomide at a dose of 5 to 10 milligrams or lenalidomide at full dose 15 to 25 milligrams. Safety profile is also quite acceptable, and Dara, pomalidomide, and dexamethasone is another combination we can utilize in relapsed and refractory myeloma patients after at least 1 prior line of therapy, basically replacing the Pollux study with the Dara-Lendex. But definitely with this efficacy data, the next step was to move to the first line of therapy. And when we go to the European guidelines published in 2021, we can see here how daratumumab is already taking part of the first line of therapy. Dara-VTD is a standard of care as part of the induction and consolidation after autologous stem cell transplantation based on the phase 3 Cassiopeia study in which the control arm was VTD. We can see here how response rate improved over time, and at the end of consolidation, 54% of the patients achieved complete response. But I would like to show this update analysis presented at ASCO 2021, and we can see how from the complete response rate point of view, the incorporation of daratumumab as part of the induction and consolidation in combination with VTD resulted in approximately 72-76% of complete response rate, and from the MRD negativity point of view, between 57 and 64%. And these data are great because definitely this is going to result into a significant benefit in terms of progression-free survival. The hazard ratio has been 0.58, and you can see how the median progression-free survival has not been reached yet, and there is a trend towards a significant benefit in overall survival. An analysis in more depth based on the minimal residual disease was presented at ASH 2021 by Hervé Abetulasso, and regardless of the second randomization, the use of data as part of the induction and as part of the consolidation, if we focus on the proportion of patients in CR and MRD negative, the addition of data resulted into a significant benefit, and most importantly also in terms of a population able to maintain the MRD as negative. This is what I previously showed you. From the toxicity point of view, in this case, the toxicity is quite acceptable. Daratumumab is going to be added just as part of the induction as well as a consolidation, 4 and 2 cycles, and the incidence of neutropenia was just slightly higher, no more peripheral neuropathy, and even from the infections point of view, there are not a great incidence of infections in DARA VTD with no impact in the peripheral blood stem cell collection. Basically, the other standard of care we can see in these guidelines is bortezomib, lenalidomide, and dexamethasone, and the next step is to add daratumumab to this standard of care. The Griffin study has just been updated also at ASH 2021, and this is based on the Griffin study. This is a phase 2 clinical study in which 200 patients were randomized to receive DARA VRD transplant, DARA VRD, DARA LEN as maintenance versus VRD transplant, VRD LEN maintenance alone. And the primary endpoint was to evaluate the response rate at the end of consolidation. And again, we can see how response rate improved over time. And at the end of consolidation, there is a clear benefit for DARA VRD versus VRD alone. And indeed, if we continue evaluating the role of DARA as part of the maintenance therapy, and I will allude to this later on, 82% of the patients treated with the DARA-LEN as maintenance achieved a complete response. This translated into a clear trend toward a benefit in progression-free survival, and of note, at 3 years, approximately 90% of the patients treated with DARA VRD remain alive and progression-free. And this is definitely something relevant. The median follow-up is now of approximately 3 years. And again, in terms of minimal residual disease negativity rate, you can see how the MRD improved over time. And at the end of the 2 years of maintenance, 64% of the patients achieved MRD negative. Again, important to realize how the superiority of DARA VRD over VRD alone was maintained across the different subgroup of patients in terms of stringent complete response rate as well as MRD negativity rate, indicating that this combination is going to be effective in the elderly population, in patients with advanced stage of the disease, or even with high-risk cytogenetic abnormalities. And once more again, the incidence of grade 3/4 neutropenia is a bit higher together with upper respiratory tract infections, but these 2 adverse events did not lead to increased rates of discontinuations for DARA, bortezomib, lenalidomide, and dexamethasone. Definitely, in order to incorporate DARA VRD as a new standard of care in these guidelines, we have to wait to know the results of the phase 3 Perseus study. As you know, this is the phase 3 clinical study comparing DARA VRD with VRD before and after autologous stem cell transplantation. And once the results are available, we will incorporate DARA VRD as a standard of care in our guidelines. In terms of maintenance therapy, some data about the use of daratumumab. The Cassiopeia study evaluated the DARA maintenance as monotherapy, but the main problem for this second part of the Cassiopeia study is that the control arm was observation. And you know that observation is not anymore a standard of care after autologous stem cell transplantation. DARA monotherapy increased the progression-free survival, but from my point of view, and this was updated at ASHA 2021, definitely DARA maintenance is going to add a benefit in terms of MRD negative as well as MRD negative sustained over time. But when we look in the right-hand side of the slide, for me, it's important to emphasize the benefit of DARA as part of the induction, because DARA VTD DARA resulted in 64% of MRD negative, DARA VTD followed by observation 58%. No significant differences. The main benefit is observed from the incorporation of Daratumumab as part of the induction, and definitely from my point of view, it would be most interesting to evaluate the role of DARA added to the standard of care lenalidomide. And I showed you before how the addition of DARA to lenalidomide increased significantly the minimal residual disease negativity rate in comparison with len alone, that it is the appropriate comparator arm. But as I previously told you, we have to wait in order to see the results of the phase 3 Perseus study. Just a slide based on the master study updated at ASHA 2021, and this is an important study in which Daratumumab is combined with carfilzomib, lenalidomide, and dexamethasone, and we can consider that this would be the most effective combination. But this trial has another important feature, because the durability of the treatment is based on the minimal residual disease status, and DARA KRT induction followed by transplant, followed by minimal residual disease evaluation. And if the MRD is negative, patients discontinue the therapy. If the MRD is positive, patients are able to receive 4 additional consolidation cycles of DARA KRT. MRD negative, stop treatment, otherwise other 4 additional consolidation cycles and the same effect. And with this minimal residual disease adapted consolidation therapy, approximately 80% of the patients were able to achieve minimal residual disease negative. And this translated into an excellent progression-free survival and overall survival, but important consideration for patients with a standard risk or just one high-risk cytogenetic abnormality. This approach maybe is not valid for patients with ultra-high risk, 2 or more high-risk cytogenetic abnormalities, because these patients, we can see here how rapidly started to relapse, and definitely the population with high-risk features would benefit from continuous therapy in spite of the use of the most effective induction regime, followed by transplant, as it is in this case DARA KRT, followed by autologous stem cell transplantation. If we focus on the transplant ineligible population, these European guidelines, you can see how recognize also 2 combinations based on Daratumumab. One of them is DARA added to VMP based on the phase 3 Alcyon study. And VMP was the standard of care for 1 year fixed duration, and the experimental arm included DARA VMP 9 cycles, followed by DARA monotherapy until progressive disease. And in terms of progression-free survival, as well as overall survival, there is a significant benefit for the addition of Daratumumab. This is quite important because you know how many rescue therapies they are now available and how difficult it is to find right now benefiting overall survival. But in the Alcyon study, and this is something that we are going to see also in the Maya study, we see already a benefit in terms of overall survival. This benefit is derived from the fact that majority of the patients responded, 91%, 46% of complete response rate, and approximately 30% of the patients achieved MRD negative. And this translated into a significant benefit in terms of progression-free survival. Safety profile, very relevant because we are dealing now with elderly population, but the same message with the Dara VMP, a slightly higher incidence of neutropenia, as well as infections. But when we evaluated the incidence of discontinuations, very low and similar in both arms. And another important consideration, Dara monotherapy as maintenance is very well evaluated, very well tolerated, and you can see here how just a few patients developed grade 3-4 adverse events. Dara VMP is a new standard of care, but definitely the winner in the management of elderly population with newly diagnosed myeloma is the Dara-Lendex. Based on the MAIA study, Dara-Lendex as continuous therapy was compared with the Lendex as continuous therapy. And the benefit in progression-free survival is great. You can see here how the median PFS has not been reached yet. It can expect it to be longer than 5 years. And this is the longest median PFS we've seen for elderly patients with newly diagnosed myeloma. And indeed, in this study, you have to know that over 40% of the patients were older than 75. And the efficacy was maintained across the different subgroup of patients, even in the population older than 75, and even in the population with high-risk cytogenetic abnormalities, median progression-free survival of 45 months for this population. Again, the efficacy is observed in terms of overall response rate, 93%, 51% of complete response rate, 31% of MRD negative, and how some patients are able to maintain it as negative over time. And a significant benefit as expected in overall survival. And this has recently published, and you can see here how at 5 years, 66% of the patients remain alive when they receive Dara-Lendex as part of the first line of therapy. And from my point of view, this combination is extremely relevant because it could be possible elderly populations to receive just one line of therapy, Dara-Lendex, and some patients will not require from subsequent lines of therapy because of the life expectancy of the elderly population. The benefit in overall survival also maintained across the different subgroup of patients. And another important consideration is the evaluation of these combinations according to the frailty score, because we know that elderly patients include a very heterogeneous group of patients. But the addition of Daratumumab seems to partially overcome the poor prognosis of the frailty score, because here you can see how in terms of progression-free survival, DVMP is comparable in fit, intermediate, and frail. In the MAIA study, the situation is not so similar, it's a bit different, but look how Dara-Lendex in the frail population resulted much more benefit in comparison with Lendex alone in the frail population. So basically, this is related with the safety profile, and the incorporation of the anti-CD38 monoclonal antibody would be feasible to whatever newly diagnosed myeloma patient transplant ineligible. Is there any way in order to try to prevent infections? This risk score was developed and presented at ASH 1 year ago. And we know how the elderly population older than 75 with elevated LDH, low albumin levels with abnormal ALT, the liver enzyme at baseline, can result into the identification of patients at higher risk of infection development. And this was evaluated in a training and validation data series of patients. And from my point of view, the practical message is if you are able to identify these patients with high risk of infection development, please prescribe some antibiotic as prophylaxis during the first months in order to avoid upper respiratory tract infections in this population. How are we going to incorporate finally, and this is my personal view? Well, according to all this information, I personally consider that Daratumumab is going to take part of the first line of therapy in a majority of the newly diagnosed myeloma patients. maybe in combination with PI and IMiD, maybe in combination only with immunomodulatory drugs. And this great efficacy so far reported will result in the fact that some patients will receive just one line of therapy. At the moment of the relapse, if I envision the future landscape, definitely you know how the BCMA targeted therapy is rapidly moving to the first relapses. But it would be a great opportunity to recapture again the anti-CD38 monoclonal antibodies like Daratumumab in combination with other new molecules like venetoclax, selinexor, or the new Thelmods. But we are entering into the BCMA targeted therapy, and let me share with you a couple of clinical studies with a small sample size, but bispecific monoclonal antibodies targeting BCMA or GPRC5D, talquetamab or teclistamab in combination with the Daratumumab. And just to note how the addition of Daratumumab resulted into a better efficacy in terms of overall response rate as well as complete response rate, and to note that these studies were conducted in heavily pretreated myeloma patients after a median of 5 or 6 prior lines of therapy. But this is going to be the future. Before finishing my presentation, just let me share with you some slides about also something that will be the future in the management of myeloma patients in India with the Daratumumab. You need to move rapidly to the sub-Q formulation, basically because Daratumumab has shown to be very effective across the different stages of the disease, even with some trials in smoldering myeloma patients. And maybe the unmet need is to reduce the patient burden without compromising the data safety and efficacy, because with the IV formulation, patients required to stay at the hospital 7 hours for the first infusion, 4 and 3.5 hours since the second and the subsequent infusions. So this is really the unmet need. And in order to resolve this unmet need, the sub-Q formulation was developed. You know that Daratumumab was combined with recombinant human hyaluronidase throughout a technology able to deliver large volumes, in this case 15 milliliters of volume, flat dose 1800 milligrams in abdomen subcutaneous injection site during 3-5 minutes. And the role of Dara sub-Q was confirmed in this phase 3 clinical study in which Dara IV was compared with Dara sub-Q. And you have to go back to the heavily pretreated myeloma patients refractory to both proteasome inhibitors and IMiD in order to put in context how the overall response rate as well as the maximum concentration throughout at the beginning of the cycle 3 were comparable for Dara IV and Dara sub-Q. And the same was applicable to progression-free survival as well as overall survival. And definitely this was the rationale for the approval of Dara sub-Q as part of Dara sub-Q instead of Dara IV. And you know that majority of the trials I showed you during my presentation, especially in the upfront setting or in early relapses, incorporated the use of Dara sub-Q. Dara sub-Q can be safely combined with whatever standard of care. And this is what we are doing right now in our clinical practice. And I hope this is something that you will do in India very soon. And I stop here. Thank you very much for your attention. And now pleased to answer or to discuss all questions you have.
Thank you so much, Dr. Maria. That was fantastic. You really started from the beginning of Dara and you brought us up to totally updated version of the whole thing. Grateful to you for doing this for us. And now we will invite some questions from the faculty that is present here. I see one question in the question box already. Dr. Roshni wants to know, will first-line Dara combo obviate the need for autologous transplant in some patients?
Well, this is a good question. And I would say that maybe the only problem is we don't have evidence-based data so far. I can imagine that this would be potentially restricted to patients with no high-risk features, because patients with high risk benefit for sure from autologous stem cell transplantation, but maybe patients with no high-risk features and achieving minimal residual disease negative could potentially avoid autologous stem cell transplantation. But is this something that we can do right now in our clinical practice? My answer is no yet. And the French study has just started a clinical study in order to answer to this question. So in the meantime, I would recommend you to continue doing autologous stem cell transplantation. But in the future, maybe.
Thank you. Dr. Krishna Ratnam wants to know, DARA has been approved for the first-line treatment in transplant-eligible patient?
DARA is approved, yeah, is correct. The Cassiopeia study resulted in Europe into the approval of DARA in combination with VTD only as part of the induction as well as part of the consolidation. What is the problem here in Europe? That in majority of our countries, the standard of care is RVD instead of VTD. And this results in, well, a problem, because basically we don't want to go back to the use of thalidomide because of the peripheral neuropathy and so on. And in many centers, what we are doing is directly to go to DARA VRD as part of the induction and consolidation. But the answer to your question, yes, EMA approved this combination approximately 1 year ago.
Pankaj?
Thank you, Dr. Maria. My question is regarding the fixed dose sub-Q DARA. So, Indian patients may be not as, in terms of body mass index or body surface area as compared to European or American. So, how do you arrive at a dose of 1800 mg as subcutaneous DARA as a fixed dose? So,
Yeah, of course, this is an important question. And as DARA sub-Q is not approved yet in India, this was the reason why I restricted the number of slides focused on DARA sub-Q. But the first clinical study, the PAVO trial, confirmed 1800 milligrams as the appropriate dose, as fixed dose. And the Columba study, the phase 3 clinical study, utilized body weight as a stratification factor. This means that the patients with a body weight lower than 65, between 65 and 85, and higher than 85 kilograms were equally represented in DARA IV and DARA sub-Q. When a analysis was conducted, it was observed how the efficacy was equally observed the efficacy was comparable for DARA sub-Q regardless of the body weight. The only exception was from the pharmacokinetic point of view. It's true that the concentration was slightly higher for the DARA sub-Q in those patients with a body weight lower than 65 kilograms. But this effect did not result into any safety problem and no in more efficacy. This was the rationale in order to conclude that no dose modification should be done based on the body weight, and in principle, the flat dose of 1800 milligrams should be used. I have to say that I think that the patient with the lowest body weight included in the Columba study was 49 kilograms, and the highest one, 100 plus something.
Thank you.
Dr. Maria, can you tell us something about the high-risk myeloma, especially deletion 17p? In clinics, what should be the protocol today?
Yeah, definitely. I think that these patients should be treated in a different way. And fortunately, we've seen at ASA how specific clinical trials are being conducted in this population. From my point of view, I think that two key concepts more than specific combinations. We have to try these patients with deletion 17p or high-risk cytogenetic abnormalities to receive the most effective combinations, because we have to try these patients to achieve MRD negative. Today, with the information we have, it is quite well established that the achievement of MRD negative and maybe sustained over time is the only thing able to overcome the poor prognosis of the presence of deletion 17p. This means that in my clinic, the standard of care can be RVD or RVD plus Daratumumab, followed by autologous stem cell transplantation. But if my patient after transplant is not in MRD negative, I have to do something else in order to put the patient in MRD negative before proceeding to maintenance therapy. And this has been the rationale, for example, for the Optimum trial conducted by the Myeloma UK, in which they combine VRD with the cyclophosphamide and Daratumumab as part of the induction, followed by transplant and consolidation with Dara VRD and Dara-Len, two consolidations before going to maintenance with lenalidomide. And this would be my main message, to try to utilize the best combination available in your centers, but measuring, if possible, the minimal residual disease and trying to put these patients in MRD negative, because so far we have plenty of novel combinations, but honestly, there is not any new combination able to overcome the poor prognosis of the presence of high-risk cytogenetic abnormalities. Even tandem transplant is another possibility for patients with a high risk. If we evaluate the response after the first transplant and we see that the first transplant has been effective, go to the second one in order to complement or to consolidate the efficacy.
Thank you. Does carfilzomib-based protocol upfront, like masters, make a difference in such group in place of?
Well, yeah, so I don't know, because honestly, master study is a phase 2 clinical study with no more than 126 patients. And we have some other evidence coming from the Clarion study many years ago, or the Endurance study recently published and presented by your colleague Saji Kumar, showing how bortezomib was quite comparable to carfilzomib. So it is difficult for me. Definitely, I think that carfilzomib is a potent proteasome inhibitor. And from my point of view, maybe the efficacy is dose dependent. And if we are able to increase the dose of carfilzomib, and the patients are going to receive a higher cumulative dose of carfilzomib, maybe it is going to be more potent than bortezomib, lenalidomide, and dexamethasone plus daratumumab. But this should be evaluated in phase 3 clinical studies. And unfortunately, at least in my mind, I think that there is not any phase 3 clinical study planned ongoing in order to compare once more again Dara KRD with Dara VRD, for example, in all comers, not only on standard risk or in high risk. So I would put a question mark. And well, I can't say that the carfilzomib is going to be more effective than bortezomib because we don't have the data.
Any comments on the Forte trial for the high-risk myeloma carfilzomib?
Again, this is an important study, but you know that carfilzomib is taking part of the 3 arms: KRD transplant, KRD, KRD 12 cycles, or KCD. It seems to have a significant benefit in patients with high risk, but if we incorporate autologous stem cell transplantation, this is the only subgroup of patients in which you can see a benefit, because KRD 12 cycles or KCD transplant KCD in high-risk patients resulted in a median PFS of approximately 36-40 months, comparable to the median PFS reported in the high risk with bortezomib, lenalidomide, and dexamethasone. So this is the question why it seems that it can add a benefit, but we don't have, in my opinion, solid data to confirm this.
Standard risk myeloma, using 4 drugs upfront, using Dara, you think that some small fraction of patients will be cured?
Well, maybe. The problem is, well, and I've been with you in another session of 1 year ago talking about the cure of myeloma. And a challenging situation is how to define a cure. Cure definitely means disease-free, but also treatment-free. So maybe we have to try to design right now new clinical trials based on this objective, the cure. And this means that we can't plan continuous therapy until progressive disease. Otherwise, we can't talk about cure, but maybe the incorporation of the quadruplet combination as part of the induction in the young population and incorporating the minimal residual disease negative sustained over time as endpoint could help us to identify some patients potentially cured. But we can't be 100% sure because I've seen in my clinic last week a patient relapsing 15 years after the first line of therapy. And he was definitely in complete response. And he was treated with conventional chemotherapy, transplant, and maintenance with interferon. And now he's in relapse. Honestly, I thought that this patient was going to be cured. And I don't know if now the disease is different or not, and it is another different disease. But this is what we see sometimes in myeloma. So we have to take care.
Any comments about Daratumumab maintenance? How do you see the future?
Well, I see a future for Dara maintenance, but in combination with lenalidomide, more than single agent, based on the Griffin and the Perseus study. And the Perseus study, as well as the Griffin, were designed to give Dara for fixed duration of therapy, 2 years of maintenance. And I think that this has to be the future. Otherwise, we can't make our young patients receiving continuous therapy with 2 drugs, lenalidomide and daratumumab, forever, because I think that this is not practical at all from the economical point of view, from the quality of life point of view, and so on. But I see a role for Dara in combination with Len.
Any comments about treatment of extramedullary myeloma?
Well, a challenging population again, and Dara can add some benefit, because of course we are going to use more effective combinations, but I have to say that Dara is not the excellent drug in order to resolve the extramedullary disease. And sometimes in extramedullary disease, we have to go back to the conventional chemotherapy. We have just had the opportunity to see at ASH update of Filtacel, BCMA CAR-T, as well as ide-cel in patients with different prognostic factors. And the main message is that patients with extramedullary disease was the poorest population treated even with BCMA CAR-T. So definitely challenging situation. And we have to try to utilize the best combinations, but don't forget radiotherapy as well as conventional chemotherapy for these patients.
Thank you. Any question from the faculty here? Yes, Dr. Kungar? No, nothing. Okay. Right, then I think we have finished all the questions. Thank you so much, Dr. Maria, for sparing your time and being with us. It was wonderful interacting with you. So thank you so much.
Thank you very much.
Okay, bye-bye.
Bye.
And thanks to all the colleagues for being with us for last 7 days. It was a wonderful academic session. We enjoyed it. And I hope all of you, especially the student community, has benefited. Thank you. Bye-bye. And we close this webinar.